up for you this morning. So before I start off the program, let me just let you know that we have, so we have a patientsafety.co.in. Please visit that website and take an oath of patient safety by filling in the endorsement form. 5 lucky endorsements will receive exciting prizes today as well. And then we have 2 best patient safety improvement ideas and slogan. So that should be, that shall be rewarded with Kindles again. So there you go. Submit your slogans along with your name, mobile number at the slogan counter at the May I Help You desk in the front. I think there's also a lot more exciting games that will be announced through the day and a lot more gifts that all of you can win, which I think will all be announced at the end of the session today. Right, so to start the day, the first session, it's my pleasure to introduce Dr. Anupam Sibal again for this lovely plenary session on the levels of patient safety. Now, levels of patient safety can vary based on the quality of care that we provide, the system, the processes in place to prevent harm, and the stability and the ability of healthcare providers to identify and respond to adverse events. So we will hear from Dr. Anupam Sibal, Group Medical Director. He's a senior pediatrician. He's established the Division of Pediatric Gastroenterology and Hepatology in 1997 at Indraprastha, and like I told yesterday, an amazing human being. He's being joined by Dr. Narottam Puri. Dr. Puri is the Principal Advisor at QCI, Advisor for Medical Ops at Fortis Healthcare, Advisor Health Services and Medical Value Travel, FICCI. He is an ENT surgeon by training and has spent nearly 5 decades in healthcare as a teacher, clinical practitioner, and healthcare administrator. It is also my pleasure to welcome our speakers, Dr. Neelam Dhingra, Unit Head, WHO Patient Safety Flagship Initiative, Geneva, Switzerland, Dato Dr. Jacob Thomas, Chairman of the Board of Directors, Ramsay Semi Darby Healthcare, Malaysia. May I request Dr. Sibal and Dr. Puri to introduce the panelists and take the session forward. Thank you, gentlemen.
Good morning, friends. Thank you very much for finding time for us. You know, we might work in different hospital systems, different sizes of hospitals, different countries, but we are all united by our deep commitment to enhance patient safety. So a warm welcome to this exciting session where we're going to learn about what's happening at the global level, a peek into regional initiatives, and then, of course, country-specific. And may I request Dr. Narottam Puri for his opening remarks, please.
Good morning, ladies and gentlemen, and thank you, Anupam. It's indeed a great pleasure to be once again in this conference. I think when Lucien Leap became the champion as far as US was concerned, we were worried who's going to champion patient safety here. And having been associated with NABH since its inception, this was a principal thought. And I think Apollo has done a wonderful job in stepping into those shoes and creating a conference which is now internationally recognized. So it's an honor and a privilege for me to join the entire fraternity of medical, nursing, and paramedical colleagues and administrators who have only one principal motive for following quality in our lives, and that is to make sure that our patients remain safe. And I think it's a wonderful opportunity to share the dais with you, because I believe you are one of the finest speakers we have today in India.
Thank you so much. And it's a privilege to invite my dear friend, Dr. Neelam Dhingra Kumar, who's been at the World Health Organization, Geneva, now for 23 years. And all the action that we see in terms of the patient safety plan for the decade, the journey, the movement, she's really led this. And you should just hear Dr. Tedros speak about Neelam's work, and you know, as an Indian, one gets this great sense of pride. Thank you, Neelam, for taking the trouble flying from Geneva, and over to you on the journey thus far and the way ahead. Thank you.
Thank you, Anupam. Thank you, Professor Puri. It's such a pleasure and honor and delight for me to be here today amongst you, and it's home for me, of course. So without taking too much time, I would first of all like to thank the organizers, particularly Anupam, for inviting me and giving me this opportunity. And I would like to take you through the journey of patient safety at global level in the last couple of years and some very important landmarks and milestones which we have achieved and what is the way forward, because without involvement of each and every one of you, we cannot reach where we want to reach in zero harm in healthcare. So if I could have my slides, please. And if you have the, this one?
Yeah, so the green arrow on the top.
Okay, thank you so much. So I'm going to present on the decade of patient safety. There have been, as I mentioned, there have been important landmarks and milestones in the patient safety journey globally in the last couple of years. And in 2021, we started a decade of patient safety, which is WHO's response to the global call for action to several governing body resolutions and decisions which have been taken by the World Health Assembly of WHO. And so the decade of patient safety is a response from WHO to meet those calls of urgent, working with countries for urgent action on patient safety. So you would all agree with me that when we go to, or when one of our family members go to a healthcare service or a facility, we never expect that we are going to be harmed. We go there because we want to get treatment, we want to get the cure for our problem, we want to heal whatever we are suffering from. So we have that hope when we go to a healthcare facility that we are going to be better and we will come back with a good health. So no one actually should be harmed in healthcare. We presume that healthcare is safer. However, there's a huge, huge body of harm which happens in healthcare. So I just want to share a couple of figures globally which have been estimated for the body of harm and the huge burden of harm. Although data from particularly low and middle income countries is very limited, and most of these are estimates, but even then it is an underestimate, still shows the huge burden of patient harm, health burden, as well as economic burden. So even in high income countries, 1 in 10 patients are harmed in hospitals when receiving care. And the estimates suggest that in the low and middle income countries, approximately 134 million adverse events take place every year in hospitals only in LMICs, and which contribute to about 2.6 million deaths annually. And most of these are avoidable deaths, unnecessary deaths. And that actually amounts to that every 1 minute, 5 patients are dying in hospitals in the low and middle income countries alone. It's a huge, huge burden of patient harm. And when we are speaking of universal health coverage and going to primary care and ambulatory care, even in those services, huge body of harm, and this is a global estimate that 4 out of 10 patients are harmed in primary and ambulatory care settings. So what are the barriers? Normally when we are accessing the health services, the barriers are either related to physical barriers, too far, or there's a financial barrier, people, they can't afford it, or informational barrier, we don't really know much about what are we being offered, or there's a discrimination sometimes. But there's another very important barrier, which is unsafe care. If people get aware that this particular health facility has had some adverse events, there's a major loss in trust in the healthcare system. So unsafe care is a major barrier to access to health services. So recognizing this huge burden of harm happening in healthcare across the world, which is avoidable most of the times, political leaders from countries came together. And particularly, I would like to mention an unprecedented global patient safety movement, which started from 2016 with a series of annual global ministerial summits taking place. And the political leaders from the UK and Germany, they got together and pioneered a series of annual global ministerial summits. So in London, there was a summit in 2016, hosted by the UK government under the leadership of then Health Minister, Mr. Jeremy Hunt, and also Hermann Grohe, the Health Minister of Germany that time, in 2017, hosted the second Global Ministerial Summit. And this was followed by a summit in 2018, hosted by the Japanese government, and then in 2019, a summit hosted by the Saudi Arabia government in Jeddah. WHO has been a strategic partner with countries who are leading this initiative from the very beginning, and we're very proud that our top leadership, Dr. Tedros and Dr. Margaret Chan, in 2016-17 in particular, were very closely involved in this initiative. So this huge global momentum, which was created through the annual global ministerial summits, engagement and involvement of political leaders from several countries around the world, led to a landmark resolution in 2019 at the World Health Assembly, which is the Global Action on Patient Safety. And this resolution was extremely important because it not only was a resolution for different actions on patient safety, but also recognized patient safety as a global health priority and established World Patient Safety Day as a WHO mandated day to be observed annually on 17 September. So they're only 11 days recognized by the World Health Assembly, and very proud to share that World Patient Safety Day is one of them. And then the resolution also asked WHO to work with member states and partners to formulate a global patient safety action plan, which is a roadmap for 10 years for strategic action by different partners for patient safety. So this was the consultation just before the COVID pandemic was dawning on us as a scourge. We actually met face to face, and you can see world experts meeting in Geneva, 24-26 February 2020. And that is where we laid a foundation for the Global Patient Safety Action Plan, and Dr. Tedros announced a decade of patient safety of WHO's committed action for next 10 years. This was followed by, as I mentioned, the Decade of Patient Safety, which is a flagship program, and several of these elements which are listed in this honeycomb picture, these are some of the key initiatives, but there are several others. So World Patient Safety Day, of course, facilitating and developing a global campaign and calling for action every year on a dedicated theme for World Patient Safety Day, working with countries after firstly developing the Global Patient Safety Action Plan, and then also working with countries to implement the Global Patient Safety Action Plan. Giving countries a global patient safety challenge, a change management program to bring areas of proven harm to the limelight of need for visibility, and also taking very clear action and implementing proven strategies to address that harm. So medication without harm has been the third challenge which WHO has given to the countries. So Global Patient Safety Challenge is one of the other initiatives. Then creating a Global Patient Safety Collaborative, working with the UK government to create a collaborative where several countries come together and work with academic partners and WHO to implement the change in improvement in patient safety through the collaborative, and also a Global Patient Safety Network, a real-time network online to share experiences and resources. In addition, of course, one of the main functions of WHO is to develop norms and standards. So several guidelines and tools and standards have been developed for patient safety as part of this flagship. And finally, patient and family engagement as a very strong pillar for action for improving patient safety. So patients and families and caregivers being a very important partner in co-development of health. So just sharing with you the process of development of the Global Patient Safety Action Plan. We started immediately from 2020 consultation, as you saw, and starting from February 2020, in May 21, we had the action plan adopted through several steps of consultation, internal, external, drafting, reviewing, member states briefings, public consultation. So several steps during this time of 2 years. And finally, it was presented to the 74th World Health Assembly in 2021, and which was adopted, and it was launched in August by Dr. Tedros himself. And the Global Patient Safety Action Plan, as I mentioned, is a roadmap for 10 years action on patient safety, and it's called as Towards Eliminating Avoidable Harm in Healthcare. So with the objective of zero harm in healthcare. So I'll just very briefly share with you what this Global Patient Safety Action Plan contains, and you have, of course, it's available on the website. So it creates a vision in which a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere, with a mission to drive forward policies, strategies, and actions based on science and patient experience, system design, and partnerships to eliminate sources of avoidable risk and harm to patients and health workers, and a goal to achieve maximum possible reduction in avoidable harm due to unsafe healthcare globally. It has 7 strategic objectives, so creates a framework for action. And these are, as you can read, policies for zero patient harm, high reliability systems, safety of clinical processes, patient family engagement, health worker education, skills and safety, information research, risk management and improvement, and finally synergies, partnerships and solidarity. And as you can recognize that this particular framework for action really addresses patient safety from a comprehensive systems approach, so that we strengthen the healthcare system, and wherever there are gaps in safety, we address through these actions. And there's a 7x5 matrix which the action plan gives, which is there are 5 strategies under each of these strategic objectives. And if you go into the depth, under each of these strategies, there are 35 strategies. Under each of these, there are 4 partners who are listed. They have to take action to make things happen. And these are the partners: governments and government institutions, all stakeholders, patients and healthcare workers and professional organizations, and all stakeholders, academic and research institutions, healthcare facilities and services, and WHO Secretariat through its 3 levels of the organization: global, regional, and country level. In addition, monitoring and reporting is an extremely important part of this action plan. And so there are 10 core indicators which the action plan defines. And this is the first time, actually, we've launched a survey to collect information from countries because we have a reporting requirement as well to the World Health Assembly. So in May 23, just in 3 months' time, we are going to report to the World Health Assembly on the progress in implementation of the action plan in the last 2 years. And we are also working on a global patient safety report, which is the first ever as well. So these are the important developments which relate to actually measuring the progress in implementation, and over a period of 10 years show impact and better health outcomes. Just a few words about the World Patient Safety Day, which I'm sure all of you are related and committed in one way or the other. As you can recognize that after the resolution of 2019 was adopted in May, September was the first time we observed. So our very first World Patient Safety Day was observed in 2019, where we also worked with partners to create a legacy and a vision, visionary design and a visual design. You can see patient safety also got a logo, which is very rare to get in WHO, a global logo for an area of work, as well as a World Patient Safety Day. And Speaker for Patient Safety was a theme for the very first World Patient Safety Day, where we also gave a call each and every year since then, the 4 years we have observed, to actually lit up iconic buildings and monuments in color orange to align the initiative with universal health coverage. So in 2022, last year in September, we observed the 4th World Patient Safety Day, which was dedicated to the theme of medication without harm, which builds on to WHO Global Patient Safety Challenge on medication without harm, particularly to address unsafe medication practices and medication errors. And I'm sure you're aware with the recent estimates that more than 50% of avoidable harm which happens in healthcare is because of unsafe medication practices and medication errors. A huge body of harm which happens because of unsafe medication practices, medication errors. So the day was dedicated to medication safety. And the most important part of the campaign was improving interaction between health workers and patients through a campaign, No Check, Ask. So before you give it and before you take it, no check, ask. And then we have the 5 moments for medication safety as well, which is a tool for improving patient engagement. So the world really turned orange on 17 September, and there's a famous jet d'eau in Geneva. And just to conclude that this year, the theme for World Patient Safety Day is engaging patients for patient safety. We also worked on consensus statement this year, and last year actually, on the role of policymakers and healthcare leaders, as well as launched other products, Health Worker Safety Charter and implications of COVID on patient safety. Just in 10 days' time, we have the 5th Global Ministerial Summit, which was put on temporary hold, hosted by the Swiss government in Montreux. And these are some 10 actions which we are asking every country to take forward to implement the Global Patient Safety Action Plan. I won't go into detail. They're very much aligned to the 10 core indicators, reporting learning systems, action plan, as well as networks, curriculum, reporting back, policies of having patient representatives, prioritizing and resources, and strategizing. Some of the impact at national level through several national policies which have been developed: Sri Lanka, Nepal, Finland, Kenya, Malaysia, Ireland, UK, India, so to name a few. So with that, I would say time for action has come. So let's walk the talk, and let's work towards a world in which no one is harmed in healthcare and everyone receives safe and respectful care every time, everywhere. Thank you so, so much for your attention.
Thank you. Thank you so much, Neelam. Really appreciate. Thank you. It's now a privilege to invite someone I look up to, someone who's been a mentor to many of those who are present here, Dato Jacob Thomas, surgeon by training, and has really led the movement in terms of healthcare improvements in Malaysia. He's currently the head of the private healthcare productivity nexus under the Malaysian Productivity Corporation of the Government of Malaysia. He was chair of the Joint Commission Board for 3 years, and before that he established the Association of Private Hospitals of Malaysia. Over to you, Dato.
Thank you. Very good morning and namaste to all here present. And I want to thank the organizers for giving me this opportunity to be part of this fantastic conference. I always say that the Apollo Patient Safety Conference is the largest patient safety conference in the world. And this has been echoed repeatedly. And I deem it an honor for me to be always part of this conference. Actually, when I saw the list of people speaking at this particular session, and with the stalwarts of WHO on both sides of me, I said, what am I doing here? But after listening to Neelam, I think all I have to do is to just say what we have done in our region. And I must also say both the government, the Ministry of Health, and the private hospitals and Ministry of Health hospitals in Malaysia and the region, we have just looked at WHO for direction. And I also had the opportunity to look at JCI for some direction which they were able to give us as well in the initial stages. And I must say that today, the Director General of Health of Malaysia is a Vice President of WHO looking into emergency issues, and we are very proud that we can play a role. So I'm not here to say anything new because we just followed WHO and the leadership that they had and provided for us, and we were able to go through the pandemic. When I talk about the region, I'm going to talk not just about the country I come from, but also the countries where we have hospitals. Two of my Indonesian colleagues are here, and they went through quite a lot, and we in Malaysia were able to learn from them. And this was the message I wanted to say, that how do we go ahead in a time like the pandemic. So the regional patient safety within the era of the pandemic is what we are going to talk about. Now, we look at WHO global initiatives working towards eliminating any harm. JCI and its teaching helped us a lot. Associations we are involved in, the Association of Private Hospitals, AHPI here, the Philippine Hospital Association, I can go on with the list. Healthcare conferences, local, regional, and global, helped us a lot to learn how do we cope, what do we do. National accreditation bodies like NABH, CAS, MSQH, National Patient Safety Council, Patients for Patient Safety movements, which is very active in many parts of the world, and individual hospital groups like the leadership Apollo has shown, Max, Fortis, IHH, KPJ, and Ramses MW. I think this list can go on. And there's one more movement which one of my colleagues spoke about yesterday, is a program developed, in fact, by and made popular by Mark O'Brien himself from an institute in Australia called Cognitive Institute. And this Speak Up for Patient Safety program has been put all over 500 hospitals which belong to our group, and we took it on specifically to make sure it works, and it's something which is really a great tool. And World Patient Safety Day, we celebrated. I think Neelam talked again and again about it. Now, healthcare challenges over the ages. We know we have gone through a lot. We had the plague in 1346, polio in 1916 and 1952. We had AIDS in the 1970s. We had SARS in 2003, Ebola in 2014. In fact, when Ebola came, we were told that 1/4 of the world's population will be wiped out. But it didn't happen. Same we heard when COVID-19 came. So we have the coronavirus now. How do we go? We are short of beds. 2 patients share 1 bed. And this is quite common. So this goes on and on. And so I think we look at global disasters, we look at Middle East crisis, we look at... So today what happens? Look at what's happening in Turkey, and look at what's happening in the Ukraine. We have to deal with that. So every situation, the message I want to leave with all of you is that we need to reset. Reset, there are more travel restrictions, immigration laws are different just to protect and make sure patients are safe. We need different immunization requirements. Nationalities not allowed in some countries because of high volume of patients there. Medical tourism is reversed now. Countries which used to go to other countries now, they are staying back. And Asia has developed as the new destination for many. Now, we have to keep our workers safe and patients safe. So, why reset? Current healthcare systems were not designed to deal with the scale of the current crisis. An unpredictable, large-scale challenge happens, and the pandemic is opposed to the direction that healthcare systems are going. So, going forward, the burden of chronic healthcare problems, especially among the elderly, will far exceed infectious disease. I'll skip some of that in interest of time. The drive efficiency, shifting care from hospital to outpatient or home care settings, and this is something which is happening very, very actively in many countries around the world. So we want to look at the limiting investment in overall prevention, and we find that the way finances are allotted for different areas of healthcare is also going to change, and resource allocation becomes a priority. So I would just want to thank you there. I was given just 7 minutes, so I'll stop there and maybe join you all for a time of Q&A. Thank you so much.
Thank you so much, Datu. And now we move to what we've been doing in India. And it's a privilege to invite Dr. Parminder Gautam. He's the National Professional Officer for the Patient Safety Quality Initiative at the World Health Organization India Country Office. More than 2.5 years of experience working in different governmental agencies across different portfolios. Over to you, Parminder.
Thank you, Dr. Sibal. Good morning, all. At the outset, I am extremely thankful for the organizer to having me here. So directly coming to the point is that you've seen the global action plan. This is what our headquarters does at WHO. They set the broad contours and the directions and the policies and the strategies that may be adopted by independent member states, we call the countries, which can be adopted. The same get translated into regional strategies. We have got different regions. So India belongs to 0 regions. So we developed a regional strategy for patient safety, and then we customize the broad strategy. The tools are developed by WHO headquarters. They get translated, they get customized as per priorities of the member states of our country. We have customized them, and we develop our own, with the support, we develop our own patient safety implementation framework. I will just take you over there. So if we talk about India, so it is an articulated commitment of government India that will provide quality and safe care. But the biggest challenge here, I would like to just emphasize that we all talk about culture of safety, culture of quality, culture of this. But culture is nothing but a collective behavior of an organization. And behavior, it depends upon what are our values and attitudes. And our values and attitudes are nothing but our beliefs and perceptions. Unfortunately, if we see in India, be it the community, be it the healthcare providers, be it the decision makers, the bureaucrats and the policy makers, what is the perception about patient safety? So what is the perception, how it is taken care? We all talk about these many people die. Everybody thinks that yes, patient safety is in you. What you will do you make error? No, I don't make error. So the common perception is that the errors are made by the professionals, those who have ill intention, who are unqualified, intoxicated, incompetent healthcare worker, they make errors. And similarly, in India, if you see, the doctors are considered to be next to God. How can God make error? We cannot make error. And as a provider also, we all believe that we cannot make error. It is somebody else. Here, before I go further, I will just ask, how many of you have got screen guard on your phone? Please raise hand. All of you. How many have oxygen cylinder at your home? Why? Perceptions and beliefs. Why we have screen guard? Because we believe that my phone may fall, it may get damaged, I need to protect. For that, I didn't attend any conference, mobile safety conference. I didn't have to attend because I know. And what about oxygen cylinder? Fire will not happen in my house. It can happen in the neighboring society. It can help in somebody else's place. So we do not. Similarly, so this is a concept in psychology. We called it in disaster, the delusion of personal invulnerability. So with it, we are harmless. Similarly, the healthcare providers have a delusion of perfection. I cannot make error. I am qualified. I am experienced. I have a lot of experience. My intentions are good. I want to serve my country. How can I make errors? So similarly, so how do we go for these errors? We keep on training and retraining and take actions against them. So recently I will relate an incident where a nurse inadvertently administered co-vaccine to a baby in place of polio vaccine. So what happened? And on top of it, we have a media which made it a heinous crime and doctors the terrorist, and both the A&M and the doctor were sacked. Dr. Narantapuri named Dr. Lucian Leap. In his words, if we keep on punishing the pupils, those who are making mistakes, then patient safety would remain only a dream. So this is there. So we all know that errors are not made by any singles. There are pitfalls in the processes, there are lacunas in our systems. So, and to err is human. Everybody can make mistake. We all forget an item on our grocery list. We often forget our keys, where we have placed our keys, where we placed our glasses. Because our making errors is a pitfall of having a brain, because our brain get information in a jigsaw puzzle, like in some brackets, in some sockets. All that fail. Pedal edema, liver palpable, dyspnea, JVP raised, CHF, derifylin, LASIK. So that's there. So that is the one thing I want to do. As for what are the initiatives, there are various, in India, the patient safety are scattered throughout. We have Consumer Protection Act, we have Center Pollution Control for Biomedical Waste, radiation safety, we have got ARB, National Pharmaceutical to control the prices of the drugs, then the license and registration, quality accreditation. Patient safety is an integral part of all the quality certification available in India, and we do have this surveillance mechanism, adverse event following immunization, pharmacovigilance program where adverse drug events have to be happen, and the hemovigilance where we are supposed to report all the reaction. Unfortunately, again, the problem is the reporting is almost negligible. So until only we will report, how will we learn? The learning system will not. So Based on the global action plan, there were 7 strategies. For India, we have developed 6 strategies. Patient for patient safety comes into the institutional framework only. And infection control is a very priority, so we have included it as a separate strategy. And based on that, that is readily available on our website. You can go through it. In terms of institutional framework, we do have a national steering committee. We are in the process of getting nodal officer for established at the state level. We are about to run a mass media campaign. We will take support from Apollo, your resources also, in running a mass media campaign on patient safety. So this is another thing that I would like to highlight, patient for patient safety, because patient is the only constant throughout the continuum of the care. So what we are envisaging, we have an established framework for community participation in our health systems. At village level, we have got village health sanitation committee, we have got Jan Arogya Samitis, Rogi Kalyan Samitis, which are represented by the community itself. So what we are envisaging, what we are promoting to Ministry of Health is that let us take advantage of these, and the organization like KAHO is working, Saksham is working, so that we can take this patient for patient safety movement forward. As far as reporting and learning system, we already have 3 systems for drugs, for blood and vaccines. So we are coming up with a new web portal, training and capacity building, including patient safety in the curriculum of nursing and other medical courses. Infection prevention, that is lot of resources already been developed, capacity building is going on. So this in safety, use of safe surgical checklist, safe childbirth checklist, safe injection. These are also integral part of our national patient safety implementation work. Last but not the least, we are happy that India is part of the Global Patient Safety Collaborative, and we are requesting Neelam Madam and with them and with other partners like ICMR and even the corporate hospitals also, we will go for research in the prioritized area. Thank you. And this is a roadmap. We need to, patient safety teams are there. Then we blame-free culture. That is, I think, that the main thing that is required. Reporting and learning system. These are all the repetition that has been done. And it is not longitudinal in nature. Many of the things can be taken at a time also. Thank you.
Thank you. Thank you so much, Parminder. And I'll request Dr. Narottam to summarize, please.
Thank you. Thank you very much, Anupam. Once again, good morning, ladies and gentlemen. It's been a revelation listening to Dr. Neelam Dhingra, Dr. Thomas, and of course, our very own Dr. Parminder. We finally learned that physicians need to heal themselves. What they used to say in Latin, cura te ipsum medis. Physician, heal thyself. But are we really doing enough from the perspective of understanding that patient safety is the fundamental principle of healthcare quality? I think we all know that it requires 2 hands to make the sound of a clap. And it's very heartening to note that there has been a development in the field of the responsibility of the patient in contributing to his or her health. Medication error, which WHO celebrated last year as the patient safety theme, fundamentally addressed this issue. And I think it's important to realize that part of the problems that emanate out of medication errors occur with the concurrence or inadvertent or incomplete knowledge of the other party, that is the patient. And therefore, it's very important that due importance has been given to the patients themselves. And I'm told by Dr. Anupam Sibal that many from the patients' community are also represented, and I congratulate the organizers for inviting them. Because unless and until the community that is going to be safe is represented, their problems heard, and they are educated about the pitfalls that occur in a system that is inherently risky by nature, that is healthcare provision, we are not going to achieve the goals. So from the perspective of what WHO has done in promoting and continuing to harp on the theme of patient safety as not only a mortality reducing, but a morbidity reducing effort, which is what all healthcare organizations try to do, all doctors and nurses try to do. I think this continuum needs to be maintained. Finally, I would only like to point out one thing, and that is that the effort, like Dr. Thomas also pointed out, needs to be reset from time to time, because the times keep on changing. From plague to COVID is completely different in the attitude of the availability of, or the understanding of the medicine at that time to what is going to come. And this resetting has to be led by WHO. Organizations which represent, like I like this word Dr. Gautam used, that have delusion of perfection in healthcare, using psychology, is perfectly good to understand. My own point would be that if there is one field which requires collaboration, not just between organizations, not just between public and private, not just between nations and regions and world, but also between patients and doctors, to both understand that it is a collective will and collective effort that will cause reduction. I'll conclude by just saying that WHO did extremely well in keeping the last year as focused on medication errors, this year on the patient. I hope for countries like ours, the next year is devoted on healthcare communication. One of the major problems that we have is a lack of communication. We don't communicate well between doctors, we don't communicate well between doctors and nurses, amongst nurses, and we don't communicate at all well between patients and doctors and patients and doctors' relatives. So I wish there was time for a Q&A, but I'd request this August gathering to reserve your questions to the tea and coffee session for the three speakers, and I'd request them to please make themselves available. Thank you for inviting me, Anupam.
Thank you so much. That was indeed a lovely session, and once again, our apologies that we will not be able to take the questions from the audience. But like Dr. Puri said, please catch them. And may I also say, Dr. Puri, we grew up watching you, so it's a lovely pleasure to see you on stage and to be able to hear you live. Thank you so much. So ladies and gentlemen, we have a slight change in the agenda. So we are going to be doing a very, very wonderful session now. The future of healthcare, a walkthrough. So it is my pleasure once again to introduce Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group. She is a global healthcare influencer, healthcare technocrat, social entrepreneur, and humanitarian. She is passionately committed to transforming healthcare systems through technological advancements and accelerating positive transformation for effective healthcare service delivery. And she is absolutely the right person to talk on the future of healthcare. So let's hear her riveting thoughts on how she visualizes the future of healthcare. It's my pleasure to welcome Dr. Sangeeta Reddy on the stage.
thank you for the time you have spent at Apollo Hospitals. Your next appointment is scheduled for 3rd of March. I will call you ahead of that to remind you.
Morning, ladies and gentlemen. Day 2 of a very exciting conference of all of us coming together to do something special. I've been asked by the organizers, and Gaurav in many ways controls our lives, to give a little bit of a glimpse into what is happening in the future of healthcare. And it is my pleasure and privilege to try and do so. I think that there's an over-preponderance of a tremendous amount of science coming into the world. We are changing the way technology is being used. We're looking at something completely different. We're conceptualizing enhanced care through the integration of medtech, clinical pathways, clinical decision support system, AI, various aspects of integrated risk prediction models. And finally, at the center of it all is patient safety, is the care we give to patients, is the thought process, is the technology, all merged together, but delivered. So while there may be, tremendous things that are getting bombarded at us, I want to begin truly, first by acknowledging all of you and sharing with you one magic mantra that Dr. Reddy gave us and continues to give every surgeon, every doctor, and every healthcare professional. And he said, you have the greatest of technology. You may be the brightest. You may have got a gold medal in your university. But remember only one thing. And we thought, this is the mantra. And he said, whenever you're near a patient, remember that the path from your brain to your hand goes through your heart. And that, ladies and gentlemen, is the ultimate of why we are all here today. And as long as we remember that the path from our brain to our hand goes through our heart, everything will become worthwhile, everything will be meaningful. So I'm going to quickly share something, but the reason I'm sharing this is that yesterday I told you all, or I asked you all, how many of you, understand the significance of cancer? How many of you have a family member or someone you know or love who's suffering from cancer or died of cancer? How many of you? See, almost everybody in the room. But how many of you know someone who's suffering from hypertension? Also almost everyone in the room, but the statistics that I shared with you yesterday is 1.17 billion people. And while we don't know exactly why cancer forms, we have multiple cures, but we don't have the ultimate cure, and our cure rate is still, at best, not able to save everyone. But hypertension we can control. So I want to begin by saying, as science evolves, please first take the knowledge and the science and the capability that we have, and all of you in the room, ensure that you implement it to the ultimate and the maximum. I'm going to move on to sharing some of these thought processes. So I did yesterday promise to tell you a very, very special story. And that story is related to this quest to solve cancer. So a month ago, we began a project in Meghalaya. And this project in Meghalaya is supported by the government, by the World Economic Forum, by World Bank, but it's not very, the cost per patient is under $1. But it is mobile vans, devices, technology, blood samples, biomarkers, and a population-wide screening for cancer. Our pursuit of population health began in the small city or the small village of Aragonda with 700 people. Today we're taking care of the end-to-end life of 68,000 people. The care from conception, when they're in the womb, all the way through life. And I think that as we all are in our individual hospitals, but we have WHO, we have the government, we have a proactive environment, and we have research and we have data. The time has come for us now to talk about population health and how we can separate the vulnerable, do early detection and screening, and from screening, we move to what we can do of proactive and preventive care. So that while on one hand we are treating, and I can tell you the most fantastic stories about transplant and minimally invasive cardiac surgery and proton therapy, but I'm standing up here and talking to you about what I believe is as critical in the future, and that is prevention. So please, when you go back, think about this. And let me tell you that research is moving at an unbelievable pace. Do you know that research shows that telomeres, mitochondria, and inflammation work together to prevent cancer? And this could lead to interventions that can offset one of the most harmful consequences of aging. So the correlation between aging and cancer, so while a few of you did not have anyone who knew cancer, all of you know someone who's aging, and we're going to be there as well. So it is important for us to begin to understand what are these early things. So I think what I'm coming here to say is that besides all the knowledge that you have, the knowledge that we are currently using is knowledge which is sitting within the body of our hospitals. And then we're now beginning to get this external knowledge. And the pace at which this is happening, how many of you know that ChatGPT passed the medical exam and could be certified? I mean, this is scary. And, every day there's something new and different which is happening in this field and this world. So where I'm actually leading up to is that if we build on the knowledge that we have, if we create our own hospital environments in the best possible way, and then if we take the next step, and that next step, ladies and gentlemen, is federated learning and data sharing. And why am I saying this? Because time and time again, we're beginning to see that the pace of all this new learning, what we built in our clinical intelligence engine, I don't know how many of you have seen it, but this is the cumulative knowledge of 40 years, probably 14, 15 years of data, 12 million patient encounters encapsulated into now the best possible pathway for 95% of outpatient engagements. And we will continue to create and update and improve that. But imagine if what took us 14 years to collect, if hospitals in India and across the world could say, let's look out for all the positive treatments for cancer. And we collate that data and we research that data and we accelerate the pace of new development. That's really what I'm here to talk to you about. You understand patient safety, you know your protocols, you know how to do operational improvements, and you're doing it every day. We know that IT and information systems are important in the hospital, and we're going to keep adding. We'll get our HIS, we'll do our CRM, we'll connect with patients, you'll use ChatGPT whenever you want to, but we need to take it to the next level. And that next level is opening our ecosystems, creating federated models, and then inviting science and researchers to partner with us more. Many years ago, actually 40 years ago, when Dr. Reddy put out his vision for Apollo, he said, we are committed to achieving excellence in clinical care, research, and education. We did the clinical care, we've added the education. Now we're focusing on the research. And the time for research was never more important than now. How many of you know how the vaccine happened? How did the world, scientists across the world, give us a vaccine within months? A normal vaccine? Yes, please. So, absolutely, it was through collaboration, but it was through, the adenovirus structure was opened up to the world. So the scientists and researchers could begin to examine and explore. Yes, AstraZeneca had an inner track, they moved faster, they were the first, that is fantastic. But equally, around in approximately 3 to 6 months within of each other, there were almost 7 different organizations who had an effective virus cure. This has never happened in the world, but that's because scientists began to share. So imagine if all of us as hospital administrators and doctors begin to start sharing what works and do it at a national and an international scale. So I think that is the primary aspect of what I'm talking about, because I believe that the world is transforming. Our patients are wearing sensors. You're getting a multitude of data. Intelligent brains in the other room are trying to figure out what they're going to do to organize that data. How do we take that data? And people often say that healthcare is drowning in data but dying for information. We know so many things, but we don't know the right thing at the right time when the patient needs it. So the crux of the future is about collecting data in a readable form. So using coding, using standards, collaborating to share that data, processing that data using artificial intelligence and human intelligence, and combining that data and bringing it back in a circle so that the doctors have it exactly where they need it next to the patient, so that the nurses have it exactly where and when they need it. This is the crux of where we are going. There are different things happening in AI, and I think it's important for me to share some of those, but I want to simplify the concept of AI because everybody's saying AI, AI. But I think everybody's wondering, how am I going to use this? So let me just take a few minutes to talk about AI. I think the first aspect of AI is a combination of what symptom causes what disease, and therefore enables diagnosis. So I've often wished, Dr. M.K. Mani is one of our most senior nephrologists. He's retired now. 38 years ago, I had the pleasure of training with him, working with him, as with people like Dr. M.R. Girinath. And one of the great things that all these clinicians did is that they continued to teach. But how many people can an individual doctor teach one-on-one? 10, 20, 30, 40, 50, 100, maybe 200 to do it well. But imagine if their encapsulated knowledge of treatment guidelines was put in the hands of everybody. So this is what the clinical intelligence engine is trying to do, and I'm going to request my team to share that video afterwards of the CIE. But what it does is it takes the treatment methodologies and protocols of hundreds of clinicians and puts it in the hand of everyone. So on Dr. Reddy's birthday, February 5th, we actually launched the first edition of the CIE and made it available and free for doctors all over the country. So this is not for patients to self-diagnose. This is for doctors to assist them in their treatment planning. So that is the first aspect of use of artificial intelligence. The second one of artificial intelligence is risk scoring. Microsoft and Apollo partnered to create the AI CVD. This is possibly the largest collation of patients who had symptoms and were studied over a period of 17 years. And then their cardiac incidence, how many people with this kind of cholesterol and this kind of blood pressure had a heart attack within what time frame. Long-term risk prediction. And AI risk scores come in all forms. We can do this about, cardiac, you can do it about cancer, you can do cumulative risk scores. They use federated learning models, but they also use deep learning and put them into identifiable models. So if you look at your current outpatient, and if you link to an AI CVD score and just press the button, a doctor who's possibly doing a laparoscopic cholecystectomy on a 65-year-old. Also analyzes, does this patient have an increased risk of cardiac? And if he does, he's going to make sure that he's done his treadmill test, maybe done his calcium scorers, we've studied his blood work, and we know that he has a cardiologist who's cleared him for surgery. And if we don't do these things, 1 in 1,000 patients who are having a laparoscopic cholecystectomy, he walked into theater, might have an MI while he's having his surgery. And that family is someone all of you will have to face, saying, "Acha tha, paidal mein aaya hospital mein, yet this is what happened to him." And these are the kind of situations that we cannot say, we couldn't do anything about. We are planning and training of how do we put the defib in the theater, how do we make sure that we solve the problem when it happens. We need to spend an equivalent amount of time proactively planning for the prevention of that incident. And you all understand this better than anyone else. Please take this message from the operating areas of patient falls and all the other things, infection, wound site, everything else that you're looking, take it more into deep clinical prevention. That is my second request to all of you. So number 1 is organize your data. Number 2 is take known AI risk models and scoring and put them into your deep clinical areas. Sepsis prediction models, 3 or 4 of them have been presented in the other room. We have one as well. If your patient is in ICU, please ensure you've done that risk model scoring, because you may pick up sepsis before your critical care consultant walks in the next day and finds that the patient is already in sepsis. These are the kind of things that go under the category of AI risk scoring models. Imaging and signals. Very, very wonderful and critical areas, because we're seeing hundreds of radiology images, hundreds of ECG images. Imagine if your post-cardiothoracic patient went home with a patch and you were monitoring him for the next 5 days. Imagine if the elderly patient who also has a heart failure is also wearing a patch but also has an electronic weighing machine. And if her liquid balance is changing so that she doesn't arrive in your emergency room gasping, and then you're pushing Lasix in the emergency room because you want to reduce the load on her heart. These are things that we can proactively prevent. And AI models are here to help you. So this is not some esoteric thing which is happening only in Google and Microsoft. This is something which is in your hands to begin to implement today. Radiology risk assessment scoring. There's a fantastic brain bleed system. If we apply that into all our imaging, the minute you finished, very often in all of us have technicians, we all have CT scan open 24/7. You get a brain injury patient who's come in at 2:30 in the morning, you rush him into CT. But sometimes you're waiting 1.5 to 2 hours before your doctor reports it. If you have the AI risk scoring for brain bleeds, you will know in 2 seconds with a 95% accuracy whether this is a brain bleed. And then what you do is you wake up that radiologist if he's sleeping in the duty room, and you get him down in 3 minutes rather than 20 minutes. So whatever the time frame. The time is varying depending on your doctor, your hospital protocol. But the point I'm trying to make is that the machine can help you before the human being can validate what the machine has said. Some point in the future, the machine may become more accurate. At no point in the future do I believe that the machine will replace the human being. But aspects of what the machine is doing will replace what the human being is currently doing. And that's why what I said about these is that AI will never replace doctors. But doctors and hospitals who use AI may replace doctors and hospitals who don't use AI. And that's why at this conference I really wanted to share some of these thoughts with you. There are 2 more categories of AI that we are looking at. Number 1 is what we call TOP, which is throughput optimization. What are you doing to ensure that patients are not waiting in radiology in one area, whereas they can be going to another area to get their X-ray done? How are you scheduling right? All this is something that every single one of you are running around every day and tracking through some level of dashboards or some feedback mechanism. AI can help you. What is the prediction of throughput in your hospitals? Somehow, do we see greater load on Saturday and less load on Sunday? Do we see greater loads on Monday and less loads on Tuesday? And these are the kind of patterns which can be analyzed so that you're handling staffing, you're scheduling better. So top algorithms, in AI-enabled top algorithms are very powerful. They're new. We haven't yet perfected this. We were focusing on clinical, but I'm very happy to announce collaborative programs on top algorithms for hospitals who want to partner, and let's find a way to do this together. The last and the most important aspect of AI, which I alluded to a little earlier, which starts with federated learning, but is the genomic AI. Because as all of us know, the cost of deciphering the genome has come down radically. What used to be a multi-million-dollar project is now coming down to a few dollars. Many of you, how many of you have had your gene analyzed? Gave your blood, got genome patri, one of those detailed analysis reports? A few. Oh, I'm surprised. This is very few. We're going to talk more about this later, but I mean, not today, but we really need to talk about this. How many of you have stored your stem cells? So I promise you, at the next year's conference, many more hands are going to go up. Right now, I'm seeing nobody has stored stem cells. Okay, women, this is confidential, but how many of you have stored your eggs? No hands going up either. So trust me, these numbers are going to change. Career women are looking at storing their eggs so that they can have their babies when they want them. Because I was in Agra day before yesterday, and they actually, I'm heading G20 Empower for Women, and one person said that babies and careers are at loggerheads in a woman's lifespan. Because at the time when it's perfect to have children is also when you have to work your hardest at your career. And so women are planning to store their eggs and have their babies when they're 37, 38, 40, 41, because that's when they've already become vice presidents. They can take a month off, they can manage because they have 5 assistants. So, but this is a little bit of an aside, but I just want to come back to genomic AI. The genome data that we have combined with the genotype and the phenotype are going to give us new cures. But besides new cures, 90% of the focus of genomic research is now going into longevity. I'll give you a few more predictions besides the fact that next year when you all come, many more hands are going to go up about having done their genome study. I genuinely predict that in the next 10 years, we will not be doing knee replacement the way we do it now. I think that in a proactive at 35, 45, 50, people will do stem cell therapy and regrow their cartilage. I think that AI-enabled gait analysis models will correct gait problems at their early stage, because when you're walking in the supermarket or in the mall, somebody will tell you, step on this gait thing, you'll analyze it, you'll get a report on your mobile phone, they'll give you a risk prediction that if you don't do something today, in the next 5 years, you'll need a knee replacement. You will go today and do something. These are the type of unbelievable changes, and I want to bring back that, this will happen in an everyday lifespan, and this will happen to all the major things. Imagine 100,000 people waiting for transplants. And imagine that with 3D printing, bioregeneration, and multiple aspects of nomics, that we will be able to grow organ. And if we can grow an organ and use an artificial organ, people will not be waiting. These are the kind of things that we can put together because the world is changing, and because healthcare is advanced, and because universal health access is daring us to dream. And because all of us will begin to create federated learning models where we will share our data and accelerate the pace of discovery. So I want to end by actually saying what you already know, and that is that you're all fantastic. You're handling multiple daily challenges, you're collaborating, you're finding ways to look at the costs, the patient need, the changing technology, the evolving protocols, doing it with a smile, and then the workforce. Your tired workforce, your workforce who got a job in Saudi Arabia, your other workforce who wants to go to Australia or Canada, we're handling it all. And then we're adding another element, which I'm saying all these things are happening. So don't be worried. All these things are here to help us. Let's sit together and decipher how we use science to our advantage, how we use technology to our advantage, because at the end of the day, we are here for patients, we are here to keep populations healthy, and we are here not to be bombarded by science, but to use science and technology to create a new future, which is the way we design it. As they said, the best way to what? To predict the future is not to come to conferences like this, but to create the future. So let's together create the future. All the best, ladies and gentlemen. Thank you for being a fantastic audience. Namaste. So over the years, you know that we started this conference because we felt the importance of sharing. Dr. Reddy once said that if I have 1 million bricks in Apollo Hospital, I've had 1 million problems making it happen. And so he said we must share what we know and what we learn to help others. So the Institutional Funding Act to fund hospitals was done at his behest. The Organ Transplantation Act was something that he pushed. Our project consultancy division came forth because of that. Our sharing like the CIE or this conference is that. And I'm really happy that our outstanding team in the quality area and our clinicians and our quality people have put together their knowledge, and we today have something that we want to share with all of you.
Thank you, ma'am. I did tell you she was the best person to talk about the future in healthcare. So after that wonderful session by Dr. Sangeeta Reddy, like she said, we have a book release and something that I think all of you will be very, very interested in. So a little bit about that. So it is essential we understand to continuously and constantly outmatch one's own impeccable standards. And with that regard and with that premise, we present to you this very insightful book, which, like ma'am said, has been prepared by all the quality team across our hospital. It's taken them close to 18 months to put together the content. It has everything from policies to processes, which is based on practical and cumulative experience from the largest health group of India. It provides invaluable insights and ideas for achieving exceptional performance in the quest for quality for every healthcare professional. And I'm sure every one of you and every one of your organizations would find it extremely useful. And there are a lot of copies outside, so please do have a look and please do pick it up. But there's something else that they have done. You'll be very interested to know that at the end of the book, they feature something called a mind map. And that's something that all of you should spend some time looking at. And to release the book, may I have the pleasure of inviting Dr. Jonathan Perlin and Dr. Neelam Dhingra to please come on the stage. We would like you to release the book and present the first copy to our joint MD, Dr. Sangeeta Reddy. Ma'am, please. May I also have the pleasure of inviting Dr. Hariprasad sir and Dr. Anupam Sibal and Mr. Gaurav Loria to please come on the stage. Yes, can we also have the video playing? Thank you. Thank you, ma'am. Thank you, Dr. Perlin, Dr. Dhingra, Dr. Hari Prasad, Dr. Anupam Sibal, and Mr. Loria. Thank you so much.
Good morning, everyone. Let's begin our next session on making patients aware of safety standards. Please join me in welcoming our speakers, Dr. Shravan Subramaniam, President and CEO, GE Healthcare, India and South Asia, and Managing Director, GE Healthcare. Dr. Joel A. Roos, Vice President, International Accreditation, Quality Improvement and Patient Safety at JCI. Ms. Barkha Dutt, Founder and Editor, The Mojo Story, former editor, NDTV. Dr. Nilesh Shah, President and Chief of Research and Innovation, Metropolis. And Dr. Shrirupa Das, Director, Medical Affairs, Clinical Research and Device Safety, Johnson & Johnson MedTech India. As healthcare providers, it's our responsibility to ensure that our patients receive the highest standard of care and are aware of the safety measures in place to protect them. We'll be exploring a range of topics in this session, including the benefits of patient engagement, best practices for communicating the safety information, and the role of technology in doing all of this. Our aim is to open pathways and dialogues to involve patients and their families so that they can play an active role in their own care and reduce the risk of harm. Please allow me to welcome our moderator for the session, Dr. K. Hari Prasad, the President, Apollo Hospitals Group. Dr. Hari Prasad has contributed to the launch of the first ever dedicated accident and emergency hospital in the country at Hyderabad. He is the first individual outside of Europe to be honored with the Fellowship of College of Emergency Medicine UK, and the first individual in India to be honored with the fellowship by the International Federation for Emergency Medicine. Request you, sir, to introduce the speakers and take this session forward.
Good morning, everybody. I promise you this will be a fun session. So, this will also be the best session of the 2 days. Not because I am moderating it, but because you have a panel which is wonderful. Dr. Shravan is the technology man here. He's doing a lot of work, not just making machines, but also making solutions for GE, for healthcare. Thank you so much for being here, Shravan. And then we have a man who has an oversight of quality of what's happening across the world from Joint Commission, Dr. Joel Ross, who is the Vice President of International Accreditation from Joint Commission International. Then there's a personality on stage who needs no introduction, Ms. Barkha Dutt. All of you would know her. I don't need to introduce. Then we also have Dr. Nilesh Shah, who is the President and Chief of Research and Innovation at Metropolis, and Dr. Shrirupa Das, who is the Director of Medical Affairs, Clinical Research and Device Safety with J&J. So you would see that the panel is very diverse. You have manufacturing sector, you have labs, you have other solution providers, and you have somebody like Barkha who is representing the common man. So let's have some fun during this session. And I always say that quality should be fun and it should not be thrust on anybody. And I wanted it to be a very interactive session. While we will have a few questions for the panelists, any of you have any questions, please write it on a slip of paper and give it to me. I'll be moving around here so that we can ask them. So the first question is for Barkha. Did you ever get hospitalized?
Can you hear me? Yeah.
Yeah.
Like, that's a trick question because I was admitted to Apollo in December. You have to have known that.
I knew that and I wanted to market for Apollo
So that's
a little
cheating.
bit.
That's cheating. The question is cheating.
But on a more serious note, while you were there at the hospital, what was the thing which scared you the most while you were at the hospital?
Firstly, it was my first time that I'd ever been hospitalized, and as a very active journalist, the idea of being in a hospital itself was terrifying. Secondly, this answer may surprise you, but what scared me more than anything else, I was hospitalized with pneumonia, was the cannula. I was being given intravenous antibiotics, and I have very, very thin veins. And every time the cannula was actually inserted, I had to change my cannula 3 times. It pained more than coughing all night and not sleeping, which was the sort of downside of having pneumonia. And nobody could, really appreciate this, because it's, people have seen me reporting from war zones and traveling through COVID, and to explain to them that, but I do have this fear of needles, alongside. I may not be scared of bombs, but I'm scared of injections, is a very difficult thing for anybody to comprehend. But that was the most terrifying and unpleasant thing for me.
Yeah, and you were at war zones and you were at the hospital. Which scared you more? Which environment scared you more?
The hospital.
You didn't feel safe in the hospital, you felt more safe in the war zone.
I think I was able to displace my fear in the war zone. It would be a lie to say that you don't feel scared when you're in conflict zones. But what happens is the adrenaline sort of helps you displace the fear. But when you're in a hospital, the adrenaline has already crashed. And all you're doing is constantly thinking and overthinking about what might happen to you. Distractions are limited. And you feel kind of not in control of yourself. Not that you're in control of things in a war zone, but you're driven by something. So your mind is distracted. And I think we don't pay enough attention to how the mind acts up when the body is in pain in hospital.
Yeah, that actually sets the tone for the rest of the session. The common man is actually scared in a hospital. So I want to ask a common question to all the remaining 4 panelists. In your respective areas, in your respective organizations, and because safety is not just in hospitals, I think it covers the entire spectrum of healthcare, starting from manufacturing to whatever, labs, tests to hospitals. So in your respective areas, do you think you make enough efforts to make it safe? And what do you think are the gaps in your own respective areas? We can start with Shravan.
Thank you so much, Hari. You introduced me as a technology man, so maybe I'll give you a perspective from technology. And Sangeeta was also talking about using AI and predictive models. So I read some time ago in The Economist about the aviation industry and how they keep things safe. And to keep an aircraft safe, all you need is, of course, a pilot. You need the computer that flies the plane, and you need a dog. Why? Because the computer is going to fly itself, and the dog is there just to bite the pilot anytime he gets near the computer. So that's what safety is in the aviation sector. Now, if you'll indulge me, Hari, and you take that analogy to healthcare, there's so much that technology is doing to keep us safe. But are our clinicians keeping pace with it? Are they making the right choices? Are they using the data that are available to them to make these safe decisions? Every year, my hair stands on end when I read of a patient or a patient's relative walking into an MRI room with an oxygen canister. That's just a recipe for disaster. It can cause severe damage, if not death, when these things happen. So taking the analogy a little further, medical technology, you come from the pharma industry. There are 2 gates that you have to cross to get a product to market. Number 1 is always safety, and only then we look at efficacy. So in our space, safety and quality go hand in hand, and having that knowledge, empowerment of the clinician and the patient is absolutely paramount.
Yeah, and that reminds me of one real-life incident. Chief Minister of a state was involved in a bomb blast, so he was taken to a hospital, and he was on the MRI couch. And the faithful security guy, he was a Z-class security person, he went into the MRI thing, and believe me, he almost died, not because of the bomb blast, the CM, but because of what the security guy did. Because the the shotgun which was there in the holster came out like a bullet, went across his face and went into the magnet. So that's as far as safety is concerned. Shravan, thank you so much. And this session is actually being hosted by Nat Health. And Shravan is heading Nat Health, so thank you so much for being here. Dr. Joel, I'm sure you would have seen the whole world and you have a lot to say, but we have 90 seconds.
Well, I'm not sure I've seen the whole world, but I've seen parts of it. I think, you know, we understand at many levels what patient safety is and what quality of healthcare is, but it has not been universally adopted or built into our systems, if I was going to really generalize, in the fact that not every hospital has it, you know, as a core tenet, and many physicians that are not affiliated with a hospital have even less affiliation really with the idea of patient safety because, you know, they're not part of a system. When you walk into a system and you have accreditation, when you have, you know, quality improvement mindset, it's sort of part of your practice, but it's not necessarily if you're in a clinic setting. But you know, the WHO wouldn't have a mission if patient safety wasn't paramount around the world. We wouldn't have as much of a mission if patient safety was really truly adopted universally in everything we did. There's elements of it and we talk about it and we're approving it, but it's nowhere near where it should be.
Thank you. Dr. Nilesh, on the lab side.
So, as a lab professional, we represent very small portion of entire healthcare, but an important one. And when a patient walks in, and I'm going to talk about the industry rather than my organization Metropolis alone, the gap remains non-uniform, but definitely there is a gap and there is an area of improvement. When a patient walks in, what is he looking for? He's looking for a biosafe collection, and I take inspiration from what Barkha said, you know, patients are scared of needles. Right from there, they do not know what is going to happen to me, what all they are going to do with me, how many times they are going to collect blood, and how much blood they are going to collect. Unfortunately, some communication and some information sharing is lacking. So patient is expecting, one is a biosafe collection and transparency on what is going to happen. Beside that, most importantly, is looking for an accurate report. A report which can be perceived accurate also is very important. So report, when we describe, there are multiple things. Right test taken, timely report, comprehensive report which declares everything including limitations of the test, and also it should be easily accessible, and there should be somebody to interpret, guide, and so on. All this put together is a biosafety, put together is patient safety, I would call. If my report is not accessible, if it is not delivered on time, if it is not properly interpreted, if limitations are not put on the report correctly, it will be perceived different than what it is actually, and the patient care, patient management can go wrong. Besides that, few things which patient less care about, but it's important, is confidentiality. Today, unfortunately, across the board, patient report confidentiality is not like what is there in the Western world. There is nothing like HIPAA compliance and all that here. Confidentiality is one big gap. Similarly, critical result. If the result is critical, it has to be communicated on time, which also I see some of the places gap. And the communication to whom and how it is communicated also is very, very important. Having said this, there are a few other aspects which we should be careful about, which talks about use and misuse. Your sample has been taken, you are not allowed to do more tests, you are not allowed to use the sample for any other purpose. These all are part of, I would say, patient biosafety. And the last but important one which I want to talk about is setting the expectation right. Many a times expectations itself are set wrong. For example, these days lots talked about full body checkup. Now there is nothing like full body checkup. A lab test you do, whether you do 50 tests or 200 tests, is not full body checkup. You are creating a wrong expectation in patient mind. And I think that also creates patients' safety compromised. Thank you so much.
Thank you. Dr. Srirupa?
So I think I would like to build on something Shravan already shared. So as far as the devices or the tech sector or the pharmaceutical sector is concerned, we are governed by regulations by CDSCO on quality standards, which I think all manufacturers, it's mandatory for all manufacturers to follow, and they do. And especially for an organization like Johnson & Johnson and many of the other companies where most of our products anyway get imported. So, in general, they are manufactured and distributed according to norms laid out by the US FDA or the other regulated markets. So where I see a potential gap and an opportunity for us to further strengthen in this area is when it comes to training of healthcare practitioners, and which is even more important in the tech sector, because when there are devices that are being used by surgeons, are they using them correctly? Are they really, are they mindful of all the warnings and precautions that are really set out in our IFU, or sort of the guidance or the holy grail for use of the product? And while organizations like J&J, I'm sure GE also does, and all the other manufacturers as well, we do take a lot of initiative in training surgeons, and we train lakhs of surgeons every year. But I think reinforcing some of these key messages is very, very important, so that we are sure that everybody is using these products in the right manner. And the other area where I see is also for us to get those insights and that intelligence from the field, from surgeons, from hospitals, from the entire healthcare community. If they faced any issue with anything, if there is something that they were not entirely comfortable about, if whatever the issues may be, I think it's very important to keep circling back to the manufacturer, which helps us further improve our product. So I think these are two areas, potential opportunity areas where we could collaborate and work on.
You guys are very unfair. The previous session didn't allow you to ask questions. I've said, give me questions and we'll ask them, and none of you have so far given me questions. Now, all of us know that there are gaps in the system, and I don't want to waste the time of the panelists or all of you who are present here today, because all of us know that there are gaps. So we should go back with at least one or two solutions that we could implement back home and make sure that the time spent here is useful. So I would ask, and more importantly, make Barka feel safer to come to a hospital if she does need to come to a hospital. So the common question for all of you, name one safety measure which you take in your own organization, which you think is the most important learning for an audience like this, and which will make Barka feel safer. We can start in the same order. No, Shravan.
So we've actually mandated wearing seatbelts in the rear seat, and we don't get reimbursed for our taxi if we don't wear a seatbelt. So safety is something that we sort of embody in everything that we do, not just in the manufacturing process, but in our daily life also.
So how many of you wear a seatbelt while you're driving? Many don't. Yeah. Go ahead, please.
Well, as I don't have a healthcare organization, so to speak, my advice is actually straightforward.
Actually, you could share probably the most important one which you've seen across.
Well, I'm going to take a little different tact. So if I was for a patient, choose a hospital that's accredited. If you're an administrator or a physician, work in a hospital that's accredited or get it accredited.
And that need not be just JCI, it could be NABH, it could be any accreditation.
I actually agree with that statement. I said very specifically accredited. I didn't say who.
Right.
What I do is that I pick up every opportunity which is patient touch point, and I use that opportunity to communicate. I think if patient has come for an inquiry, I don't let him keep asking question whether I should come fasting or not, how much time it will take for result, and so on. I keep write-ups and everything ready to hand it over in writing. These will inform much more than he can ask questions. Same way, if he goes to my electronic media, he has got all the questions which are in FAQ format answerable and available. And a lot of transparency is shown even on the report, where a lot of limitations of our test also are clearly displayed. The expectations are set right at every phase when we communicate with the patient, including when we are doing phlebotomy. We show them I'm using a disposable syringe and needle, and what is going to be processed henceforth and so on. So I feel communication is the biggest gap than anything else. If you keep making patient aware, and if you keep the expectation setting right, I think things will go right and patient will feel safe. Thank you.
Can I just jump in there? Because I
please.
think that was a really important point about communication. One thing that all of you as experts have to understand is that the patient today is much more aware than before, but often has half knowledge. As they say, half knowledge is a dangerous thing. So we're all Dr. Google, right? Before we come into a hospital, if we're in a condition, we have Googled our ailment. We have decided the worst, right? So we come in with fear because Google tells us that we have all of these many ailments possibly. So what we really need is someone to tell us, okay, you may have read this on Google, but it's not this, this or this. And FAQs would really help. And honestly, I know doctors find it funny when people say, is this needle clean? But I think you should encourage the fact today that almost every patient will ask that question before they're injected. And the internet has made people both more aware and more stupid, as with all technology, right? So you have to factor that in interpersonal relations between healthcare providers and patients.
We'll talk more about Dr. Google.
Sorry, 2 points very quickly. That's why I introduced pre-test counseling and post-test counseling for patient as well as doctor. At times, doctor also expects something which is not possible on the lab. So pre-test, post-test counseling, this is one. And as far as needles are concerned, there is a provision of making painless or pain-free blood collection, which also is an awareness which is created for people who are afraid.
Let's see if she'll come to you for a health check. Dr. Srirupa. No, I was talking about a preventive health check.
So I think it kind of ties in with the, all this communication with patients and all that we're talking about in a way ties in with the patient information leaflet that, pharmaceutical companies have. While that's not mandated for all products in India, but like maybe in the US, but I think it's a very important step, and it helps being transparent with patients as well, where you have everything put down on a sheet of paper, all the pros and cons and, the warnings and precautions and what is it that they need to be mindful of, what is it that they should avoid while taking the medication. And this is a good source of information, and I think it's very important for the healthcare providers to, also have that open, transparent communication with patients along with this piece of paper document as well, so that they are aware of what are the medications that they are being put on, or what are the other surgical procedures they are being put on, and the potential hazards and also the benefits, so as to enable them to make that informed decision. So it's a decision they are taking along with their doctor or surgeon. So that sort of is kind of a shared responsibility, and I think that's very critical from a patient perspective.
Actually, Barka needs to go, but before we let her go, we are living in a world of perception. And today there's a huge trust deficit between the community, the patients, the doctors, the labs, whatever you call. And probably people like Barka are responsible in part at least for that trust deficit.
What do you mean?
Because they talk a lot about things when something goes wrong, and it's hyped up and the whole world comes to know about it when something goes wrong. But I can assure you there are a lot of good things which are happening in the hospitals or in the manufacturing space or any of the other healthcare sectors, spaces, but the people do not know about it. And you will communicate only what is told to you and what you come to know about. So how do you think, as healthcare professionals, we should get out there and should create a communication pattern and help you to reduce, at least reduce that trust deficit which exists?
I mean, so I think the 2 years of the pandemic that we went through, which I kind of actively reported from across India, was an example of how if healthcare ecosystems give access to media at a humanized level, how that narrative can change. You know, otherwise what happens is that we get very formal handouts, they're in very technical language. You have to understand that to change the narrative, Hari, you need to reach people out there who are not doctors, who are not nurses, who are potential prospective patients, who are the world at large. And I think sometimes, you know, either you're talking in a language that is far too technical for most people to understand, so you could have a really amazing breakthrough, but you haven't translated it into a simple, accessible, you're disagreeing, into a simple, accessible language. Or two, sometimes there's such a fear of interacting with media. Oh, you know, they're going to write this, they're going to write that, that there is no access to sometimes really wonderful things. And trust me, as journalists, while we will of course report what goes wrong, we're very interested in how technology or new breakthroughs are in a way changing things, because this is one space that every reader or viewer is concerned with. This is not a niche space. So I don't know why there isn't much more interaction between the healthcare space and journalists.
Well, one of the things we're not talking about in any of this conversation, so it's a great point, but we're also talking about the wrong things. So when a patient, you know, as a physician, when a patient comes in to see me, they're worried about, I want this, you know, they've talked to Dr. Google, they want their antibiotic, they want, you know, they think they know what's wrong, they want this treatment, anything along those lines. But the conversation that's not happening and what we're not publishing is about safety itself. Is, you know, we have the leaflets for the medication, but we're not having patients, you know, choosing hospital X or procedure X or asking about even simple things, or, you know, paying attention, are you washing your hands? Are you, what are the outcomes, you know, how many OR fires? I mean, I'm searching for statistics at the moment, but these are safety statistics that we should be looking at, that we don't, as physicians, talk to patients about, help them choose a hospital based on these sort of data that may or may not be published on a hospital website. So it's not only a lack of communication, but it's talking about the right things and getting that into patients' lexicon. And actually, for many physicians that are not even affiliated with a hospital, to get them thinking about that as well. So I think that, you know, there's both ends of that.
Thank you. Thank you, Barka. And I know you need to go. Thank you so much for sparing your time here. And but do go and have a health check.
So
okay. Sorry. Since I mean, I always have a lot of fun pulling Anupam's leg in all these conferences. So I would like to request him to join this, join the panelists. Yeah, go ahead. Yeah, please.
So I was just going to take over same thing from Barka, and what we do. Just want to communicate. Let me start from the report. The report itself is patient friendly. This I perceive, this I take as an area of improvement for all the labs. The report is interactive report, where when a patient is reading, he does not understand, say lipid, he clicks on the lipid, it opens up all the lipid. He clicks on the cholesterol, then it describes what is cholesterol. So it's an interactive report, patient-friendly report, will make patient feel comfortable. Because this patient of this era is not like what we have seen 30 years ago. They have changed, they want to read the report themselves and feel satisfied. So also, on, as I said, patient report has to be very, very comprehensive. This is one thing. Second thing, what we do is, at every collection point, there are clear posters and access to information available to patient, whether it is test, what is a profile, what is content of profile, even pricing transparency and turnaround transparency is created. So what my suggestion and submission would be that at every touch point, if patient is made aware of what is available, how process is going to occur, what are the limitations, and what can you expect, and set the expectation right, I think that helps patient in big way. Thank you.
Go ahead, Sean.
Hari, I think there is a cultural element on reporting, and do we reward or punish reporting, right? And the cultural element that we all see, say, in the roads, Let's say Anupam is riding his shiny bicycle on a foggy Delhi morning, and Hari is driving his fancy Maybach, and he knocks him off his perch.
I hope I have one.
Yeah. What does Hari do? Is he going to stay and face the consequences, or is he going to take to his heels? And in India, we see this all the time. People take to their heels. And the same culture also follows us in whatever we do in healthcare. Do we proactively report at the risk of being punished, or do we try to bury this? Again, evoking what Sangeeta said, there's so much data. How can we integrate all this data and have a culture of proactively sharing and reward the errors that we find rather than take punitive action? I think that is something that all of us need to take to our quality conversations. Last word here is, we start at GE, every meeting that we have with a group of 5 or more starts with a safety moment. What did we learn from safety today, and how can we share that? Whether it's someone stubbing their toe in a staircase or an MRI incident, we encourage proactive sharing and we reward it.
Yeah, go ahead.
I just want to add on to that. So the Government of India has such a wonderful program, the PVPI, which is run across, and the whole purpose of PVPI is to gather any adverse events that are reported of drugs or devices across the country, build that into and they have such a wonderful database, and then to convert that into guidances which either the manufacturers need to incorporate, or hospitals or other stakeholders in the ecosystem need to incorporate and implement. But sadly, the reporting of adverse events in our country is so abysmally low. So even though the scenario has greatly improved over the past few years because of all the efforts that have been put in by PVPI, but yet it is way, way low than what it should be. And I can, talk here from a little bit of my personal experience. In one of my earlier organizations, we were doing a registration trial for a vaccine to be, which was meant for children. And when we had the results of the study come in, the adverse events, and remember, this was a vaccine which was being administered to infants and little kids. The number of adverse events reported was so less. We had a tough time, sort of convincing our global stakeholders, people who are reviewing the study report, as to why they are so low in India. It's because of our mindset. So even parents are of the opinion that टीका लगा है बच्चे को तो थोड़ा सा बुखार तो आएगा ही, थोड़ा सा दर्द तो होगा ही, and that's not something that is worth reporting. And I think this is a mindset that we need to sort of address. And typically for drugs which are which are investigational drugs, which have not yet been approved in the country, a typical sort of a very lay description of an adverse event, which I'm sure many of you are aware of here now, is that even if someone is walking on the road and something collapses on their head, yet it is still a reportable event. Why? Because you need to report that, and you need to do the causality assessment to really find out whether the medication somehow in some way was responsible. It could be something like the person was drowsy, or there was a little clouding of consciousness, and hence he or she walked into a danger zone, not being able to interpret the visual and auditory signals of danger. So it could be something as simple as that, but we somewhere, culturally that's something that we are lacking, and that's an area that we need to improve.
You want to add on something?
Reporting from hospitals, from healthcare providers, and reporting from patients. And as healthcare providers, as stakeholders in the ecosystem, I think that's something that we really need to encourage.
I'm going to go a step further. I'm going to go a step further on that. It's not about, just drug adverse event reporting, and it's not just India. It is adverse events, it is near misses in medicine, in hospitals across the world. There is a complete lack of willingness to report, and it's multifactorial, and it's real. It's about repercussions. It's about until there's truly a culture of safety embedded in an institution, and it's in pockets where someone feels safe, supported, and encouraged to really report the adverse events so they can be analyzed, looked at, and really, prevented in the future. So it's not just limited in size or scope.
Yeah,
and,
it's all about,
and that's our challenge.
Yeah, it's about sharing, reporting, learning from best practices. And one of the most important things for that is transparency. All of us who know Anupam know that he is very, very transparent when he decides to be, but otherwise he is very opaque. So what does it take for healthcare institutions, or what is actually preventing healthcare institutions from being really transparent and sharing thoughts? Because ultimately it's for the benefit of the patient.
Thank you, Hari. Really important, to cover transparency, and you sort of also talked about being opaque. And I think it's really important because there are 990 shades of gray. There's only one black, one white. So you really have to look at who you're addressing the idea to. It's like trying to explain the same concept to a 5-year-old, to a 15-year-old, or someone who's done an MBA from an M7 school. So you really have to see how to filter that information. But of course, extremely important that you do not compromise on facts. You do not compromise on stating what is the absolute truth. But it's about how do you actually give out the message. I think it's extremely important that, we kind of reset things. One is at the level of the institution. Everyone talks about blameless culture and so on and so forth. Ask that 22-year-old nurse who just graduated and it's her first week and she actually gives the wrong dose of medication, and just ask her how much confidence she has to actually go up to a nursing supervisor or the nursing superintendent that, somebody will take her aside and say, listen, it happened because of this, there's a system issue. Somebody will do an analysis, will be say, see, this is what happened with all you young people. You are so distracted. So even before she has a chance to talk about and express what is in her mind, there is this worry of being judgmental. And I think this is very, very important. We have to take this thing about being judgmental away. We need to have a blameless culture. At Apollo, what we've tried to do is, over the last few years, is to encourage reporting. So we actually start giving out batches if you report more. So, you just bring about a cultural change, and this takes time. And this is at the organization level. Then when we come to the level of the patient, see, the expectations these days are unreal. They really are. Everybody wants everything done now. You've gone to a cinema, you want to have coffee, you want to book it on an app, my exact coffee, so when I get there, I don't have to wait. So the same applies to healthcare. I go see a doc, everything needs to be done there and then, diagnosis X, Y, Z, everything. But medicine is complex. There are 13,600 diagnoses. There are 40 papers published every hour. By the time this panel discussion finishes, there are 20 more papers published on PubMed Central, peer-reviewed. So there's huge amount of knowledge out there. So we have to reset the expectation from a patient's point of view, and also that there is no such thing as a guarantee of success, a guarantee of cure. Because if we'd figure that out, nobody in our family would die. Nobody in our family would ever have to face a complication. So sort of we need to bring the expectations down. And this is a process that I think is going to take a while, and having more discussions of this nature involving the media and at an organization level, and also informally when we talk to the community that, listen, nothing is perfect. Life is actually supposed to be perfectly imperfect. So why do you expect medicine, clinical medicine, to be perfect? It's not going to be perfect. And we have to accept that as long everything that should have been done has been done, the system has been followed, and the organization is open to accepting the fact that there is an opportunity for improvement, I think that's as far as it's going to get.
Thanks, Anupam. I promise that he was very transparent when he spoke just now. Now, there are a lot of questions which have come in, and we promised to answer their questions, and I would ask a specific panelist each question so that, and I would request them to be very crisp in the answer. was a lot of questions. We'll start with Dr. Ross. How do we handle Dr. Google?
So there's a difference, Dr. Google isn't going away. Maybe it will be replaced by the chat bot, which will be a little bit more accurate. But, Dr. Google has a role. It is engaging patients in their care. The other side of this, and this is more about the quality and the interaction, not about patient safety, but it starts the dialogue with the patient. It's up for the physician to take up that dialogue and spend the time. I too am an emergency physician. It is, you have limited amounts of time to spend with a patient, and it's often easier to write for the antibiotic than to sit down and spend 10 or 15 minutes to explain, no, it really is a viral upper respiratory infection. It's best, treated symptomatically, and you're contributing to antibiotic resistance and the like. It's much easier to write the prescription and send the patient away. So Dr. Google does serve a purpose. We need to take up the challenge and spend the time with the patient and do the hard thing amidst all the other pressures that we deal with as, and it's not just the physician, it's the nurse, it's the entire staff. So that would be my initial answer.
Yeah. Dr. Nilesh, patient safety is not just about doctors, nurses. Most of the time they are the ones who are blamed. But it is along the entire spectrum of things which happens. And one of the important components in that spectrum is the patient himself or the community themselves. So how do we make sure that two things? One, they are aware of something called patient safety and quality existing in healthcare institutions. And second thing is, what do we do to make them feel empowered to ask questions? Because when they come to a hospital, they're so overwhelmed, as Barka just said, that they're very scared to ask questions. So very quickly, if you can answer these two questions.
So I will compare with a laboratory scenario, not the hospital scenario. And we do have patients who want to interact. Those patients are definitely entertained. But many patients want the information, but they do not want to interact. They do not know whether it is safe or it is allowed or it is fair to ask questions. I think we have been promoting our pre-test counseling, post-test counseling in big way. As a laboratorian, we are also supposed to do some advisory. All this put together, we try and communicate lots with the patient, be transparent at every level so that they feel safe. And since again I'm coming on transparency, I would also like to say transparency also in talking about limitations of the test and if errors are made. Let me come to an error where at times, see, there is no lab in the world which is perfect. If lab says I never make a mistake, they are not a lab. Now it makes a difference from a lab to another lab who is honest in communicating it. When I find error in my lab or my subordinates find, the culture is set that we are supposed to communicate. No questions asked, no permission required. Please communicate to the patient and doctor, okay, these three results have gone incorrect because of this reason. This is how we are going to ensure that in future it doesn't occur. We would like to withdraw and this is the right result. And this is transparently communicated. And I must confess, in 37 years of my career, I have made friends by doing this and not enemies. Those patients and doctors have become loyal and they felt more comfortable to complain or share feedback. So this is what we do.
Actually, a lot of questions came in. Thank you for them. A lot of them were actually answered during the course of the panel. Some of those which we didn't have time to do so. But I'm sure during the rest of the day they will be answered. But everyone who is asked the question, please make sure that you come to this side, this corner and collect a gift hamper because you made an effort to ask the question. So before we conclude, we just have, actually we are over time by 2 minutes. In 30 seconds, if you can, each one of you can give a take-home message focusing on communication, role of communication in patient safety.
All right, I have the microphone. So absolutely, as providers, we need to communicate with patients honestly and openly about errors, safety, and spend time educating them on the process and what to look for.
Honest, transparent communication through multiple modes which patient understands well. That is the key.
I see Siddhartha from Nat Health here, so I'll put in a plug for advocacy. I think taking the conversation to the government and policymakers and asking is good enough. And how do we raise the bar with people like we have today? Can we use more technology to make that happen?
I think really building that culture of safety, being open, transparent with patients on pros and cons of all treatment options that they are being put on, and also making them aware that it is their responsibility as well to report back to the healthcare provider if they are uncomfortable with something or they're facing any kind of an adverse event, which again needs to be circled back to the manufacturer. I think this will go a long way in addressing patient safety overall.
I think 3 quick points. One, that realization that it is critical. The second, making it a priority. And because if you don't make it a priority, then it gets drowned in the list of things. And the final most important point is follow through. Yeah, today, yes, I think it's a priority. Yeah, I want to do about it. But when I leave this hall and I go back to my organization, it's just going to fall by the wayside. So, you know, this commitment to follow through.
Yeah. If you don't remember anything, don't worry about it. But remember the last sentence which each of the panelists said. That would be a great take-home message. We've come a long way in terms of talking about quality, talking about errors, accepting that errors do happen in healthcare. And I must tell you here that Nat Health has taken up this initiative of talking about quality and healthcare and communication. So please do join Nat Health in supporting that initiative. And I would like to thank each of my panelists for being wonderful, and most importantly for keeping their answers short and crisp and not hopefully boring you with this session. Thank you so much. You've been wonderful.
Thank you, sir. We'll quickly take a short break. During the break, you can visit Rajabagh Hall. You can visit Rajabagh Hall, where we have a very interesting session happening on speaking circles, where you can discuss key topics. There are 2 key topics we have defined. Accreditation leads to patient safety, really, and dreams for a perfect organization. What can we do? Also, for the patient clubs, patient safety club members, we have a special session in Mumtaz Hall on Dream, our expectations from technology. There are a lot of prizes coming up before in the valedictory session. The iPads promised from yesterday will be given away then. So be sure to be back here for the valedictory session. We'll have the next session at 11:35 in this hall on hardwiring, reliability, and the future of patient safety. Request everyone to be back on time, please. If you haven't enrolled for the BLS session at 3:30, please do so now. You can go out to the May I Help desk outside of this hall and leave your name and number on a piece of paper, please, for the BLS session at 3:30.
Portso plays a huge role in determining the ease of operations within any hospital. The tasks of porters require immaculate precision and timing. The problem: the most crucial aspect for big hospitals is undoubtedly their proficiency, speed, and nurses' time. Innumerable lives rely on the efficiency of the staff on a daily basis. Hundreds of patients are admitted, taken in for examination, rushed into OTS, supervised in their wards, and discharged every few hours. Huge amount of drugs and samples are sent to labs, files exchanged, beds and trolleys are moved every minute. Although, more often than not, this efficiency takes a beating because of factors as simple as disorder. The nurses are left to handle the administration of the hospital, making repeated calls to supervisors and control rooms with walkie-talkies and piles of register entries with no record of porter availability, while the porters make chaotic trips from the wards to the assigned location and back, whiling away 20 to 25 minutes per trip. They then sit idle with no one to report to, as nurses further lose time in merely finding a free porter. All this while the patients suffer. Execution of these tasks in an untimely and disorganized manner often proves fatal, as nurses fail to attend to the patient's needs as they are clearly overburdened with administrative works. The solution: to bring an end to these issues, we introduce the all-new efficiency improver, time saver, Portso, a very unique and innovative porter management system that can aid the biggest and busiest hospitals in functioning smoothly and swiftly, as it majorly reduces human intervention. The following explanation will provide a deeper understanding of the function of the system. Working. The porter management solution is based on real-time location system. All porters are assigned Wi-Fi tags displaying requests raised by nurses. Like the aggregating system used in cab services and other transportation apps, a request is automatically sent to one porter who is closest to the requested location, filtering him out of all others who may already be engaged with an assigned task. As the porter moves to the requested location, his name, photograph, current location on the map, his ETA, estimate time of arrival, and the movement is displayed on the nurse station, on the mobile, and also in the control room workstations. The porters can be tracked in real time. As soon as he reaches the requested location, the porter presses the blue start button on the tag to begin his task. On reaching the destination, pressing the red end button marks the completion of the task, and the new task that is next in line will be assigned immediately. The start and end time duly get recorded in the system, declaring the porter available once again for another task. Excellence of Portso. This innovative solution saves a great amount of time, tracks every porter's movement in real time.
This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius. Your heart gave them heart. At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX, Fujifilm Sonosite. Any patient, anywhere, anytime. This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute, or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius. Your heart gave them heart. At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX, Fujifilm Sonosite. Any patient, anywhere, anytime. This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute, or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius. Your heart gave them heart. At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX, Fujifilm Sonosite. Any patient, anywhere, anytime. This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute, or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius. Your heart gave them heart. At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX. Fujifilm Sonosite. Any patient, anywhere, anytime. This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute, or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius.
Namaste. Welcome to the 9th International.
At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX. Fujifilm Sonosite. Any patient, anywhere, anytime. This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute, or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius. Your heart gave them heart. At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX. Fujifilm Sonosite. Any patient, anywhere, anytime. This is for the visionaries, the change agents, explorers, and dreamers. Those who see the world of medicine not as it is, but for what it could be. It's to them that we at Sonosite dedicate our own vision. A vision of how outcomes can be bettered, how lives can be changed, how the human touch can be optimized. It's what drives us to see you behind every scan, every day, every crucial minute, or precious second. From the moment we dedicated ourselves to point-of-care ultrasound technology more than 20 years ago, you, the men and women on the front lines of modern medicine, have been our inspiration. You have inspired every screen, every transducer, every wheelbase, every workflow, every button and knob, or lack thereof. The way you move, the way you think, the way you care. In measures both subtle and large, your skill gave our product skill. Your genius gave them genius. Your heart gave them heart. At Sonosite, we never forget who's behind the scan. And we're behind you every step of the way. Welcome to the next. Clarity and confidence comes to light. Meet Sonosite PX. Fujifilm Sonosite. Any patient, anywhere, anytime.
The Apollo Institute of Medical Sciences and Research. As Dean of the Medical College, it gives me great pleasure to reflect on the growth of this institution. From humble beginnings, we've grown by leaps and bounds, and today we are home to 150 medical graduates every year. We have expanded into the field of postgraduate medical education, and the presence of renowned faculty and a dedicated support team ensures that we are a sought-for destination in higher education. The Medical College General Hospital provides affordable, quality healthcare. The Arogya Shri scheme ensures that no one is left behind. Research in healthcare, research in health education is the third area of thrust of this institution, and the availability of projects and grants enables us to contribute to the scientific output of the nation. AIMSR is a place where education, healthcare, and research happens in a nurturing environment.
Our 5 years MBBS and our postgraduate programs combine robust academics to produce exceptionally prepared, patient-focused clinicians and researchers. Our principal teaching hospital is a 600-bed facility with over 21 clinical specialties and caters to hundreds of patients from economically poor sections and marginalized populations of the society.
The Apollo Institute of Medical Sciences and Research. As Dean of the Medical College, it gives me great pleasure to reflect on the growth of this institution.
Welcome back, everyone. Can I request you to please inform your colleagues and friends outside to come in? We should start in another 2 minutes. Let's get started with the session, a plenary on hardwiring reliability and the future of patient safety. Patient safety, like we have been speaking, is the top priority in healthcare. And with a plethora of technology and medical practices available today, it's more essential than ever to be informed of the latest trend and the most reliable practices.
In the plenary session, we will discuss the importance of evidence-based approaches, the use of technology to improve patient safety, and the need for continuous improvement and learning.
Thank you, Maitri. Please join me in welcoming the session chair, Dr. Ashwini Agarwal, Director, PwC, India. Please come on stage, sir. Mic, sir. And please join me in welcoming Dr. Atul Mohan Kochar, CEO, NIBH, Dr. Carsten Engel, CEO, ISQA, Dr. Mark O'Brien, the Program Director of the Oxford Healthcare Leadership Program and Associate Fellow at the State Business School at Oxford University. Dr. Ashwini Agarwal is a doctor turned MBA and an experienced healthcare consultant who has advised clients across services and industries. Request you to take the session forward and introduce our panelists, sir.
Hi, good afternoon, everyone. I'm Ashwini, and it's a pleasure to be in front of you today. So we all know that COVID-19 pandemic has been a, how should I say, maybe a ballpark event in the history of medical sciences. I mean, it has been both an enabling event as well as a humbling event, actually. When I say enabling, I mean, when we look at it, the technology that advanced in times of COVID, it was unprecedented. I think it was probably for the first time that we managed to have a vaccine rolled out in 1 year. The degree of collaboration that we saw was simply unprecedented. I think the scientists, the doctors, the nurses, all across the globe, they came on a single platform to contribute this particular thing. Humbling, I'll say that because all said and done, we still lost many lives that may have been otherwise preventable. I mean, if you look at the numbers, I think it's around 6 million lives which have been lost actually as per the official count, but there may be many more actually. So today we have an August session with us. We have a panelist with us. I'll welcome Dr. Atul actually. Dr. Atul is the CEO of NABH. We have Dr. Mark. Dr. Mark is, I'm sorry, from Oxford. And then we have Dr. Carl actually, who is the CEO of ISQA. So we will have an interesting session over here. We will start with small presentations actually, to highlight some of the experiences that we had during times of COVID. Interesting thing over here is, like, for example, we want to understand how accreditation can play a role in making us better prepare for future pandemics. Like they say that future pandemic can never be prevented. This was not the last pandemic that we witnessed in a lifetime. Maybe there will be many more. But as we go about accreditation, as we build our healthcare systems, maybe there is a case that we can be better prepared for that. So maybe I'll request Dr. Carl if you can make a small presentation on the particular topic. Yeah.
Namaste. I thank you for the opportunity to speak to you today, and I bring you greetings from the entire ISQA community. Accreditation has contributed significantly to the promotion of patient safety. I'm convinced that accreditation has a great potential to help us when we move forward. But as is the case for everything else, accreditation must learn and adapt. It must review and continually revise itself in order to remain relevant and useful in a world full of challenges, but also full of opportunities. Let's have a look at those challenges. First, we are not good at using the evidence that's available to us. Numerous studies over a long period of time demonstrate that only 60% of the care we provide is aligned with evidence or consensus-based guidelines. 30% is waste, and 10% of our patients are actually harmed while receiving care, and these numbers have been constant for a long period of time. Evidence is slow in reaching from academia to the daily clinic. Some estimate a lag time of around 17 years. But we should notice that this is not the way it has to be. During the COVID pandemic, translation was much faster than that. New technologies are emerging and influence the models for care provision fundamentally. Think telemedicine, think precision medicine, care tailored to your genome. There are important demographic challenges, dynamics that will impact all of us, more refugees than ever, aging populations. And the patients are not as they used to be. They expect us not to consider them as objects we do things to. Patients want to be seen as persons we do things with. They want to be seen as partners in a team that works according to the patient's answer to the question, what matters to you? That's the central question of person-centered care, I think. And society demands that healthcare does its bit to ensure sustainability. The carbon footprint of healthcare is substantial. Resources are limited, both money and staff. Person-centeredness includes protecting, supporting, empowering staff. Staff are persons too, of course. If you don't take care of your staff, how can you expect them to be able to take care of patients? And how can you, in the long run, expect to be able to recruit and retain staff? And finally, healthcare does not exist in a stable environment. We need to be prepared both for the expected bumps, for instance, due to the occasional random variations. Some days the emergency room is more busy than others for no obvious reasons. There are known patterns, the seasonal flu, big sports events, and then there's the unexpected and unpredictable, like natural disasters, wars, and pandemics. Some of this we can predict will come sometime, and sometimes we are surprised by something entirely new. All of this accreditation should help us to meet. And of course, accreditation is not a magic bullet that can solve all our problems, but accreditation does have some powers. And how does it exercise those powers? Well, first, some standards simply tell you what to do. You should have a standard operating procedure to identify patients that says so and so. Other standards help you organize your work, your governance, management, risk management, and quality development. Then there are some standards that are more like prompts and suggestions, standards that point out issues you must consider, discuss, resolve. They may indicate some possible solutions. This is a kind of standard that say you should have a policy for X without prescribing in detail how this policy should be. For standards should not stand in the way of innovation. New and better ways might be found at any time, so being overly prescriptive might be counterproductive. And finally, some standards may help you frame the way in which you think, in other words, shape culture. Examples would again be you should have a policy standard. And what this movement that's initiated by accreditation in an organization is actually a very important point of accreditation. Now we look to some of the solution for the challenges. Any set of accreditation standards will require that hospitals has evidence-based clinical guidelines and that everyone works according to them. Why do we then have the 60-30-10 problem? I think that a more data-driven approach to assessment might first provide us with a more valid assessment, but clinical performance data are known also to drive improvement, and presenting and discussing clinical performance data is a great way of engaging physicians in the accreditation process, and we know that that sometimes can be a problem. The next solution is a move towards integrated care, taking the system's perspective. We must realize that hospitals are downstream. While hospitals are important and necessary, there's the primary care and the public health component of healthcare upstream, and any problem that can be solved upstream is likely to be solved both better and more resource effective than a problem that is allowed to go downstream. It actually could be seen as a kind of waste to allow that, and we experienced during the pandemic that while the hospitals were indispensable, if we only have had hospitals to combat the pandemic, we would have been in a very bad situation. But it's true in peacetime as well. Take, for instance, diabetes care. The care you provide for a patient may be evidence-based, but if the condition could have been avoided by early public health interventions, and by this I do not only mean lifestyle campaigns, but also things like providing affordable, healthy food to everyone. If this could have prevented the diabetes to occur, then the resources to provide diabetes care could, from a larger perspective, be considered wasted, even if, of course, we should provide them when the situation is as it is. Universal health coverage in the sense of access to what you need to stay healthy is unthinkable without a systems perspective. So, we must ask ourselves if we should change the model from accreditation of individual hospitals to an integrated assessment of all health services provided to a population. And I'm not speaking about the population of all India, but some local defined circumscribed population. This may still be a bit ahead of us. There are examples of this around the world, but at the least we must promote that a hospital views itself as a part of a system. When it comes to safety thinking, we must grow beyond thinking that there's always a way in which we can know in advance what will be the right way to do things. In other words, we cannot make a rule book and the manual book that will keep us safe in all circumstances. Of course, we should learn from errors, and we should strive to avoid those errors that we know may occur. And of course, rules and standard operating procedures for a lot of things will help us, but it's not all. We must accept that not everything is predictable in a complex world, and we must learn from what's going well when it comes to handling complexity and unpredictability. That's the way of thinking that we call safety too. And we need to nurture a culture of resilience. Resilience meaning things like the ability to respond, learn, monitor, anticipate when you stand in a situation that's not according to the book. And we need to take a multi-pronged approach to safety. And be aware that one of the pioneers in resilience and safety too, Erik Holnagle, said those wise words: resilience is something a system or an organization does rather than something it has. You can't create it just by building structures. Vincent and Amalberti point out 5 different types of strategies that can be used to support and achieve patient safety. The first strategy is standardization of specific procedures, and this corresponds to complying with classical accreditation standards. Strategy 2 includes things like use of checklists and structured handovers, training of staff, improved levels and organizations of staff. This is also not too difficult to codify as standards. Strategy 3 could be things like technical constraints, gas couplings where oxygen couplings only fit in oxygen outlets is a prime example, but it could also be defining no conditions, for instance, don't perform a spinal if platelets are low. Again, this can be expressed as standards, and so can the fifth strategy. But the fourth is different. I quote from Vincent and Amalberti. In settings where care can be precisely delineated, strategies to control exposure to risk and maintain standards will predominate. In contrast, in more fluid and dynamic environments, strategies to improve monitoring and adaptation may prove more to the fore, although all environments require a solid procedural underpinning. Very briefly, a procedure-oriented accreditation will provide you with a very good toolbox. Those of you who were accredited when you faced the pandemic will know that. But the challenge for accreditation is to find a way to increase the way in which it supports you and your system to make the most of the toolbox. And I am not sure that this can be done by creating more process compliance, writing more procedures. I have actually seen some very nasty examples of adverse events that happened when professionals, including physicians, followed standard operating procedures faithfully without really knowing what they were doing and without being able to recognize when things began to go awry and there was a need to respond adequately. We need to learn to assess and promote the components of resilience, respond, learn, monitor, anticipate by our accreditation programs. So, by now it should be clear that we are not just scratching at the surface. There is a need for fundamental changes of culture, our fundamental assumptions, our picture of where we want to be, the way we do things here, our values. Two important aspects of culture to address are the two related ones that I have listed here, teamwork and co-production. We need to focus on the team rather than on lone heroes, and that needs to start at the educational level, that medical students must be taught and learn by doing to work in teams when they solve problems. Resilience is something that rests in a team, not in lone heroes, and in a team that's characterized by professionalism, mutual respect, and open-mindedness. We also need to create a culture of co-production with patients and families. The challenge for accreditation is that we know ways of measuring culture, and we can put them into standards. We can demand that you do culture surveys. An on-site survey can add another dimension to the assessment of culture. Can culture be influenced in other ways by standards? I think yes, if the standards are used to initiate questions, discussions, and afterthoughts in the organization, because that's what eventually will change culture. Accreditation is a driver of change and a supporter of those who want to change. And how does this work? Declaring and publishing that this is what we expect from you and we will come and assess whether you meet our expectations will clearly put a topic on the agenda. Skillfully written standards will encapsulate knowledge and transfer knowledge in an actionable format. In this way, the standards talk to both head and hands. To achieve a change, you must also talk to the heart. This is leadership. But the heart sometimes needs a little bit of a nudging, a pressure if you like. And isomorphic pressure is the perception that it is unacceptable and damaging to you not to comply with certain good practice. This was actually one of the lessons learned from the CLAPSI intervention in the Michigan that you may have heard in one of the earlier presentations. But this is what the accreditation program can do from the outside. It's very decisive what you do from the inside, how you would take accreditation up in the organization and use this as part of your strategy. Accreditation can provide an organization with a roadmap. Holnail says that we need these three things to be able to effect a change. The position, know where you are. The goal, know where you want to be. And the means, knowing how to get there. If there is a common understanding of this at all levels in the organizations, If there's a desire and a willingness to make change and work together to find and employ the means, then there is a possibility for successful change. Process-oriented accreditation focuses on the position and means. It assumes that if your processes are right, so will your outcome be. The thing is linear. There's a linear connection from process to outcome. Position is assessed and expressed in terms of policies and procedures. One of the appeals of this approach is that it's actionable. It is not necessarily easy to change a process in an organization like a big hospital, but in some sense it's straightforward and you can follow your progress in real time. But we need to move to a complementary view of accreditation, and I just want to highlight two of the points here. One is the point that says examination of processes for compliance with requirements will have to be played down, while processes will instead be examined to understand why outcomes are as they are. And judgment will be based less on process compliance per se and more on outcomes. Reporting will focus on mechanisms rather on the compliance measurements that could degenerate into some kind of a tick box exercise. And finally, ISQA has an important role in healthcare accreditation by running the international accreditation program that offers accreditation of accreditation standards, accreditation bodies, and training of surveyors. The standards for standards are called the principles, and the current 5th edition will undergo a thorough review and revision this year, and the aim of the review is to enable the accreditors to take a leap forward along the lines I've outlined to you. We have currently a hearing process where a lot of external stakeholders are asked on their views, and we will involve all the accreditation bodies that come together in our accreditation council to provide their input so that we can present a revised version by the end of this year. It's also part of our mission to collect and make known the body of evidence that support accreditation and that can learn us important lessons on how to make the best use of accreditation. The evidence is not weak, but it's also not as strong as we might wish it to be. Actually, the evidence for accreditation is probably stronger than the evidence for most other quality improvement strategies. But it's important for all of you to contribute to build this evidence, and the simple way of doing it is to be sure that you collect data on your progress of your accreditation journey, because that will be the fundamentals needs to move us forward. Some of this will be discussed at the annual ISQA conference. This year it's in August in Seoul. We have closed submission for abstracts now, but I'm happy to inform you that India is on the top 5 list of submitting countries, and I hope to see many of you there and join your colleagues for discussions. Thank you for your attention.
Thank you. Thank you, Dr. Khan. Thank you for the holistic overview of the entire accreditation process. I think it's pretty important that as we undertake the journey towards patient safety and as we strive towards accreditation, we understand the concept in is holistic. Otherwise, we tend to remain in silos and pick up 1 or 2, 3 things only. Now, among the multiple things which you mentioned, sir, I think I want to take forward the discussion on the staff leadership which you mentioned. Now, Dr. Mark, it is said that maybe leadership is not only about the technical skills, it's about the non-technical skills also. The best batsman may not be the best coach. Similarly, the best surgeon may not be the best quality champion. So in your experience, how does the leadership change, or how does the different leadership patterns influence the healthcare outcomes? Do you think there is a merit that we should start training our leadership from the early days? What kind of cultural traits should I be looking at? How should the leadership be ingrained for the future?
Thank you very much for the question. Yes, it's certainly, I think, what we've learned in healthcare is when we look at other industries, they typically will develop a pipeline of leadership that may go for 10 or 15 years in preparing people for leadership. And for much of healthcare, it's often very good doctors and nurses being selected because of their technical expertise, then being thrust into leadership. I was in the presentation I'll give, I will reference one of our recently retired professors at the business school at Oxford, Professor Lalit Johri, And Lalit used to always start his lectures and whatever, or courses, by saying, congratulations on coming to Oxford, being selected for this course. You are all here because you are so successful. You have so much unlearning to do. Everything that made you acceptable for this course is what you have to unlearn to become a great leader. And I think part of the journey, not only that I'll be talking about, which is the journey of the heart, is this switch from a technical expertise, but now in the leadership space we need a technical managerialism to run things well. But as you know, that doesn't account for the huge variation we have in healthcare. It's much more about the quality of leadership and what is the way we develop those leaders. Yeah.
No, absolutely, absolutely. Very rightly said. Dr. Atul, you have been a leader in this particular space, and now we know that the healthcare is far more complex than what it used to be. Previously, maybe there were a couple of niche players only, but now as you look at that, we have cybersecurity experts, we have e-pharmacy players, we have online aggregators and whatnot actually. So the healthcare, I believe, is a lot more complex than what it used to be. So in this particular kind of a space, when we have new players emerging, new stakeholders arising, how do we ensure that all of them understand the value of accreditation? How do we ensure that probably accreditation is not only limited to one stakeholder, it's actually ubiquitous, everyone encompasses the spirit of it?
Yeah, thank you, Dr. Ashwini, and sincere apologies to all for the continuing laryngitis. So this has been a good discussion, especially Dr. Karsten. I think he took us through the entire future prospects of what the future of accreditation is going to be, how is it important. And Mark has really told us about the leadership, that everybody can be a leader in spite of their speciality. Now, we all realize that change is the only constant, right? And COVID has also shown us that we are as good as the weakest link in the chain. So if we are to stay relevant, if we are to prevent future pandemics, or if we are to just create or change that culture, bring that culture of change, we really have to work towards it. And the only way, like ours is a big country, we are not one country, rather we are 36 countries rolled into one. And the provider versus providee gap is also huge. And the only way we can bridge that gap is by leveraging technology. India has already shown to the world in certain manners that we can leapfrog. Like our Aadhaar is a unique interface which is now useful in the entire fintech industry. We also are very aware that India succeeded by leveraging the strength of technology in the COVID vaccination. I think that's a wonderful thing. And the only way we could achieve all that humongous task of 200 crores of vaccines and nearly ubiquitous presence of Aadhaar is by having SOPs in place. So I make a very strong case for accreditation, certification, SOPs. Even if it's not accreditation in one go, let's say, I mean, we are very proud to have standards which are accredited by ISQA. Not only standard, our organization is also accredited by ISQA. But we realized much earlier in 2014 that one size in India does not fit all. So we brought in the entry-level standards. So that entry-level standards are helping, hand-holding small players in finding their feet in quality. So these are very small setups, nursing home, mom and pop stores in tier 2, tier 3, tier 4 cities, where earlier there was no concept of quality. So now we have 10,000 plus hospitals which are entry-level certified. So these are extremely important for the quality consciousness of the country. Coming back to your question, you said there are so many players. So we need to have certain standard which weave together the goodness of all those things. And for that, we are very proud to announce we have already drafted the digital health standards for the country. And they are based on the basic tenets of Ayushman Bharat Digital Mission. There are 4 components of ABDM, the Aadhaar number, the health professional registry, the health facility registry, and the interoperability. So these are the game changer standards. So we are aware that first time about 2 years back, our Honorable Prime Minister gave us the Ayushman Bharat Digital Mission, the NDHM, which is now known as ABDM. So based on that, we have drafted the National Digital Health Standards, and the pilots are currently on as we speak, 4 hospitals, and we have developed them in conjunction with PwC. So thank you so much to the wisdom of PwC also, because they bring in that collective learnings and experiences from 106 countries. So, so these standards have the potential of multiple aspects. One, bringing together the entire digital ecosystem, whether it's a wearable or whether it's a registration, whether it's a DigiLocker, the diagnostic, the imaging, or any aspect of the healthcare which is going to change in very near future. Also, this is also going to involve lots of trainings in various parts. Training, and these are enabling standards, because over the past few years, like I can vouch for the 18 years of NABH existence, we have seen that hospitals like Apollo or Max or Fortis, they have come up and they are the true islands of excellence comparable to the best in the world. But since we are a big country, the hospitals in tier 2, tier 4 remote areas, they also need to be brought up to that level. And for that bringing these standards, that collective consciousness of a digital ecosystem, they will come in very, very handy. And that's my belief.
Thank you, sir. Thank you very much. I absolutely agree with you that even though we have the niche stakeholders, there are some common binding principles. A binding principle like interoperability that should be applied to each one of them. And maybe technology is the way forward. Technology can play a leading role over there. Thank you, sir. Sir, you also mentioned about the diversity in India. That, like, for example, we are actually 36 countries in a way, if you look at the size and the number of it. And from a health system design perspective, it's not actually one health system design. We have a tax-funded model, like a national health mission, which is akin to the National Health Service of UK. We have a payroll-based tax system, which, like, for example, all the people who are in employment, they contribute a part of their salary, and that goes through the insurance, which is more like the USA model. And we also have a large out-of-pocket model, where every patient spends from his own pocket to contract with a local healthcare professional or a local doctor, actually. Now, among this entire diversity, I think there is a need for some local adaptation as well as the overall standardization. So, Dr. Khan, this is your experience in multiple countries. How can we drive this particular change that we have so much of a diversity, but still we have local adaptation as well as standardization? What's your take on that? Are there some lessons from other countries that we can adopt in India as we go forward?
Hello? Yeah. Yeah. Yes. Well, this is obviously one reason why standards should not be too prescriptive. We can ask the same questions to many different kinds of providers, and the answers will sometimes be different if you look at a big university hospital and a small rural clinic, but they all need to address the question of fire safety in some way or another. And standards can help us create a common language across many kinds of organizations, and standards is also a way that we can reach out to a large number of organizations through a cascade. And there are many countries, I could mention Australia as one example, where they have a set of national standards, and it's a country with, of course, big metropolitan hospitals, but also a country where there is an outback with small bush clinics that work by the same fundamental standards, but assessed in a way that's sensitive to the context in which they work. So there are examples of that.
Thank you, Dr. Khan. I think this is interesting, actually. Like the Australia, we have national health standards over there. Maybe there are some principles that we can incorporate over here. Dr. Mark, now in India, we have this thing of fragmentation of providers, actually. So unlike other countries where average hospital size may be 7,500 bed, in India, the majority of the hospitals are like 10, 15, 20 beds only. Now, this is the way the Indian system has grown over the years, and this thing is likely to persist at least for some time, actually. Further, like for example, we have an overlaid emphasis on the technical expertise or technical education part of it, but concepts like healthcare economics, public health system, or maybe, let's say, for example, the health system, these are not really taught in the education curriculum, the core part of it. Now, in this particular case, how do you say we can develop the future leadership? How can we inculcate some of the principles you said earlier, which actually percolate down to the last provider, last mile, actually?
No, it's a great question, and thank you very much. So just thank you. As you can tell from my accent, even though I have a position at Oxford University, I have an Australian accent, and I actually started my life as a rural family physician in one of those very remote hospitals. Actually, it was funny, when I was coming here on the weekend, one of my Australian friends asked me whether I was coming to speak at the conference or to open the batting for Australia after last week's test match. I've come to speak at the conference. Look, I think one of the, we've done an extraordinary job in the last 100 years in transforming the life of the world. If you look at life expectancy 100 years ago, most of us in the room would not be here. So I think we have to pay homage to the incredible technical advances, and that's not just been in hospitals, it's been through public health, it's been through primary care, it's been through community care. But the challenge is, and you've heard it over the last 2 days, the challenge is that when we start measuring the outcomes, we've almost become victims of our own success. The technology has become so wonderful, so predictable, so reliable, that the biggest cause of harm now is not so much a difference in the technology or the technical ability of the people that are caring for you, but rather the quality of the leadership, the culture of the organisation. And so, as Carsten said, this is really important, because a leader in India is different to a leader in Scotland or a leader in South Africa, because there are cultural elements that come into play. But what we know is that you cannot be a leader without followers. And what sort of people do people want to follow? And I talk about this personal transformation journey that every leader must go on. There was a very interesting man who wrote a book about the challenge that we face in our lives in our 50s and 60s, where we move from success to significance. And I think one of the biggest challenges we have in healthcare leadership is, well, there's two really. First of all, how do we develop a pipeline of leaders so that we become like every other industry? Leaders are identified early, trained, prepared, protected from their mistakes when they make them when they're young. But secondly, we've got to start from where we are, which is most of the leaders we have not gone through that pipeline. They are clinicians, or they are people who've come from other industries. And we have to think about, how are they going to transform the system? You've heard many speakers talk about, we have the science, we know how to do it. The question is, why isn't it working? And so that transformational change in your heart is a spiritual, philosophical change. And the program that I lead at Oxford, we unequivocally talk about the interior journey that you have to undergo to become a transformational leader. The move from success to significance. You can tap into religious experiences. You can tap into leadership experiences from great philosophers. Ironically, I believe much of what we need to know about leadership and incorporate into leadership was known thousands of years ago. The world's great religious traditions have encapsulated what are the human needs and desires, what are the things that humans crave for, and what are the values and ethics that will make you someone that people will want to follow and join and create movements of change. So I get very worried when discussions of leadership inevitably end up in some countries in a very technical, managerialistic talk. You need to be a great technical leader to lead change, but you will go nowhere unless you undergo a personal transformational journey. This is a deeply interior, personal experience. And we have so much wisdom to tap into. And so we have a professor of strategy at Oxford who talks about, what predicts strategic success. All of your organisations will have these great, here's our mission, here's our values. I can walk into any hospital, any country, anywhere in the world, and I have the privilege of doing that. And people say, oh, what is a good hospital? I say, there's no such thing as a good hospital. There's a good ward, a good clinic, because on level 2, there might be a wonderful ward, and on level 4, there's a ward that I wouldn't go to. They're in the same hospital. They have the same board. They have the same remuneration structure. What is the difference? The difference is the personal qualities and transformation that the leaders on level 2 have undertaken, that the leaders on level 4 have yet to undertake. So there are no good hospitals. There are no good health systems, in my view. There are wonderful leaders who have encapsulated the humanity that attracted me into medicine, the thing that made me want to be a remote doctor in Australia, to care for patients, who have then thought, how do we multiply this effect? And my professor of strategy at Oxford that I talk about talks about the most important strategic predictor of success is not so much the vision statement on the wall, but it is the attention to detail of the things that we don't show visitors when they come to our hospitals. Everyone wants to show the shiny new ward or the new machine, or here's the renal unit, it's wonderful. What we don't want to show them is, here's a unit that we're almost embarrassed about. Here's a unit that, to be honest, I wouldn't want any of my children or family to be treated there. And until we have those authentic conversations, and until we realise that, and I don't want to talk in spiritual language, but a spiritual analogy is, until you have answered a call from God, from a philosophical driver, that you are to be a different person, someone who has put aside your personal ego and success to become someone who concentrates on the success of others, then you will never be a great leader, your ward will never be great, and if you get lots and lots of those in one hospital, maybe somewhere in the world there will be a good hospital one day.
No, thank you, Dr. Mark. I think this is pretty well said. I take away that maybe the personal transformation is probably the first step as we look towards building a new leadership. Yeah. So moving on, Dr. Atul, our leadership has taken multiple reform initiatives right now as we look into the new healthcare ecosystem. We have PMJY that was started in 2018. Now we have ABDM. Before that we had PM Abhim also, and multiple other initiatives. In fact, this is not only by the central government, many of the state government have also expanded. And we have many of the state health schemes covering in the India right now. Now, where do you think that the accreditation fits into this larger set of national initiatives being taken? How do you think that we can ensure that accreditation is a part of the national discourse and is adopted by all the central and the state government national programs?
Yeah, thank you, Dr. Ashwini. In fact, over the past few years, we have seen a very pragmatic tandem shift as far as healthcare is concerned. And we have noticed that traditionally, health has been a concurrent list subject, which is a state subject. We are a federal structure. So we are moving very slowly from a state-dependent healthcare model to a partially centrally funded or partially centrally governed kind of a model. We've seen lots of synergy, lots of central flow of schemes, and I think the main thing responsible for that is the ABDM, PMJ, which is there. So earlier there were many states working in isolation. Now there is a central coherent kind of a language and a discourse which is flowing that we all need to follow certain basic tenets which are extremely critical to the life of a common man. And towards that, I think that's a very positive thing. And that's where the change is going to be. Once we have seen PMJ, we have seen ABDM, and now we also see that there are centrally funded HMIS and LIMS which are being made, which are being validated, and which will be provided in free domain. So that what one state does is not in isolation with another. So lots of coherence is going to be there. And that coherence is good for all of us. That's going to provide the interoperability between state. And I would just like to add to what Mark said so wonderfully, that Mark, you are in the land of spiritualism and the leadership. I truly believe that what you see today here, about 2,000 of these, there's a leader in each one of them. And that's the USP of India. Technology, of course, we are good at. Technology, of course, is being disseminated far and wide. But these people, they work the midnight oil. Despite all constraints, they take care of our patients, their patients, our patients, with lots of empathy, lots of personal connect, and lots of being on the toes all the time, because that gap is there. And I think we can all have a huge round of applause for ourselves, because and that formal leading structure with lots of inspiration. I was just speaking to Dr. Sandhya Shankar Pandey from Fortis, and she said how their institute, the Fortis group, for example, I mean, I'm sure every other group is also doing that. They have now picked up, based on psychometrics, top leaders in their field, and they are sponsoring for the highest, and one-on-one apprenticeship also. I'm sure every big group does that. So I think what you said is so very relevant. That's not about what the collective ecosystem is. That, of course, is important, but it's also very important to vouch for yourself, look within yourself, and be that leader you are expected to be. Because every person who has chosen healthcare, whatever field, whether you are a clinician or a nursing officer or even a ward boy, they have that little spark of empathy and caring worldwide. So they've chosen healthcare, they've chosen to be there. So they're the leader in them, which we need to hone and shine. Thank you.
No, thank you, sir. Thank you. I think very rightly said, there's a leader in probably all of us. And so, yeah, there's a leader in all of us. And as we look forward, as we probably drive in the new ecosystem, there is a need to harness that particular leadership pattern and pull it out. Yeah. Moving on. Dr. Kal, we believe that accreditation should be a continuous supportive process, and it should never be a penalizing process to begin with. In the context of India, where the landscape is dotted with many smaller hospitals, we may find that many of them may not even have a formal quality control department. Now, in this kind of an ecosystem, what role do you think the accreditation agency should play to provide technical assistance to these hospitals? What kind of a role they can play over here? Dr. Kal.
Thank you for the question. I think it's very important to frame the right narrative about accreditation. Accreditation is different from regulation in the sense that regulators say you must meet this in order to be able to exist. Accreditors say we want to take you there. And people start from different levels, but we must frame the narrative and the way in which we structure our awards system in a way that recognizes progress rather than recognizes the distance from where you are to the very top level. Of course, you should be aware of that to have something, to have a beacon to go for, but you must be acknowledged for your progress. And as I understand it, that's exactly what you are trying to achieve by creating your entry-level accreditation. Now, what kind of support can we give? I think, and we, in my home country, Denmark, we have experience from accrediting both big and small, very small organizations. In big organizations, it is natural that quality management is somehow bureaucratized. There are quality departments, quality managers, and the challenge here is, of course, that we should not see quality as something the quality department takes care of while the rest of us do the work. In a small organization, I think it's important to avoid bureaucratization of quality. There may be tasks that are allocated to specific persons, but quality should really be a topic for conversation in a team that in the very smallest organizations are actually only one team, or in a little bit bigger organization, a couple of teams. It is difficult for accreditation organizations to provide direct support to individual organizations for independence of accreditation reasons. There must be firewalls between those who accredit you and those who support you in your journal. You can't have someone accredit what they have supported themselves. But you can provide a lot of generic tools, and you can create partnerships with local organizations that bring together a group of smaller organizations to support them in their journey, to make sure that the supporting organization understands the accreditation requirements and understands the accreditation journey. And we have experience in Denmark in establishing those kind of systems, and we have found they work. And it is true that especially for the small, isolated hospitals, it's very important that they feel that they are supported and they are guided on their journey, while being allowed to find their ways and integrate it into their own DNA. And one final remark, where I go back to what has been said before, I think it's very important when we're talking about systems that the leaders see themselves not only as leaders in their own organization, but as partners in a greater system. And it's, of course, important for those at the very top that they ensure that there are no negative incentives for the individual organizations to act in a way that is to the benefit of the system as a whole. And this is unfortunately not always the case.
If I could please make a comment on that, because I really like the way you said that. Obviously, as I mentioned, my background was originally in a very remote, small town. So I have the privilege of leading the new healthcare leadership program, executive education at the Oxford Business School. And we did some work asking healthcare leaders across many countries and cultures, what do they want, what do they need? And they identified, apart from that personal transformation I spoke about, 4 key areas: how to formulate strategy appropriate for their country, their organisation, how to drive innovation, and particularly how to govern innovation. Innovation is not an end, innovation is a tool to deliver a result. And I get very worried because I hear a lot of conversations in healthcare suggesting that innovation is a goal in itself. And I think we have to be very careful to make sure that innovation delivers the value that the resources we allocate are delivered. The third thing people wanted to know about was how to increase the performance of their team. And the fourth thing was how to make sense of the digital ecosystem, which for many healthcare leaders is completely overwhelming. They are not digital natives. They didn't grow up with the digital ecosystem, and they are struggling with that. And so when we come to accreditation and the whole way in which we approach improvement, while I've spoken about the personal transformation journey, there is a very technical element to this as well. And what we're seeing, I think, one of the biggest challenges I'm seeing in leadership across countries is not recognising that the type of work we do in healthcare, to borrow from David Snowden's model of complexity, is we actually do 3 different types of work. We do linear work, we do complicated work, which is algorithmical, but most importantly, we do complex adaptive work, where, and the analogy that I use, I'm a very simple person, I use simple models, but I imagine an 82-year-old lady who breaks her hip. She has early dementia, she has diabetes, and she has heart failure. What is a good result? If she wants to die, what is a good result? A peaceful death. If her son is the professor of medicine saying, "You must save my mother," what is a good result? So we see increasingly across healthcare this complex adaptive work, and how I define it as, this is where we start work not even knowing what result we're trying to achieve, with no idea where we're going to end up. Now, airlines don't run that way. Airlines do not take off and after 20 minutes say, I wonder where we're going to go. I wonder what we can do with all this fuel we've got. Most of our people at the coalface are starting work, particularly in complex areas like psychiatry, geriatrics, emergency medicine. They are actually flying the plane without even knowing what the destination is, and even how much fuel they've got on board, and which engine is going to fail today. Or in fact, do we have any pilots? So we cannot use algorithmical, complicated models from industries like the nuclear industry or aviation solely as the way in which to prepare leaders. And I see the biggest failures in implementation and performance are essentially inexperienced leaders using the strategies that you would use in complicated algorithmical work in complex adaptive work, and it just doesn't work. And it comes back to that personal transformation. Complex adaptive work is done best by leaders who are good listeners, who do not have big egos, who are actually uncomfortable with uncertainty. And one of the things about our technical training, particularly for us as those who are doctors and nurses, we are trained to a high level to eliminate uncertainty in our work. If you become a great leader, particularly in complex adaptive work, you have to become very comfortable again with high levels of uncertainty. And an inexperienced imposition of certainty onto complex adaptive systems leads to malfunction. It leads to workforce burnout. Another way of saying it is that we lose wisdom. We end up being an experiential knowledge-based system without anyone sitting up on the balcony saying, is what we're doing today wise? Given the resources that we have, is this a wise way to conduct ourselves? And I'll finish with my last challenge is, and I would put this to your systems and to your hospitals, are you running a health system or a disease system? And in the way you lead, are you leading healthy workers or are you creating diseased workers? Is the style of leadership, is your technical ability in this area of managing complexity high enough so that you are not burning people out, so that you are not causing trauma and harm to the people you lead? And so this is, for me, is the great challenge of leadership, not just to be technically good, but to be a wise leader of those you lead who can actually conceptualize what outcomes we are trying to achieve and is very, very comfortable with the fact that you will never go to work as a healthcare leader with the certainty that someone goes to work with in Air India or at GE Nuclear. So that would be.
Thank you very much. Sorry, yeah.
I love your example of the 82-year-old lady, and that reminds me that one question I think you should remember as clinician is the question I mentioned, what matters to you? That should be part of every conversation with every patient. You might phrase it in different ways, but you need to clarify that. Once that is clarified, then the response might be that you begin to fix some broken parts, but you shouldn't start with looking at and assuming that here are some broken parts, it's my job to find and fix them.
I think that's a wonderful example which you gave. And complex adaptive work is the take-home message today. Because standards or algorithms can no way outshine the basic common sense or what you are, the basic tenets that primum non nocere, first do no harm, or basic care. And Mark, India is the land of frugal innovation. Here we only call it as jugaad. And our textbooks are full of that, full of patents, local things. So I think, but there's a lot to be said for what example you gave. Thank you.
Thank you, sir. Thank you very much. I think this has been a real eye-opener for me. I have some more questions actually, but I'm being told that time is up. So I would just like to say thank you to all my panelists for coming over here and sharing their experiences. It has been an absolute pleasure hosting all of you. Thank you very much. Thank you.
Thank you everyone. If you have any questions for our panelists, they'll be around during the networking event. Please feel free to reach out to them. We'll move into our next session, which is Spotlight the Top Care. It's a very exciting session. And we have heard the torchbearers of the healthcare industry, the influencers, speak to us about their hard work, their vision. Now let's get to know what is behind the curtains. A little sneak peek into their personalities, into the personal fronts of our speakers. So I'll welcome on stage Mr. Gaurav Gloria to take this session ahead. And we have with us a panel of guests for the talk show. May I request Dr. Roos, Dr. Kocher, and Dr. Aarti Verma to join us on stage, please.
Mr. Gaurav Loria, Group Chief Quality Officer and Head Operations, Senior Vice President, Apollo Hospitals Group. A senior healthcare executive with over 16 years of experience. He has led more than 35 real-time JCI and more than 60 real-time NABH surveys at various hospitals.
Can I have Mr. Gaurav Gloria on stage, please? Request you to take the session forward. Give me 1 second.
A very good afternoon to you all. So today, this kind of a format, we are doing it for the first time in the last 9 years of the conference. We just thought, let's get a little sneak peek or understand a little bit more about the vision, about some of the personal interests, some of the personal understandings of these three eminent personalities that I would like to invite on the stage to join me, please. Dr. Roos, if you could please come on the stage. Dr. Kocher, if you could please come on the stage. And Dr. Aarti Verma, please, you're most welcome to join all of us on the stage. I think I'm going to need this. Please have a seat. Please, sir. So before starting on this format, I would just like to brief you about the structure and the format. So we'll have Q&A with each of these personalities for about 10 minutes. The section is divided somewhere into talking a little bit about their vision, their understanding for the first 4 minutes, followed by a personal questions for the next 3 minutes, and the last 3 minutes kind of a rapid fire where we'll see how they answer and how they perform. However, I don't have any gift or any gift hamper to be given to them, as you would have seen in our other talk shows. But we would, the more we know about them, because I'm sure we know each one of them very closely. We have met with them, spoken with them in some of the other platforms or some of the other forums, but we have always been eager to know a little bit more about them. So starting with Dr. Roos, we have prepared one AV on him. So can we quickly have the AV, please? One of the things, before I get into the Q&A also, I would like to tell you that all three of them are definitely not social media friendly, because it was a real challenge for us to even pull out something about them from the social media. So I'm sure if we couldn't do it after so much of hard work over the last 30 days, you know, I don't think anybody else would know more. So let's get into it. So Dr. Roos, the first thing, you know, when you speak with organizations about JCI accreditation, and you know, when you sell accreditation as a product to them, what are the top 3 things that you talk about them? Like, you know, how do you think it really helps them, or what are the top 3 things you do?
So I try hard not to sell anything.
Okay.
I try to, you know, as a leader, I try to create a vision and explain benefits. I leave it to my sales team to sell. No, I think that's important as from my perspective. But highlighting the, you know, the importance of accreditation in terms of improving as a tool, not an end state, for improving quality and patient safety for everybody that walks in the door of a facility. And then there's different ways that applies, and you actually heard a great presentation right before this, so I won't belabor it, but that's really what I focus on.
But if there are 3 things that, you know, let's say not JCI or NABH or any other accreditation, but what are the 3 things that people should, you know, it helps people?
Well, if I understand, you know, the 3 things that I think that are really required for improving the quality and the patient safety and the like, I could boil it down to 3 things. And the first one is leadership. That's the easy one. The second, though, is teamwork. And the third is having a quality improvement program. And there's many different quality improvement programs and tools and techniques out there. I'm not going to say one is better than the other, but choose one. But leadership, creating the vision, particularly about, you know, patient safety, a culture of safety. Everything else will fail if you do not have leadership and hands-on, visible, interacting with your staff.
Sure, thanks. The cost of healthcare has been seen increasing year on year, and especially post-pandemic, it's become even more. So what are your views on how accreditation and cost of healthcare, you know, how are they interrelated, or is there a comparison, or is there even a relationship between these?
So we're all facing staffing crises, we're facing COVID crisis, and yes, healthcare is getting more expensive, reimbursement rates are dropping, and you have inflation. But, and accreditation is expensive, and it doesn't matter which one you choose, some are more than other, but there's the investment of time and resources and paying for that. But I would argue when you have higher staff turnover and less staff, that adopting mechanisms to ensure quality and patient safety are cost effective. They're very difficult to measure, but if you want to make sure you're doing the right things regardless of the new nurse that's coming in after you've had that turnover, there's tremendous value there, and we've not done a great job in any organization capturing that, but I would say that's the relationship.
Great, thank you. What techniques, methodologies, tools, or resources, you know, you would advise that need to be used, or you would have used, to ensure a very reliable and a safe healthcare delivery system?
So I've touched on some of them, and one is making sure, as a leader, and I have led large organization and large facility, is making sure everybody is involved, everybody is on board, and really creating the culture of safety, which takes work day in and day out, because it's really easy to slip back and criticize the junior person, you know, you did what? To the congressman's wife? And versus what did we learn from it? You know, and thank you for letting us know, and that sort of thing. That is really, really important, because with that, you can't build anything without it.
Thank you. We move on to the next section quickly. As you would have served about 30 years in US Navy, and you know, I'm sure you would have also received JCI surveys and you would have undergone them at the forefront. So in comparison to your position where you are now, let's leave that aside. But then when you were at the forefront facing the surveys, what were the biggest challenges that you faced?
Well, I will share the biggest, but I laugh a little because as over 30 years, I went from a resident to, you know, junior faculty, chairman, and, you know, I was on very much a leadership track that you described. Initially, I was the person that would be duct taped and locked in a closet when Joint Commission came, because the hospital was afraid to let me talk to people. I matured over time, and that changed. The biggest challenge I ever had is running our facility. I've talked to many people here in India and other countries. They talk about nursing turnover, the like. Imagine walking into your hospital one day and told 1/3 of your staff will be gone in a week. That's the challenge. And that's a true story. It happened multiple times for deployments. I supported the Mercy. And yet, with that turnover, you were expected, remember, accreditation, and you're always accreditation ready. Doesn't matter which organization, you're expected to maintain that same level of quality and patient safety, and to create a system where you can get new people immediately in, have them trained up and familiarized so that quality and safety doesn't drop. So I'm very attuned to the challenges you face. I've just had to do it on a much quicker scale, and that's the biggest.
I think I'll also agree with the first bit of your point that you raised. We have seen that during a lot of our accreditation, sometimes, you have those senior doctors, nurses, administrators, they just take leave and they go away because they don't want to face the surveyor or to answer any questions. So that's the easiest way to go around. Okay. Can you describe a time, when any action that happened would have had any unintended consequences? So, what happened and how did you kind of manage this?
Yeah, I'll go on, I can't think of an example when I looked at those questions. However, what I will, and there were plenty of them, so I want to say it was perfect. I think the bigger point to that, though, is as a leader being to admit and be willing that you were wrong and made a mistake. Probably if I had one, I hired the wrong person for a job and I had to replace them. But willing to say, this wasn't the right call or the right decision, and moving back and changing your decision, but also admitting it. I think, it takes a certain amount of humility as a leader to do that, but it pays off in the long run. So not quite what you asked, but I think equally important.
Okay, so if I have to ask you a last question on this, in this category, what's the biggest decision you would have made on a personal front in the last 1 year?
So my belief is people are everything. You can have great standards, you can have a great organization, but your organization isn't anything without the right people in the right job. So I would say the recently hired person for a position, and I would say in the last year that'd be one of the bigger decisions because it affects a lot of people and affects your organization for the long run.
Okay, so if I have to ask the audience here, how many of you would have gone through any one survey, where you have faced the survey on ground? Can you just raise your hands? Okay. Did you undergo any stress during that surveys or any of those surveys that you faced, or was it like smooth? So how many for stress? All of them. Okay. So I am representing all of you, and I'm going to take that revenge. Okay. So let's give them this this set of rapid fire questions, and let's see how do they perform under a stress test. Okay. This is the first stress set of questions goes to Dr. Roos. One morning you wake up as a superhero. What is the first thing you'll do?
Work on world hunger. But I'm going to need 7 days, just like they created the earth. There's a lot of things to tackle.
Okay. If you wouldn't be in this profession, what would you have been doing?
Marine biologist.
Wow. Tell me something that is true that almost nobody agrees on.
I'm always right, so it's going to be on sports and baseball and who's a better player.
What's one of the qualities you admire the most in others?
The ability to sit back and listen without opening their mouths and take it all in.
Okay.
You can see it doesn't work for me.
If you could have a gigantic billboard anywhere with anything on it, what would it say?
Something to the effect of, let's celebrate and cherish the differences among ourselves instead of fighting over and killing each other over it. And that comes from the perspective of...
Yeah, I think that's profound. That's amazing. Thank you. One fictional character that you would like to meet?
James Bond.
Okay. One piece of advice you would like to give to your younger self?
Enjoy life, stop and smell the roses, and don't be so serious going through.
I think that should be a learning for many of us.
The phrase, the expression in the US is youth is wasted on the young.
If you have to choose being an administrator or a physician?
Physician, even though that choice was sort of made for me later, but.
President of United States or Dr. Joel Roos?
Dr. Joel Roos, that's easy.
Who is your role model? And if you have a chance to meet him or her, what would you say?
Thank you. I have many mentors across my career, very senior people who have taken the time to invest in me and correct my mistakes over time. And you never, while you appreciate it, you never get a chance to thank them enough.
Thank you. I think that was amazing. He definitely deserves a big round of applause for being very sportive. So thank you so much for all those answers. We move on to our next eminent personality, Dr. Atul Mohan Kochar. I think at least each one of us who is sitting here would have somewhere or the other come in, connect with him for either of the accreditation, or we would have had him, here on any of the platforms. Yesterday when he was on the stage, he said, one of the questions that he was asking, what's been your experience that, NABH is bad or the CEO is rude. But then I would personally like to say that definitely, I think, sir, you are one of the sweetest persons. And I don't think definitely there's any rudeness around it for sure. So with that, I would like to start with the first question to you. 1.4 billion people in India, challenges in terms of awareness and times in healthcare, and many are still not aware of the benefits of NABH. What are the 3 things you think NABH should do and will do to increase the awareness about NABH?
Thank you all. I think the revenge has already begun with the throat. No, I think we have to reach out to the last in the line. And that's a mandate we have not been able to fulfill, and we are trying our utmost to do. So over the next few months, you will definitely see how we reach at a district level, a block level, and then we are really working hard to go back to the drawing board and move beyond the standard, the islands of excellence. So we are very proud today. We touch 15,000 hospitals. We are very proud that 1,500 of them are multi-speciality large hospitals, but we need to make people aware about, for example, as basic as hand hygiene, communication safety, medication safety. So we have to, all the patient safety goals, WHO 7, we have to reach out to the far-flung, wide nooks and corners of the country and take it there.
I think very key and important points, sir. Thank you, sir. There are number of hospitals, and I know that this point was discussed in the previous sessions as well. That there are a number of hospitals that don't have the adequate infrastructure or systems to have any form of accreditation. If you could just specify and be more specific on identifying top 2 or 3 things that they should start doing to be a part of the NABH family.
Exactly. I think that's a very valid question. So we are working towards that again. And government is working towards that to have certain basic things in place. And the ABDM is going to show that. For example, many hospitals do not have a basic registration mechanism, the UHID. They don't have that. So that ABHA number is a small step in that direction. Very soon you will see that thousands and millions of people will get their ABHA number. And with that unique ID, the things will start happen. For example, in US, you have a social security number, which controls and governs all. So we've had a Aadhaar, but somehow for the healthcare, we have not been able to have one unique ID, over which you can layer up, over which you can build up. So I think that's a small step we are aiming for.
Great, sir. Thank you. So electronic health record is another challenge that we face in India. At least from the hospital end, we know that how challenging it is to, get people, especially the doctors, the nurses, to start using electronic health records, move away from paper. So what do you think could be done in, getting electronic health records implemented across different organizations, different levels of organization in the country?
Fantastic. See, all the big hospitals do not have a challenge there. All of them invest a lot in multi-modular EMR. including ERP, etc., etc. But now Government of India, under the ABDM, they have brought together, they have created a sandbox. In that sandbox, there are already about 1,000-odd solutions, which are private players, but which are being validated by NABH. So all these softwares are being validated by NABH. Already pilots are being held, already 10 have been validated, and Government of India is also providing, I think these are up for public comments on their portal, free HMIS and free LMIS. These are very basic, but any hospital which wishes to make use of them, I think these free softwares, including the best industry standard encryption, industry standard certifications, they will be available free of charge. So I think that's a game-changing step for all of us.
Sure, sir. So we'll move on to the next section. In your opinion, what is that one thing that could be added to improve safety culture across the globe?
Across the globe? Make NABH mandatory across the globe.
That's a great selling point, though. Can you think of an example or of a situation where you had to identify or manage a clinical incident or a risk? So what exactly happened and how did you go about it?
So practically every day, every clinician does that. So I'm a dermatologist, so essentially as part of a medical college, you come across on a daily basis. And these are very important game-changing things which should motivate you. So as has been said multiple times during various sessions, even when we identify, the blame culture should not be there. It should be an enabling environment. It should be a very encouraging structure so that people can come up and tell them that, see, this happened, this near miss happened, or this near harm happened, or harm happened, but what can we do so that this does not get repeated? That's very, and that's the basic purpose of any standard, whether JCI or whether NABH or whatever.
So according to you, what is that one form of, or the best way of communication within an organization that the organization should use?
So gossip is number one, which is rapid fire, right? No, but there are many forms of communication. I think I think the leadership connect. In the earlier session, Mark very rightly said we need to have hands-on leaders who think beyond the algorithm, who think beyond the SOP. SOP, of course, are important. Standards, of course, are important. But that the basic common sense, the culture flows from a core group, and everybody should join in. It's just like Avatar movie, you know. It's the energy which flows in, and one must tap onto it.
From being a dermatologist to being a quality guru and a professional, driving the whole nation towards quality and being somewhere or the other directly or indirectly responsible for it, how much do you think you would have achieved?
So a guru is not always a positive thing in India. Ye to guru hai. No, I don't count myself as a guru. So derma is a passion, of course, and quality is also a passion now. So I think you have to have that balance. I think there's a Daniel Craig effect. So I think we are still starting out. We are just finding our feet in the realm of quality. And we have so much to learn from our grand old organizations like JCI or ACHS. And for all of us, I think there's wonderful learning. And every time we attend and meet people, I think that's the biggest learning. There's so many takeaways.
Well said, sir. Thank you. We move on to the last session on the stress test for you. What does great leadership look like to you?
Great leadership. So as I said earlier, every person, I mean, it looks like you, Gaurav, looks like Dr. Pratap Reddy, looks like every person in this hall. I see so many leaders here. In fact, all of them, there's a leader in each of them. And every day, if we would just tune our ears and listen to them, there's a huge leadership in all of us.
An example of using your experience to influence your decision making.
So many experiences. So every day in a clinician's journey is an experience. For example, you sit in an OPD, you see 100 patients or 150. Each one tells you. And each experience with NABH hospitals also tell us about what the ground realities are. So I truly believe that every day. So, for example, as I've said earlier, first time any hospital goes and invests in a NABH certificate or a JCI, it's for the incentive, it's for that, just because it's there. But then they slowly start realizing the importance of following any standard, which is extremely important. The outcomes start becoming, improving, the staff is happier, I hope so. And then all your data is at fingertips. And ultimately, it's not only patient safety, it's staff safety also, it is facility safety also. Overall, it's a very good thing to go for that.
You're on a deserted island. Which is that one app on your phone you would miss the most?
I think Blinkit or something. No, but I think it's the TEDx. I'm very fond of TED Talks. So every day during commute, I make it a point to listen to varying. And these are the true experts who convey in a very crisp manner some wonderful. So everybody should, find time, those 15, 18 odd minutes, to listen to one TED Talk across, not only related to your subject, but to any subject.
One morning you wake up, you realize that you're the Prime Minister of India. What's the one thing you would like to do?
I think the current one is doing a good job. I'll delegate it. That's what CEOs do. They delegate,
Which job in your overall career contributed the most to build your expertise? Or which phase of your career?
So the core training always matters, so the MBBS, the MD. So these are experiences, these are life experiences. And admin is part of everybody's job. So, so that core is always very important. But like Dr. Ruth said, there are so many mentors, so many guiding forces which influence you, which improve you every day, day by day.
What is that one thing you do not forget when going to office every day?
Can I tell a story?
Please.
Okay. Please bear with me. If you've listened to a similar one, it's important and worth repeating. Every time I reach office, and many times for my officers also, I tell them, this is the story of a Maharaja, and Mark, you would find it very interesting. Maharaja, who was very fond of cars. So he invested in a Rolls Royce, and this Rolls Royce arrived, and he drove it around and had real fun. He smelled the roses in them. He went he lived up in that car. 1 year, 2 years, 10 years, he ran that car beautifully, enjoyed everything. One fine morning, that car stopped. It stopped. So Rolls Royce Phantom Ghost, for example, the engine comes sealed. So he was very worried. So there's no local know-how. He calls the engineer from London. He visits India. He comes here, he opens that with his special keys, and he says, Your Royal Highness, there's some error. It's a huge error. I don't know how, but there is no engine in the car. So obviously he's saying, you're making a fool out of me. I'm a Maharaja. I also know that cars run on engines, and I've been driving it for 10 years. So why has this stopped now? Tell me. He says, Your Royal Highness, this is a Rolls Royce. 8-10 साल तो ये reputation पे ही चल जाती है. So that's the story I am very fond of. I tell all the officers, and I think every leader should tell their officers also. So the organizations we work for example, NABH for me, has been built on hard work, dedication, sweat and toil, and basic foundations of integrity, hard work by our forefathers. Apollo, for example, or JCI, for example. We have to put in double the effort to stay where we are. Even if we do nothing, it will keep running on its reputation, even if we do nothing. But one day, without substance, without change, without positive change, they are going to stop. Yeah. And we should not forget that. So we must do our bit day by day, every way, in a small way, that small incremental habits, that atomic habits.
Great story, sir. Thank you for that. 2 things that you would look for while picking up anybody for your team?
I think integrity is extremely important. So anybody who comes for an interview, they are technically by and large same, by and large. But integrity is absolutely a core area. And then that passion for work, integrity and passion should be there.
So we do have some few students also in the crowd. So anybody who is approaching him, know now when you go for an interview, what is he looking for? So watch it out. My last question to you, one thing that you would want to say to your younger generation working towards patient safety?
So can I tell another story?
Please.
So this is not rehearsed, I mean. So today is Valentine's Day, right? So nearly 25 years back, there was a girl who gave me a card. It was a greeting card. How many of you know what is a greeting card? Okay, thank you. So this is something which actually is in a paper, not a SMS or something. And it was a Hallmark greeting card brought from Archie's. And on it was written, keep dreaming, keep believing, have a rainbow in your heart. Keep dreaming, keep believing, have a rainbow in your heart. So that girl is my wife today and and she shows me a rainbow every day. No, but that's the message actually. So all of you are youngsters, many of you are youngsters. So every day you go to work, you work hard, and every day you'll get a lashing also, possibly. But keep dreaming. And I think the theme of the conference here today is dream, dare, design. I would like to add that believe also. Because if you believe, you can change the world. And India really needs youngsters like you. So I think there's a huge potential in this hall, in this country, in this world. And I think just keep dreaming, believing, and dare to design. Thank you.
Thank you, sir. And I think he deserves a big round of applause for being so sportive. Can we have the AV on Dr. Kochhar, please?
That's a 20-year-old photo. I keep using it.
You have not uploaded more photos. Thank you. We move on to our last guest for today's Stop Gear show, Dr. Aarti Verma. So can we have her AV as well? Thank you. So we start with you, Dr. Verma. We all talk about being patient-centric. What do you think that one thing that patient actually cares about?
Yeah, thank you, Gaurav. Yeah, I think patients really care about being treated as a human being, not a number in the hospital, and that somebody is there to listen to them, somebody is there to hold their hand, and replace that loving, caring family member who is not with them right now to take care. So we have to actually become their surrogate family members when we are taking care of that. That is most important.
I completely agree with you, and I think rather than a number, more than that, a bed number or a room number.
Yeah, not
because
even that.
most of the times we hear that, this bed number patient, that bed number patient. So I think that really makes a lot of difference. Any example in your experience that helped you to learn accurate delivery of reliable healthcare safety and quality outcomes?
That's a very, very obvious answer to that. My journey of understanding safety and quality began with NABH, and I was lucky enough to be part of the team to develop the standards and to implement them in my hospital. And the learning that it gave me, reading the standards, interpreting it, implementing them on ground. We didn't have any guides. We didn't have any consultants to guide us. We had to learn, read, learn, interpret. It gave us a complete systems overview of how to bring in a framework that helps us. And there's no looking back from NABH. I think NABH is our Bible. So that is one thing that I say. Of course, on a day-to-day basis, there are numerous examples that we face, but this was at a very wide system level, and it changed my life.
Well said, thank you. Can you think of a situation when you needed to support senior leaders to balance safety and efficiency to achieve reliable quality care, and what was the actual challenge?
Many times. In fact, it's a continuous activity, it's part of our job. But some of the good examples we've had where we faced very, very difficult challenges in the beginning was physician engagement, especially with doing mortality audits and clinical audits. They all felt there was no culture for that in the organization, in the country. They felt very threatened. Their egos, their professional boundaries were threatened, their peer respect. So there were all sorts of issues. We've even faced doctors walking out of the room when we wanted to introduce a system of audits in our organization. But I think one of the best things that helped us was that our medical director, he became a role model, and he said, he's a practicing doctor, so he said, please bring in my patient files as I will set the example. And there's no title involved in this. We are all humans and we cannot deliver perfect care. So the messaging went out very, very clearly that it's about learning. It's not about personal insult to anybody, and looking at opportunities to learn for everybody. It's not today it's my case, tomorrow it may be your case. So leave the titles at the door, and that's the thing that we have been inculcating, and very successfully now. We're proud to say that in our organization we have a very strong culture of transparency and no blame. So this was one of the things which we feel very proud of making strides in getting our doctors involved in the quality process.
Something similar related to just an extension of that question maybe. You have been on both the sides on medical and quality, and I think, we also sometimes face that challenge because everybody thinks that quality is quality's job. Sometimes it happens, again, it depends on the leadership, how does it work? But then what would be your take on that?
You're absolutely correct. It's a never-ending, journey. Quality ownership still resides with the quality teams, 100%. And it's a continuous exercise of engaging and getting more and more frontline workers and doctors, to introduce it and make it their DNA. But when they do make it their DNA, it's fantastic.
Yeah, I think that's really matters and makes the whole difference. As a senior vice president, you have to face many challenges. What were the early setbacks that actually later gave you an advantage?
Of course, the value of accreditation, the value of doing something for quality, Fortunately, I've had very good innings in my profession, so I'm not generalizing, I'm making it personal. I was working with the Indian Army, where the Army is very standardized and very protocolized, and you just follow. Of course, you don't lead. That was one of the biggest challenges of the Army, that you have to follow what is written down. You can't be too creative or take initiatives to do things better. But in terms of quality orientation, that was a great advantage for me, and that helped me in my later years of work. Similarly, in the organization that I joined the organization when it was on a piece of paper, and it was just a vision. And I was in a very stable job, and I said, I need to join this organization because I align with the vision. Everybody said, why are you leaving a good job? You don't even know whether this organization will survive for a year or two. The passion just got me, And the chairman, the board of directors of that organization said quality first, business later.
Yeah, I get it. Yeah, it's very important. If you have any specific book, magazine, or a podcast that you would recommend to the audience to continue their learning, what would that be?
So, I have done a lot of reading on very common sites, but I find them fantastic. I love reading the IHI updates. I find them very practical. The case studies that they give and whatever material they give is very easy to read and interpret. So it's not all theory and context. So I would encourage everybody to keep in touch. Keep in touch with National Patient Safety Agency, their websites. Books, of course, National Academies Press takes out some very good books. The Quality Chasm, reading about long-term care. So many topics are there. And for developing countries, they allow, a free PDF download of those books. So very worthwhile as part of our learning. And of course, there are very credible other sources. WHO has some fantastic publications, although they are more at policy level, but still worth it to go through all of these. Joint Commission takes out some very good alerts, so keep in touch. The journals are very interesting in quality and safety, BMJ. Those are the things that we should keep in touch with.
And please add our book that we released today onto this list.
Sure. I
was going to say that.
You can mark it down. Once more.
So we move on to the last section with you. So, I have seen you attending so many conferences or interview sessions. What's this one or the strangest question that someone asked you during an interview?
When I was interviewing to join my medical college, somebody asked me, why are you so thin? I was all of 33 kilos. I didn't have an answer.
One piece of advice you would give yourself, of 10 years ago?
Take more time out and follow a hobby, a personal hobby, whether it's painting or it's a sport. Don't give yourself up to your work. Which I did.
So I think if out of 3, at least 2 of them are saying the same thing, I think it's very important and critical to note that. I would ask you a similar question that I asked her. You are on a deserted island. Which app you would miss the most?
WhatsApp.
Okay. The biggest misconception about your work?
That I'm indispensable.
Okay.
About any work also, I also feel is fixed. Long hours are not as productive as result-oriented hours.
Yeah, so and I think in the Indian way of working, that's something which is very important for
we need to change that.
Everybody to understand that,
especially in
probably
India.
Including me also.
Yeah.
Do you have a secret talent that no one knows about?
Yeah, I love sketching very badly, but
I was really hoping you say singing, and we will request you to just sing now.
Do a sketch of you.
If you could just snap your fingers and become an expert at something, what would that be?
Oh, I would love to be a fantastic dancer.
Wow. Okay. How well have you maintained a positive work-life balance throughout it all?
Not at all.
Any one piece of advice for everybody?
Must take time out. Your family is the most important thing in this world, not just your professional success. And how do you define happiness? Success and what is your personal level of success is not, you don't have to follow and be in a rat race. You have to define your personal level of happiness and success and go for it.
Which fictional character you would most like to meet?
Oh, I loved Dennis the Menace.
Whom do you look up to for inspiration or mentorship?
At a personal level, my father has been the best mentor in my life. At a professional level, many. But if I were to just off the racks mention Dr. Parvez Ahmed, Dr. Girdhar Gyani, Dr. Narottam Puri, they have really mentored me and shaped me as a professional. Thank
Great.
you very much to all three.
My last question to you, you are given 3 superpowers. What would you want to have?
Yeah, I would love to fly like Superwoman.
Okay.
I'd love to have magical powers to be able to remove poverty and hunger. My heart goes out to the underprivileged. That's core to me. So I'd like to remove all that and bring them, give everybody a better life. And the third would be a super healer.
Great. So thank you so much. Can we have a big round of applause for her as well? I think all 3 of them have been amazing. So let's do this quickly. Let's assume I have a virtual gift hamper. Okay? So who should it go to? So I'll just take the names, and if you could just make noise. So let's see who gets the virtual gift hamper. Dr. Roos.
The lady gets it.
Okay, Dr. Kochar. And Dr. Aarti Verma. Okay, so let's say I'm also on this side. Okay, so how many for me to get the virtual hamper? Okay, great. So finally nobody gets the virtual hamper. I think all 3 of them were great. Thank you so much for being sportive, for taking up this session. I hope all of you had fun and learned some nicer things and good things from each one of these senior experts and healthcare professionals. Thank you so much. Thank you. Thank you so much. Thank you so much, sir. Thank you. Thank you. We'll just have a picture.
Thank you so much. That was a nice break and a nice twist in the plot, Gaurav. You should keep doing more of these. It's nice to know the other side of them. Okay, so very quickly, we have a session to finish before we break for lunch. And it is my pleasure to introduce Mr. Landry Gillishon. Can you please come on the stage? Thank you. So you are in the business of, sorry, let me just do this again. Mr. Landry Gillishon, I hope I get that right, yeah? Is a Global Business Development Manager of the Customer Segments Care and Business to Business for Electrolux Professional. You've been in the laundry industry for 25 years and you've instigated significant breakthroughs with the implementation of several laundry cycle management concept in many markets. And there's quite a lot here. And in your current position, you bring to the markets innovative laundry solutions that will enable optimum hygiene easily and durably while ensuring maximum profitability. That sounds very interesting. So you're going to talk on fundamental hygiene. That's great. Go for it. Thank you so much. This one. So once your presentation comes on, just do the green one and it'll move.
This one.
Yeah. And have you got a hand mic? You want a hand mic?
Cleanliness is next to godliness.
When it comes to hygiene, there is no room to compromise. Nurses, doctors and other healthcare staff using linen within various departments and wards take for granted that the linen is clean and safe in any circumstances and for any patients. But there is an essential difference between visibly clean and hygienically clean. In healthcare institutions where infection outbreaks can put lives on the line, why risk contamination? Gain full control over your linen hygiene with Electrolux Barrier Laundry Solution. Get the peace of mind that external suppliers can't provide. The best way to prevent cross-contamination is to avoid physical contact. The barrier concept brings the only logical solution to minimize physical contact as it restricts staff movement and encourages straightforward flow. and it offers a functional separation of cleaned and soiled textile. Traditionally, facilities management was kept in-house, however, with increased competition and growth of technology, companies moved to focusing on core areas and outsource business soft facilities management services. Soft facility management are services which make the workplace more pleasant or secure to work in. Welcome to Quick Clean Laundry Systems. The facility is located at Bangalore Medical College. The laundry employs RFID-based system to quickly find quantity of dirty linen arriving and washed linen leaving the facility. The soiled linen is collected from ward and sent to laundry for washing.
I'm using Quick Clean Linen since 10 months. It's very clean and stainless compared to previous days. It's cleanly ironing, and the supplying of the linen services is also very good.
The laundry employs a barrier laundry system. The soiled linen is then separated according to textile family. The linen is then washed as per the correct wash formula based on fabric type. The drying is performed as soon as possible after washing to prevent the recontamination. The process also provides a further level of thermal disinfection. The dried linen is then ironed, folded, and then stacked in separate trolley for dispatch.
In hospitals, linen and its laundry plays a very significant and important role in maintaining cleanliness both of the hospital as well as of the patient. This also avoids unnecessary usage of antibiotics as well as infections to the patients. Linen and laundry is a support service for the hospital, and the hospital finds it difficult to use its energies and resources in a support service like linen and laundry. Hence, I do believe that outsourcing is the key. For the first time in a government hospital, we have outsourced both linen and laundry to a private firm through a proper tendering process in accordance with the KTTP Act. The company, that is in this case Mrs. Quick Clean, gives us linen free of cost. Now this helps us, our patients, get clean, disinfected linen every day without a break. I believe this is a win-win situation for all. The hospital does not have to worry about the purchase and maintenance of the machinery.
Good afternoon. That was a very, very, very long introduction. Let's focus on fundamental hygiene, which I think now everyone got the subject. And we'll see the role of linen in the safety of our patients, because let's face it, we've talked about during these 2 days about fantastic subjects, all as important as one another when it comes to data, when it comes to accreditation. Which of your hospitals can run without laundry, without hygienic laundry? Can you put patients in bed? Can you run an operating theater? Can you wrap a newborn baby? What do you do without linen? You close the hospital. Here is a fact sheet that's already dated 13 years from the World Health Organization that was leading a hand hygiene campaign in which they say that hundreds of millions of patients contract a healthcare-acquired infection. between 7 and 10% of these patients do. It also says that in ICU, in high-income country, that goes up to 30%, and that in low and medium-income country, that can go up to 2 to 3 folds. 2 to 3 folds of 30% at 60 to 90%. Now let's look at what are the vectors of infection in a hospital. Anyone? This is an interactive session. Anyone wants to make a guess? What are the vectors of an infection in a hospital? I'll help you with the first one. You need to help me then. Hand hygiene, we just talked about it, yeah? Medical devices, thank you. Any invasive indeed during a surgery or a catheter during IV. Linen, of course. You're jumping to the end, but there are a few before. Foods, yeah. Best entry to our organism is our mouth. Water. But also airborne. Airborne with this picture, yes, but have you heard of the Legionnaire disease in a badly managed air conditioning system? Insects, mosquitoes, that will transport a disease from a body to another. And yes, thank you, linen is one. Linen is one of the important vectors that we should not underestimate. An example here, as a proof, we're all familiar with the methicillin-resistant golden staph. That is a bacteria that can live up to 90 days on textile. These are the very few cases that have actually surfaced where linen has been the root cause of an infection in a healthcare institution around the world. When I say very few, is that, well, traceability is one thing that we've seen is yet to be developed in many places around the globe. And then there are things that we don't necessarily broadcast very much. And you see that protection of linen is an important factor. What you can see here is, on the top left, is the transit. Think about the control you have over your processes. Would you outsource your food, your catering in the hospital? Preventing is less expensive than curing. Now, at this point, we can all agree that cross-infection increased the average length of stay in hospital. And when you know the costs of a day of hospitalization, somebody who's supposed to stay 2 days and stays 2 weeks is an expense to the healthcare system. So clearly, yes, preventing is less expensive than curing. Something a little bit more present here, very close to us, COVID, which coming out of this crisis. When you think that a virus can do this, the unthinkable, in reaction to this, we have simply and naturally put up a barrier to this cross-infection, putting up masks as one of the measures. We've isolated, segregated our weak citizens to protect them against the cross-infection. That is simply putting up barriers to the contamination. So why not simply implement the barrier concept in a laundry, you have the entry of the dirty linen processed on the one side, the right-hand side of this picture, going through pass-through machines to exit clean, and where nothing can pass through this wall. Do you actually know where your linen is washed in your hospital? Have you ever gone down to the laundry? Do you know where this clean linen comes from? Or is it just, do you just take it for granted that clean linen is there when you need it? Because there's no magic. There's no magic about this clean linen. There is actually a complex process. Complex yet straightforward, where in each of these steps there is processes to follow, making sure that clean and dirty are at all moments separated. Very easy to implement good hygiene practices in order to deliver good hygiene. I would like to finish by a statement story very quickly. When 7 years ago I first came to India, I met with Dr. Harshvardhan, Minister of Health and Family Welfare then, and we talked about the basics on hygiene. And we showed, so it wasn't just myself, I was with my colleagues and friends from Quick Clean, we talked about linen hygiene in healthcare and the journey that India had to take. 1.4 billion people is a history that wasn't written in 2 weeks, clearly. But I think that India can be proud that in these 7 years, what I've just very quickly talked about has been implemented in these 6 hospitals and more, starting with AIMS here in New Delhi, and most recently, Amrita, Faridabad. Beautiful laundry that will be treating 17 tons of hygienic laundry a day. So I think we can congratulate India for onboarding this journey and can only encourage to go further. Thank you very much.
Okay, so thank you so much for that session, and I'm sure there's a lot of people who would want to maybe ask you a few questions. Obviously, this presentation and your video will be on the website link, and if there are some people that come to us and want to know where you're available, we will ask them to find you for the questions. Thank you so much. Right, so thank you guys. We'll break for lunch. We'll meet again at 2:30. Thank you.
Welcome to the HCL Healthcare family. You've been selected to be a part of a very special mission in preventive healthcare in India today. HCL Healthcare is championing preventive healthcare by working with some of India's largest companies to provide healthcare services and products to the thousands of people that use our offerings on an annual basis.
We believe that taking preventive healthcare decisions is the right way to being healthy, happy, and disease-free. Through preventive care, we enable diagnosing We strongly believe in the values of integrity, urgency, innovation, compassion, and accountability. It is very important that we all believe the same things about the mission of the organization, to aptly serve the people and the communities we touch. We aim high and travel into uncharted territories to explore, innovate, and transform lives. We believe that each one of you will be a valuable contributor to help HCL Healthcare achieve its ambitious goals. We are privileged to be certified as a great place to work, which is only given to India's best organizations. Welcome once again to HCL Healthcare. Make your contribution count.
Welcome to the HCL Healthcare family. You've been selected to be a part of a very special mission in preventive healthcare in India today. HCL Healthcare is championing preventive healthcare by working with some of India's largest companies to provide healthcare services and products to the thousands of people that use our offerings on an annual basis.
We believe that taking preventive healthcare decisions is the right way to being healthy, happy, and disease-free. Through preventive care, we enable diagnosing potential health problems before they become long-term health issues. We are in the noble profession of caring, making sure people experience relief, putting smiles back onto faces. Prevention is better than cure. Welcome to the HCL Healthcare family. You have been selected to be a part of a very special mission in preventive healthcare in India today. HCL Healthcare is another extraordinary vision of Shiv Nadar, the man who created one of India's first and now largest IT companies. The power of the global brand HCL transcends not just across India, but to over 45 countries that we operate in. His vision and life's work has always been transformative and life-changing for those that are a part of it. And it's a real privilege for us all to be carrying out his vision. It is through wonderful people like yourself that have joined our mission that we achieve the success we have today. HCL Healthcare is championing preventive healthcare by working with some of India's largest companies to provide healthcare services and products to thousands of people that use our offerings on an annual basis. We strongly believe in the values of integrity, urgency, innovation, compassion, and accountability. It is very important that we all believe the same things about the mission of the organization to aptly serve the people and the communities we touch. We aim high and travel into uncharted territories to explore, innovate, and transform lives. We believe that each one of you will be a valuable contributor to help HCL Healthcare achieve its ambitious goals. We are privileged to be certified as a great place to work, which is only given to India's best organizations. Welcome once again to HCL Healthcare. Make your contribution count.
Welcome to the HCL Healthcare family. You've been selected to be a part of a very special mission in preventive health.
afternoon. Good afternoon, guys. Welcome back. Hope you all had a good lunch. We have a very interesting session, but I'll have a few more people come into the hall before we start that. So in the interim, I remember mentioning yesterday, and I think Raj also mentioned that our beloved chairman celebrated his 90th birthday recently. And there are a couple of videos from that. He's been wished by some very prominent members across the world, so we thought we'll just play that until I get this next session ready. Can we have that video, please, guys? Thank you.
Dear Dr. Reddy, greetings from Geneva, and my very best wishes for a happy 90th birthday. May you be blessed with good health and energy to inspire health leaders across the world, as you have done for 4 decades. Thank you for your lifelong commitment to health and to ensuring all people receive safe and quality care in India and around the world. Again, happy birthday. Namaste.
Hello, it's a real honor to wish Dr. Pratap Reddy a happy 90th birthday. Dr. Reddy, your impact over the past several decades is remarkable. I'm proud of Microsoft's long-standing partnership with Apollo Hospitals and excited to strengthen that partnership in this new age of AI as you continue to harness the power of digital technology to improve patient outcomes. Your cardiac prognosis model, which uses Azure AI to predict the risk of cardiovascular disease, is especially inspiring and meaningful to me personally. So please accept my heartfelt congratulations and gratitude for your contributions to the healthcare industry and your continued commitment to provide the best healthcare to everyone. Thank you so very much.
Hi, my name is Peter Diamandis. I'm the chairman and founder of the X Prize Singularity University Abundance 360, the author of a number of books, Abundance, Bold, most recently Life Force with Tony Robbins. It is an honor and a privilege today to have the opportunity to wish Dr. Pratap Reddy a very happy 90th birthday. Throughout your life, Dr. Reddy, you have been a visionary focused on bringing the best care to everyone. You've kickstarted India's healthcare industry for the last 40 years. You built the first corporate hospital in India. And under your leadership, Apollo today is the world's largest vertically integrated healthcare platform, impacting the lives of over 1 billion people in 70 hospitals, 400 clinics, 2,000 diagnostic centers, and 5,000 pharmacies. You know, I speak about that today. If you want to become a billionaire, help 1 billion people, that's the new definition of being a billionaire, the ability to help 1 billion people, which is what you do. Dr. Reddy, you have pioneered innovation, whether it's the first health checkup designed back in 1973, or today as Apollo pushes towards advanced telemedicine with machine learning and AI-powered diagnostics, clinical intelligence, with 40 years of incredibly rich clinical data. A heartfelt congratulations, Dr. Reddy. I look forward to meeting you. I've had the chance to know your daughter, who is incredible. I just am so thankful for the work that you do on this planet, and really the contributions you have made to humanity. An honor, again. I wish you a very happy 90th birthday.
Dear sir.
Hey, doctor.
Right.
Namaste, sir.
Hello, Dr. Reddy.
Sir. Thank you so much. Thank you so much. Right. So the next session is a very interesting one, like I said. Now, all of us, I guess none of us expected that in our lifetime we would happen upon a pandemic. I know there's quite a lot of discussion that's already happened. Everybody knows we've been there, done that. But I'm sure the pandemic should have taught us some lessons, especially so for healthcare. I know while a whole lot of people around the world were working from home or were, given paid holidays, every person in a healthcare organization was working, staking their lives, staking their families' lives, and I think there's been a lot of lessons learned. I mean, I still tell all my IT colleagues that they had it good while we were sweating it out, but literally sweating it out in a PPE and all that. But I guess it was difficult for everybody: digital, non-digital, healthcare, IT, you name it. So the discussion, I think, today is going to be centered around how we deal with a pandemic, what are the lessons that we came out of a pandemic with, and what do we do if it were ever to strike us once again. And these, again, are not lessons that we are going to be learning and we are going to take it with us. These are lessons that are going to be passed on to the generations that will probably take over from all of us. So these are going to be some hard-earned lessons. It has touched every one of us, so I'm sure everybody has a story to tell, but let's try and understand what these great minds that are going to be sitting here for the next session decide are the lessons that I've learned and what we're going to take with us in future. It is my pleasure to introduce Dr. Manish Mattu, who is the Chief Executive Officer of Karnataka region, happens to be my boss, and I'd like to think of him as a good friend too. So please may I have you on the stage, Dr. Manish? Thank you. Please also join me in welcoming other speakers. Dr. Aham Arora, Professional Educational Lead. Right. Okay. All right. So I will have Dr. Manish take over the session. He'll introduce the guests and have them on the stage. So hang on there for a wonderful session. All yours, Dr. Manish.
Thank you. Thank you, Dr. Sana. Good afternoon, everybody. I know it's a tough act to follow after a delicious lunch to have a session where we're discussing COVID, a topic which has been discussed so many times in the last 2 years. But we'll try and make it engaging and worth your time. So good afternoon once again. I'm really grateful to the organizers for giving me this opportunity to discuss something which is so relevant, not just for present times, but for future as well. The COVID pandemic, just to set the context, although we all know about, what happened during the pandemic, had a far-reaching impact on our society overall and a profound impact on all aspects of life. Economies, for example, the global economies shrunk by a big margin during that time. Even today, we are witnessing the impact, the ripple effects of what happened during COVID, with the recession in so many countries setting in and other countries being on the verge of recession. The other aspect that it impacted was education. So many children, millions of children around the world, were deprived of critical learning hours during COVID, and that impacted the development to a large extent. We also saw COVID impacting our societies, the way we work, the way we live, the way we interact with each other. All of that has been impacted, unfortunately, some of it forever. And we are seeing increasing incidents of loneliness and impact on our mental health. It also impacted the politics of the world. It brought to the fore the importance of governments in handling crises of such nature, but it also brought to the fore the existing political divisions and inadequacy or inadequate global cooperation in handling such crises. But the largest impact, the greatest impact that COVID had was, of course, on our healthcare systems across the world. And we see that some of it has changed forever. Some of the adverse impacts that it has had on healthcare systems will continue to haunt us forever. Just to give you some statistics, as of February, 460 million people have been infected by COVID globally. About 5.8 million people have died. That's a staggering number. The good thing has been, there is always a silver lining in every challenge. The good thing has been the demonstration of human resilience and how we've come back stronger. And as Nelson Mandela said, the greatest glory in life lies not in not failing, but in rising every time we fail. And I think that's something humankind has demonstrated over the last 2-3 years. Just to touch upon some of the innovations that have happened, and that segues into the topic for today's discussion, some of the innovations that have impacted us, thankfully, will continue to help us, will continue to help humankind in the years to come. Some of the innovations, of course, that impacted healthcare to a large extent, like spurt in telemedicine, 3D printing, e-pharmacy, impact in online pharmacy, diagnostics, remote working, wearables, 3D printing, robotics, data, research. I think all these will have lasting impact on humankind and will help healthcare to a large extent in years to come. It also had a positive impact on research and manufacturing. As you all know, vaccines got made in record time, manufacturing capacities exponentially increased, and as of a couple of months back, 10.2 billion vaccine doses were administered globally, which again I think is a record number and a testament to human resilience. Also, we saw some very impressive innovations in logistics, supply chain, contactless delivery, use of robots in delivery, as I mentioned 3D printing earlier as well. I think all of them are just, I think, fantastic innovations. There are also changes in the way clean energy, renewable energy, the focus on that post-COVID has been impressive, as also the impact on education by way of online classes, remote learning, and so on and so forth. So overall, I feel, while it was a big challenge, the way we have responded to it has been fantastic. And with me, I have some distinguished guests today who will touch upon their learnings from COVID and some of the innovations they have experimented with in their organizations, or what they have witnessed and what it means for us going forward. I have the pleasure of inviting on stage those distinguished guests. So I'd like to welcome them on stage. Lieutenant General Arup Kumar Das, sir, if you could join me on stage, please. And I'd request the audience to welcome these distinguished guests with a round of applause. Dr. Rekha Arkut, Dr. Ashish Chaudhary, Miss Radhika Ann, and Dhruv Kapoor. Before we begin the discussion, I'd request each panelist to give a brief introduction about themselves, and then we'll get on with the session.
Yeah, hi, a very good afternoon. I'm Dr. Ashish Chaudhary. I'm an orthopedic surgeon by profession and happen to manage Akash Healthcare for the last 5.5 years. And 3 years into COVID, how they passed. There's long, experiences and storytelling we can do for hours. But yes, today, hopefully we'll have few of our specifics, learnings related to COVID disease. I'll be happy to share here and, learn from all other speakers and from the audience. Thank you.
Hello everyone, my name is Dhruv Kapoor. I'm the Director for Strategic Customer Groups and Growth Opportunities for Johnson & Johnson Medical. My background, I've been with Johnson & Johnson about 13 years now, and currently I'm in this role.
Good afternoon all, I'm Dr. Rekha. I'm Dean of the Apollo Institute of Medical Sciences and Research. For those who don't know, Apollo has 2 medical schools, one at Hyderabad and one at Chittor. I'm a surgeon by profession, and I have donned several hats before this as Associate Dean of Students, Associate Dean of Accreditation, Associate Dean of Postgraduate Education.
Good afternoon, all of you. I am General Das. I am an alumnus of the Armed Forces Medical College. I am an ENT surgeon. I have spent 39 years in the Armed Forces, Army Medical Corps, and for the last 5 years I am in the corporate sector. I am also an institute body member of AIMS Kalyani and a member of the Healthcare Committee of the FICCI. I have been Dean AFMC and Director and Commandant of this Army Hospital Research and Referral, and many other. For the last 15 years, I am in total in administration. So I hope to have a good interaction with all of you.
Good afternoon, everyone. My name is Radhika, and I look after the medical solutions business for 3M India. I've been with 3M for close to 20 years now, and I was with Johnson & Johnson prior to that. Looking forward to this discussion. I'm happy to be here.
Thank you, everyone. So my first question is to Dr. Ashish, to you. You know, what have been some of the learnings from COVID for you? And we know Akash Healthcare is rapidly expanding into many geographies and all, especially with respect to hospital design, because I think that came up under a lot of scrutiny during COVID. And are you incorporating some of those strategies in your upcoming projects?
Yes, of course. When the COVID hit, the hospital were working. Before that, it was, you can say, a multi-speciality or super speciality hospital without any focus upon disaster wards and getting prepared for such a pandemic-like situation. But yes, the moment it came and hit us, we started speculating how do we manage the ever-increasing load of COVID. It was very uncertain situation. Sometimes we had all 4 floors filled with COVID patients, and then there was a recession happening. So we need to segregate those areas through fire doors and trying to adjust the HVAC systems and segregate the population, which is actually there were 3 categories. One is a non-COVID patient, one is RT-PCR positive, and there was still a group which was waiting for the reports, or clinically it was there, but on the reports it was not there. So that was a catch-22 situation, where to keep them. Go to the negative wards, the other patients get affected mentally also and physically as well. The chances of transmission increases. So all these confusions led us that okay, whatever learnings we had during those peaks, we tried to manage with the available resources and the the manpower which was available. But yes, going forward, a lot of things we thought, what kind of laminar flows we have in operating room. I think there has to be similar, replication happen in either a disaster ward, or we have some dedicated places which can be cordoned off in the need of the hour. So that's something which I feel is already been incorporated into the future projects. Air changes became a certain important factor in the design, where we wanted the fresh air accumulating in those infected areas, negative pressure areas have to be incorporated. So in all our future projects, we always go back to the the healthcare consultant. They discuss on these aspects. So God forbid something happens again in our lifetime, how do we make sure that the building is ready to receive such infected patients, whether it is COVID, whether it's swine flu or any other disease, we should be very well prepared. And of course, the training, the contingency plans, and on the operation side, one has to have a robust supply chain management. And one very important thing which came out of oxygen crisis. So the liquid oxygen plants and oxygen generator becomes a norm rather than exception for most of the hospitals. Yes, the placement, the infrastructure may not be possible in each and every small little hospital, but yes, according to the capacity, one should be able to have a good, their self-generating oxygen plant. If not, then they should have a very robust supply chain management, so that if such a crisis happens, they should be able to scale up. So these were the few things which came up, for the design and operational part. But yes, there are many more learnings which we keep on accumulating and, focusing on future projects. We are adding all those things to our kitty.
Thank you, Dr. Ashish. Very relevant about some of those design changes that you made. And I know oxygen shortage was a big challenge, but I think a lot of learning emanated from that too. My next question is to Radhika. COVID was a nightmare from a supply chain and logistics perspective, but I think the non-healthcare delivery aspects of the ecosystem also rose up to the challenge and made some innovations in processes and product to kind of supply the hospitals at time. What were your learnings during this time, especially from a supply chain innovation perspective, that you think will have revolutionized, so to speak, the way we've imagined healthcare so far?
Yeah, so post-COVID, I think there was a huge disruption in the economy, right? And we did have challenges right from the essential commodities to the healthcare as we talk about it. So obviously the reason was the lockdowns, then we had travel restrictions, and there were disruptions in the logistics and supply chain. All of this led to this. So from the inventory management part, I mean from the supply and demand part, we saw the demand rocketing for a few SKUs and also evaporating for a couple of SKUs. So this was a big drain on the entire logistics management part. And there were a lot of learnings, I think, that the supply chain teams have done over the period of the years that we've taken forward from COVID. So I think as an immediate response, the first thing we did was building up of inventories. So especially for the critical finished goods and as well as all the parts through the process, that's the raw materials and the packaging material, these are very critical for consistent supply of the products. So we had also needed to diversify our risk for our RMs. We need to look at multiple sources of supply or alternate sources of supplies of RMs so that the supply chain could be kept there's no disruption to it. And the other thing that with the inventories going up that the companies critically looked at was SKU demand, rationalization of some of the SKUs. Basically, we wanted to be there in the SKUs where we actually bring about a value to the customers, so, and that's where our focus was. I think the second thing that people have done, which is a little bit of a longer term strategy, is moving from globalization to localization. So it was very important to get the production base closer to the end user itself. So especially with India, with the Make in India campaign and Atmanirbhar Bharat coming up, we have actually expanded our local footprint significantly in India, and we will continue doing so in the future as well. So we'll look at how we can minimize the logistics timing and the transportation timing so that we can supply faster. The third thing that we're looking at as basically the supply chain team has come up with a supply chain risk management process. So this, again, this whole goes out identifying what are the possible risks that could happen, having a supply chain risk management framework in which you need to look at what are the possible failure modes, what could be the mitigation strategies for that, what are the, and how do you, and keep monitoring this, have regular governance, regular reviews, and look at how do we mitigate this risk. So that is critical. Supply chain resilience is another thing that has come up significantly. So by this, what we mean is not looking at the statistical data for forecasting, but you look at the data in the future, basically with the changes in demand, and we had multiple rounds of COVID. So there have been spikes up and down, but that's the new normal. So we look at the future trends, and then we look at how do we plan our systems and accordingly. There's a lot of automation that has happened in the manufacturing and supply chain part as well. I mean, we did see a lot of disruption in our manufacturing processes with the COVID guidelines that came into place. I mean, there was a lot of protocols that have been followed. So more and more automation is happening both from the manufacturing side as well as from the logistics side of you. You might be having automatic forklifters, you'll be having automation of machines, so which reduces our dependence on the human intervention, basically. So I think there's also the area of digital era. So that is very, very critical to make sure that the supply chain solutions, the end-to-end supply chain solutions are there, right from planning to procurement to your manufacturing to your logistics. That is carried upon. There are a lot of advanced analytics that have come up. This kind of software really helps in planning this whole thing better. And one big thing that's required is for the team to be upskilled with this new data in this new world of data. So I mean, unless you are agile, unless you are able to learn to the new things, that will not be, it will be difficult to manage all that. So apart from that, I think the other thing that with this data coming up, the risk of also cybersecurity also comes up. So we also see, I think most of the people would have experienced some of this, and it is very important that we do due diligence, especially with the vendors and our suppliers when we are coming to it. So the compliance part and the due diligence is very, very important. So I think this is the few of the learnings that we did see. And data will be key. I mean, data and managing the whole data in an integrated manner will be key going forward. Yeah.
Thank you, Radhika. I think very well said. That, and it's sometimes you wonder that why does it take a crisis for us to, innovation to accelerate? But I think that's the nature of human mind, and I think we leave it there. We've covered healthcare delivery design. We've covered supply chain logistics. My next question is to Dr. Rekha. We've not spoken about medical education so much as we've spoken about patients, pandemic, deaths, mortality, supply chain, pharma. But my question is, how, to what extent did COVID disrupt? We all know, but I guess you know, with your experience, you can tell us more clearly. To what extent did it disrupt medical education? And what innovations did you kind of think of to ensure continuity of medical education during and after pandemic?
So, like all spheres, it did affect education, in medical education. Now, when we talk about medical education, we're talking about three arms. One, we're talking about the teaching. Two, we're talking about learning. And three, we're talking about assessment. I'm sure parents in this audience would recognize that I think everybody moved to online teaching. Even kindergarten kids were now empowered with a laptop or an iPad or a mobile phone, and everybody moved to online teaching. But we faced a little different challenge in that most of our faculty were recruited for healthcare. So we had a shortage of faculty to take the classes. So that was one challenge that we had. So we ended up having to, schedule the classes according to their COVID schedule. So that was one thing that happened. Now, when we did the online sessions, we had 250 students. So we saw 250 little blank screens showing a ceiling fan, a rumpled bed. That was the kind of image that we saw. And so we really had no feedback at all to figure out where the learning was actually happening. But some of the positive things that happened was that when we did what we call as a flipped classroom, where we asked the student to actually read and then come back and do the discussions, we found that that worked better compared to the original didactic lectures that we traditionally did. But one thing very different in medical education is that a lot of our teaching actually happens on patients. So they actually shadow a consultant, they go to the wards, they actually see the cases, they are allowed to talk to patients, elicit history, do a clinical examination, and all of this was lost. Completely lost, and there was nothing that we could substitute for it. We did try to fall back on video clips that we had from our own practice, clinical photographs, we provided YouTube links, we did all of it, but definitely there was a sensory deprivation of sorts. They were not hearing patients, they were not feeling the empathy, being able to gauge the emotions that patients or in a real life situation. So that was something that I think nothing was able to compensate for. With regard to assessment, we realized that there were a lot of things that did not require the students to be actually there in the physical space. It was possible for them to actually turn in assignments online, and a lot of it continued even after COVID passed. So a lot of these processes that we learned during COVID, we have continued to use today. Now, with regard to the skills, especially when we talk about postgraduate training, a lot of specialties were redirected towards managing COVID patients. So we had, ENT surgeons, we had OB-GYN, we had ophthalmology, all of them recruited into care, delivery. And this applied even to residents. So across the globe, I think that particular year of students definitely had a decrease in the quality and the span of the clinical expertise that they ought to have learned. But having said that, they learned valuable lessons in terms of communication, in terms of coping with challenges, in terms of being able to allocate resources appropriately. One of the things that we have incorporated is that we've asked those students to continue to work with us for an extra year as a faculty member in order to gain that skill, because we understand that there is no substitute for that at all. So there has been some compromise that we have tried our best to compensate.
Thank you, Dr. Rekha. I think medical education, and we've discussed the kind of challenges that medical education has faced and what steps across the country colleges are taking. I hope they lead to some sort of compensation for those students so that there is no gap in learning. My next question is to Dr. Arup Kumar Das, and I think it will find resonance in the audience as well about mental health. And General Dr. Das, you've been a defense veteran, you've been a medical administrator, you've been a clinician yourself. So you've perhaps seen the three most stressful professions in the country today. You've had an experience in all the three. What's been your experience during COVID, especially pertaining to the mental health of employees, and what kind of innovative things have you been part of to kind of safeguard the mental health of the employees? If you could shed some light on that.
Yeah, thank you, Manish. As has been said in the very beginning, that this pandemic has impacted almost every person in this whole world in some way or the other, either himself, his family, or somebody. The healthcare industry has been particularly burdened and at times maybe overwhelmed with the sheer number of cases that we had to, look after. So as a consequence, what has happened is our healthcare workers, they have come under severe mental and, emotional stress handling all those things. So one of the studies carried out pointed out that 92% of the healthcare workers were stressed, 19% admitted that they were overworked, and about 45% said that they had lacked emotional support. Particularly vulnerable amongst our healthcare workers are the nursing fraternity, because they have to spend most of the time with the patients and they are involved in the direct healthcare delivery. So in the initial phases of this pandemic, there has been a lot of chaos and a lot of panic all around because of misinformation. So as a consequence, what has happened is many of the nurses, either they quit their jobs or they were absconding for various reasons. So then we realized that there is a need to instill some confidence in them and give them some safety and security so they could continue to work and we could use them in our hospitals. So we devised our own plan, and according to that, we first took up the education to the healthcare workers about the COVID, its epidemiology and spread. Then we gave them training on personal safety and COVID nursing. Thereafter, what we did was, we recalibrated their duty hours and their shifts in such a way that they did not feel the stress and they had adequate time for rest and relaxation. And those nurses who had elderly people at home and could not go home after seeing infected cases, they were provided hostel accommodation, they were given even hotel accommodation. We have also rotated these people from COVID duties to non-COVID duties because, wearing a PPE for 8 hours itself is a big stress by itself. Those who have worn it would realize. Then we have given COVID insurance to these people, plus we have given them counseling on a periodic basis, and all those healthcare workers who are subjected to some kind of a risk, we have compensated them by incentives and by providing them with risk allowance. With these measures, I think we have been able to tide over the crisis. We did not lose too many nurses to COVID infection. And this is one thing which has played a very important role in the management of COVID in our hospitals, because many of the hospitals who have not followed the protocols in the very first month of their COVID, many of them had to shut down because most of their healthcare workers got infected. So even otherwise, even in a normal situation also, if you want to remove the stress amongst your people, there are very simple ways. Firstly, you have to provide them a very nice working environment in the hospital with good interpersonal relationships, with a good working environment, and simple HR practices which will instill a lot of confidence in the workplace and will help the nurses to have a work-life balance.
Thank you, Dr. Arup. I think the safety of our employees cannot be overemphasized, and I think COVID has brought to the fore the value that each healthcare worker in the ecosystem holds. And without, we talk about technology and all, but I think without the core of well-trained employees, we'll be nowhere. Dhruv, my next question is to you, and you've been in medical devices for several years. What have been your insights from COVID, particularly with respect to innovations that happened in your sector of healthcare?
Right. So, Dr. Manish, I think a lot of people across the country learned a lot of things during COVID, right? We learned how to work remotely. We learned the importance of personal life balance, all of that. But one of the key things that everybody learned was how to prevent infections, that acknowledgement. So similarly, in the healthcare space or in the surgical space, while the operating room is one of the most sterile areas in the entire hospital, but there were areas which nobody thought of could lead to infections, and those came to the fore during COVID, and people started paying attention to that. I'm just going to talk about two such areas which were thought of as quite harmless pre-COVID, but during COVID, people realized that these could also be areas which could cause infections. So one area is, a lot of the OTs have some sort of a electric device which is used on tissues, different areas, right? Most of these devices cause smoke. The smoke, while it's 95% water, but there's about 5% DNA and viruses, all of that linked to it. This smoke comes into the OT environment. It becomes something that is inhaled by the patient, by the entire OT team. Everybody is inhaling this. And there's a lot of possibility of transmission of infections and carcinogenic smoke also during the surgical procedure. So that's one area which there was an introduction of something called as a smoke evacuator, which sucks in all the smoke. Now what this does is it has multiple filters, which takes care of the particles, and even as small as 0.01 microns. So even the COVID virus could not go through that filter. So that prevented a lot of potential cases of spread over there. The second one is pretty much a very humble surgical suture. Nobody talks that much about a surgical suture, right? But it is a foreign body which is going inside the human body. It will not cause infection by itself, but when it goes inside the human body, it provides a surface where existing pathogens can harbor, create infections post-surgery. So it becomes really important to take care of this surface and not allow any pathogens to form on this surface. Now, with that, there have been antibacterial sutures which have a coating of antibacterial on top of it. But while these have been existing for quite some time, during COVID, the importance was felt that much more, that even in the surgical procedure, during the procedure, you have to provide something locally which avoids these infections to transmit and grow in the body post-surgical. So these were a couple of areas that I thought I'll speak about, which were pre-COVID thought of as completely harmless and not top of mind for anybody, but after COVID gained a lot of importance, and a lot of hospitals started looking at such technologies also.
Thank you, Dhruv. I think very relevant point. And, I've seen a lot of now attention being paid to safety measures by everybody in the hospitals today, which somehow, it's a great silver lining. The focus on attention right from patients to doctors and all is on safety first, and investing in that across the healthcare ecosystem. So I think that's been a welcome change. So completely agree with you. I'm just going to change tracks now, and for the next couple of about 20 odd minutes, that's the time we have. We'll focus on technology largely because I think it's been an all-pervasive, phenomena, and it's such a broad topic that it'll be very difficult to cover all aspects of technology and how post-COVID we made those strides. We've changed tracks and invested in technology, but I'm going to touch upon a couple of technology-related interventions that each of their organizations and their own experience they've had. And at the end of the session, if there are any questions from the audience, we'd love to have them. So my question is first to Dr. Ashish. Everybody's talking about telemedicine, remote consultations and all. And while we've seen a spike during COVID and all, do you think it's plateauing out now? And but I think it's a great intervention. What do you think we need to do to accelerate adoption of telemedicine?
Telemedicine, before the COVID, I mean, it was a strictly no-no for any consultant. Even if I ask me, anybody coming and asking, okay, can we do a video call in 2019? I said, what is that? I don't want to do that. I want to see the patient. Only then I can, give my opinion. But, everything was forced upon us, and this was the only way you can still continue the care for those chronic diseases or those elective people procedures which were waiting for the COVID to get over. And, that tool came very handy. And, what for years and years, the government could not come up with regulation. It happened overnight. Hand washing, sanitizing, everything happened overnight the moment COVID hit all of us. So this technology adoption was forced upon, but yes, now I feel it should become an integral part of each and every healthcare system, especially if we are aiming that most of the care is going to get delivered at home. And one point of time, I think gradually, the routine services, the nursing care, small injections and all, I think tertiary care hospitals are going to be surviving only on complex surgical procedure. Rest of the things which can be managed at home, ultimately 70 to 80% of the healthcare being provided today inside the hospital or healthcare facility is ultimately going to go to the homes. That's why that another segment of home healthcare is catching up big time. So if I talk about our experience in 3 years, yes, it's not as big as Apollo would have, but a few thousands of teleconsults happened, and everybody who was not the mainstream, healthcare worker like the medicine and pulmonology and all those guys were, physically interacting with patients and managing ICU and critical patients. So people like me who were orthopedic surgeons, ENT surgeons, who were sitting idle, had no case to manage. So they were trained by our medicine colleagues how to interact, how to give the COVID treatment. We had the checklist available with all of us, and we were managing the patients remotely, at least giving them the first direction. If there is something which can escalate to our the medicine colleagues, we were doing that. So that was a very handy tool for all of us. But now, once the COVID is gone by, I think the rate has immediately come down. But I feel that it should exist and it should be promoted in a sense that every consultant must have at least half an hour dedicated to teleconsults, even in routine practice, because there will be many patients who don't want to travel 20 kilometers, an elderly female climbing down from 3rd floor, and just for a small piece of advice. I think if they can be managed on a teleconsult, it should be done. And that, that tool should be used to the advantage in routine rather than become, waiting for a pandemic-like situation to, go all out with those technology parameters. But going forward, I think this should exist and should become a routine practice in all the healthcare organization, and it's going to give, it's going to offload a lot of healthcare facilities with, managing the primary and secondary care and try and focus more on the complex procedure for which the hospitals are meant. I believe that in the next 20 years, most of the hospitals would only be, a center to manage these complex procedure, and all the OPD and everything will go to homes or to clinics. And that kind of integrated system is going to develop maybe in next 1 or 2 decades.
So, so essentially continue with the learnings from the crisis and not give up on telemedicine. I mean, continue the momentum, because essentially it's about behavioral changes from doctors, from clinicians.
Many organizations have already set up their telemedicine units across India. They'll be out of job if we don't promote this well.
Thank you, Dr. Ashish. Radhika, my question is to you, the next one. And, we're intrigued by 3D printing. While it's a very fancy word and all, but what implications do you see of the learnings that we've had on 3D printing one? And how can we accelerate it if you think there's great value in going into this technology?
Okay. So 3D printing has been there for quite some time, but I really think it's picked up over the last few years. So I think it's a huge market. Overall, it's more than a 17 billion market overall. And in healthcare per se, I think it's a 2.5 billion market, growing at more than 20% plus per year. But having said this, I think in the space of healthcare, 3D printing has been there for a couple of decades now. It started with the prosthetics and dentistry basically, and then it evolved into many other fields. So during the COVID time, I think this might have come up as a temporary solution, but now companies are looking at it more strategically to see how do we make this a part of their way going forward. So to come up with the different, I think the first thing is to understand the different users, basically the applications that 3D printing can be used in the healthcare space. So one is the medical transformation that has happened through the years through the different implants that have been done, be it dental implants or medical implants, customized hearing aids, and prosthetics. So I think this is some field that everybody does know about. The later technologies that have come in, I think it can be used for making medical models, basically which can be used more for training and education. Both at the, and this will really be it'll be a simulated model which people can use for experimenting on the bodies basically during the education and training purposes. Also the 3D patient models can really help and they'll become a standard in terms of the difficult surgeries. We talk about a craniotomy or you talk about a facial reconstruction. So this is something that can be done offline basically to see that instead of experimenting on a patient, and this would be really critical going forward. This can be used for telling the patients about the outcomes and educating them. The other big thing that the 3D printing is right now is in the bioprinting, basically. That's the latest technology that's come up, basically, which is replication of the cell tissue into some cell tissue organs like the liver or the kidney, which can be used for new drug therapies. So that's a revolutionary is that we will be seeing this in. So one is building awareness of this, and the second thing is right now it's being done in a small scale. To scale this up, economies of scale are very critical, and the biggest challenge right now is the quality of the finished product. So the machine consistency and quality is very, very critical for us to do it. While we do it in offline centers, there has to be some centralized, there has to be some standardization so that the end quality does not get impacted. The other part is having a skilled workforce. Basically this works on CAD/CAM, and this is a specialized skill set, so basically people need to be aware of that. And because most of the solutions are customized, it requires some customized training as well. So that is the second thing that is required. The other big challenge is about the cost part. The raw materials that are used for 3D printing, they are basically, if we really need to scale up the industrial production, they have to be a certain advanced material that is used. It is very specific to the 3D printer that is used. So, sometimes the vendor lock-in specs come in. So it is not an open market that you can easily get in. So it tends to be a costly affair. The last but not least, I think with these things coming up, when we are talking about scaling up the models, we need to keep in mind, we need to have a good legal framework in mind, because these designs are easily available off the net, off the web, but most of these could have some patent, so we should make sure that there's no infringement of patent or any IP issues, because that could come back on us. And there's a lot of data that's being shared. So again, data security and integrity will be critical for scaling this up. Yep. Thank you.
One point I would like to jump in here, because 3D printing is something which is very close to my heart, and we have just, last year, we set up a 3D printing lab in our facility. It is not printing metal right now, but all other material what ma'am is talking. And I second the fact that it's pretty expensive initially. So yes, first mover advantage will always be there, our set of learnings like we had in COVID. But going forward, India can lead in 3D printing, especially in healthcare. And it's been done in many other, like aviation, big time it is being used. But I feel that 3D printing in healthcare has got, a big target audience. And if you compare the cost of, providing a 3D printing solution in India, it is 10 times cheaper and the quality remains the same. We have got government regulatory bodies, especially in Chandigarh, there is one big organization, central organization, which approves your designs, which tests your design, and you can very well go for a mass production thereafter. So this technology, if we use it very well, and I'm happy to share that there are few Indian players who are coming with 3D printing machines, and the materials are open source, so we can get the cost come down within the reach of most of the surgeons. We have done 10 or 15 odd complex cases using this technology. It is fantastic, and I hope that even in my own community, a lot of surgeons are not aware. We are setting up many conferences and trying to show them examples how a complex situation out of nowhere we can try and provide a solution. Yes, the cost has to come down once it is there, and I think only India can do is everything we have done, COVID vaccine, in all spheres, even the knee implants, stents, everything has been controlled, and still the companies are surviving. So I think 3D printing also we can make an impact, which is not going to be regional or local, it could be global.
Absolutely, very valid point, Ashish. I think it's interesting to see the strides India has made as far as manufacturing capabilities is concerned, whether it's semiconductor manufacturing, 3D printing you're just talking about, pharma and vaccines we've always done so well. Even iPhones, for example, the
latest is the
EV, I think is just phenomenal. And I mean, while of course I think the groundwork of that must have started years back, I think it just come to fruition immediately after COVID. So I think great strides there and great things to feel great, wonderful about. Next question to you, Dr. Rekha, about augmented reality. What role do you see, what's your view on augmented reality in medical education, and how do you think it can be accelerated?
So when we're looking at the National Medical Council, in 2019, they introduced something called as a competency-based medical education. So basically it says that when you have a graduate passing out of your school, they are competent in terms of knowledge, in terms of skill, and in terms of attitude. Now, how do you standardize this particular process of whatever they have acquired? You find that there is a lot of variation that happens across schools and within a school itself. Now, when you are testing a student, and if you're going to be having 250 or 150 to a batch, how do you personally supervise every child and how do you grade them? So this is where use of technology comes in. So when we're talking about augmented reality, you have the complete virtual reality on one side, which is your video games, equivalent of your video games. So you're able to play there. And then you have the reality situation where the students are actually practicing on patients. It's a hit and miss. And a lot of patients increasingly are not comfortable with being guinea pigs for medical students to practice their skills. So you have this mixed reality where you are having a situation where you have maybe a mannequin or a situation, and on top of it you superimpose these apps which are available. And in that situation, you are able to incorporate multiple elements like haptic feedback and auditory feedback, visual feedback, all of this. And not only does it give you a sense of real time, it's also able to analyze. So you can grade the student even without an assessor being in that particular space. So you can say you're doing this skill with 50% accuracy today. You can tell the student, go back and practice till you are at 85, 90% accuracy. So you find that this is going to be the way forward if we want to have healthcare professionals of global standards. So that is definitely essential. Now, what can we do to accelerate it is, like we were talking about 3D printing, the problem is the cost. So you find that when we are looking at multiple students, multiple colleges, multiple modules, you find that as we scale up, the cost becomes exponentially more. So you find that, I think personally the way forward would be to have partnerships with industry. You find we would probably have to have sharing of these kind of spaces. And when we're talking about VR and augmented reality, you find it's not confined to medical students alone. You can use it for nursing, you can use it for engineering students, you can use it for architecture, and all of these areas you can use. And if we can have multiple universities come together, multiple industry partners come together, then you find that it would be possible for us to accelerate it. Definitely with the new curriculum, it is labor intensive. It is very, very resource intensive. And you find that it takes a lot of time as well to be able to certify and sign off these students as competent in these areas. So obviously we're going to require technological support on this, and definitely AR is going to be the way forward. So whether we're looking at a Google Lens, whether we're looking at a Microsoft HoloLens, or we're looking at an AccuVein, or we're looking at diagnostics, you find when we're talking about electronic patient records, there is that sense of disconnect that the patients feel. Like when you're looking and talking to a patient, you turn to the side and try to enter the data on a computer, on an EMR, they're not very happy. So we need to have some kind of a system whereby we're able to superimpose this content even as you're speaking to the patient. Or you can have, like you're doing a craniotomy and you're looking at a brain tumor and you have the MRI images superimposed on it and you're able to have a depth perception. You're doing advanced complex laparoscopic surgeries and you want to know exactly where you're having variations in anatomy. Now, all of this is something that so far has been trial and error. And that's where the expertise, the experience of the surgeon actually makes a big, big difference in terms of the outcome. But if you're going to have a situation where when you're doing a laparoscopic surgery, you have the ICG images, you have the three-dimensional MR, you have the ERCP pictures incorporated, all of it on multiple screens around you as you are going in, definitely it's going to result in improved quality, definitely improvement in the output. But as I said before, the costs are going to be huge. And who's going to bear these costs? And that's the challenge.
Yes, I think in a resource-starved industry, I think that's always a challenge of who's going to make the investment. But I think that's a topic for another day. I think COVID also brought to the fore the extensive collaboration between private and public sector, and the government, I think, leading from the front. I think we must acknowledge the role, the proactive role that the government played, in its leadership, in its vision, focus, and execution, and holding all the arms accountable during COVID, which greatly benefited the patients. I think a breakthrough innovation that also was introduced by the government was Prime Minister Modi's favorite NDHM, National Digital Health Mission, which I think, if it succeeds the way it's intended to, will potentially transform the way healthcare is being run in the country. So my question to you, Dr. Arup, is where do you see the opportunities and challenges in the NDHM rollout from your perspective?
This National Digital Health Mission, it has been recently unveiled. Most of you have heard of it. See, you come to think of it that India is such a vast country, not 1.4 billion people. Even on today, a large proportion of this population are deprived of basic health care. Now, the health care in our country is, located in cities and towns, mostly by the private players. 70% of the proportion is from private, and the public sector, government departments are able to look after only 30%. It is not humanly possible for any single government to reach out to its entire population on its own. So, with the intention of providing and reaching out to and providing affordable health care to all of its population, particularly those in the remote areas, government has come out with this National Digital Health Mission. The aim of this health mission is to develop a digital infrastructure by using IT, information technology, so that coupled with the medical resources of the country, it can provide at least some kind of a health care to most of its population. Now, what is this mission? I mean, what does it contain? What are the elements of this? The things are very simple. And firstly, in this mission, every person, a user, will be provided a user ID, which is something like an Aadhaar card. Now, government will also make a repository in which the user can store all his medical documents, personal documents, and all the digital data in that. And he can access this data anywhere in the country. So he need not be stuck to one particular doctor and one particular, all his data will be available. Now, this government is also going to make a registry of all the healthcare facilities available in the hospital so that the patient can choose from. It has also got a built-in DigiDoctor in which any practitioner can register himself or herself in the thing and portal, and he will be provided with a digital signature so that he can write e-prescription. This health mission also includes, things like telemedicine and e-pharmacy, which are going to come. Many of you must be having your Arogya Setu apps with you in your phones. you please go and see this creation of Health ID. I think it has already been created under the name of ABHA, Ayushman Bharat Health Account, where just by entering your Aadhaar card, you can create a digital health account. So, but this program is not without certain, challenges. The main challenge is that creating such a huge digital infrastructure is going to cost a lot of money. And so far, the allocation made by the government is much short of what will be required for this scheme. Second thing are the statutory and the legal clearances, particularly the data protection, the data privacy, data encryption, and all those kinds of things which are yet to be sorted out. Then other shortcomings will be that the data, once it is available, it is possible that it may be used as a tool for surveillance, or it may be commercially exploited by somebody. Then also, many parts of our remote areas still do not have an internet connection. So how we are going to reach out to those people? And such an enormous task is not possible without the participation of the private healthcare. And most of these private healthcare, they work under the jurisdiction of the state governments. All said and done, this program is a very good program if it is implemented in the right earnest. When the Aadhaar was implemented, we had a lot of doubt about Aadhaar, but now you see Aadhaar has become a part of our life. When this Arogya Setu came, it came in a small way. Then the CoWIN came, the CoWIN got incorporated in Arogya Setu. Now this digital piece is also getting incorporated. So the government is trying its best to whatever it can. And I think private and the government will have to collaborate, and a lot of these hurdles have to be removed. Only then this program can be fully successful.
Thank you, Dr. Arup. We just have time for one last question. I know Dr. Sana came in nudging me to kind of complete the session. One last question to you, Dhruv, to end the session. From your viewpoint, I mean, you're not in the business of running hospitals. What are the changes you're seeing in the healthcare landscape, from a different perspective, and how are you planning to leverage that?
Sure. So one of the key things, Dr. Manish, is a lot of people who are staying and working in metro cities have moved back home. There's a lot of remote working happening right now, right? So a lot of population has moved from the metro or the mini metros towards tier 2, tier 3 cities. They want their healthcare delivered there. They don't want to travel back to metro cities to get their healthcare delivery. So we see a lot of shift in terms of hospitals moving, hospital chains growing and opening up in these tier 2, tier 3 towns. A lot of demand for super specialization also in these areas. So a couple of things, and I'll be really quick here. One is from our business operations. Because the healthcare delivery was towards metros, mini metros, we were also aligned towards these areas. Most of the companies now are looking at how to move into tier 2, tier 3 towns, how to resource these areas much more, how to build not only manpower there, but also supply networks there to ensure that all the medical technology reaches there. The second part, very quickly, is what Dr. Rekha also spoke about. Now, as the demand of super specialization in these cities increases and people want to use new technology, it's important for them to be trained on the usage of this new technology as well. So something that we worked on is, since they cannot come to our physical institutes, can we take our institutes there? So what we've introduced is an institute on wheels. It's a Volvo bus. Inside is pretty much an entire functioning training lab, which goes to these cities where surgeons can come practice on tissues, on models, on mannequins, all of that. We are leveraging technology, like ma'am mentioned, on VR. How can some of the initial training happen using VR, and how can we take just the VR setup to them rather than them having to come again to a physical infrastructure. And the last one which I'll speak about is, again, like ma'am mentioned, on a virtual platform. So if we have a J&J Institute online, where any surgeon can enroll, depending on where they are in their career journey, right from a resident all the way up to a super specialization. As they progress, there are different recommended courses, there are different videos, live chats with experts, all of that available. So essentially making newer technology and the learning available to the surgeons in tier 2, tier 3, as well as then providing the products and services to them. That's how we see the landscape moving, and we are aligning towards that.
Thank you, Dhruv. On that note, I would like to thank Radhika, General Arup, Dr. Rekha, Dhruv, and Dr. Ashish for a wonderful session, for your insights and sharing and contributing to the learnings at IPSC, and look forward to having you again at another session. And thank you to the audience for bearing with us and for patient listening. Hope there were some interesting learnings for all of you, and the guests are around for a while in case you have any follow-up questions. Thank you so much.
Thank you, Dr. Manish, and I want to thank the panelists. That was most riveting. The session, I think we've covered almost everything before and after COVID, and hopefully we will not see a pandemic again, but we sure seem to be well prepared in case there is one. Thank you so much.
We'll go to the next session on with the quality heads. So it's a quality heads roundtable, and we'll be discussing challenges that our quality heads face in designing the path of excellence for patient safety. From limited resources to lack of data to resistance of change, we know we all have faced these challenges at some point or the other in our organizations, and I hope this session gives us some collaborative solutions towards this end. So please join me in welcoming Dr. Lalu Joseph, who will be chairing this session, and our panel of speakers, Mr. Shravan Kumar from Zulekha Healthcare Group, Mr. Gaurav Loria, Chief Quality Officer and Head of Operations Apollo Hospitals Group, and Dr. Anna George, Head of Quality, Aster India, and Dr. Shweta. So Dr. Lalu Joseph is Quality Manager and Associate General Superintendent at CMC Vellore and Secretary General of CAHO. She is an experienced healthcare quality and patient safety professional with rich experience of implementation at the largest hospital in the country that has been accredited by NABH. She is the program director for many training programs in healthcare and is also a trainer. She is passionate about spreading the wave of quality, patient safety, and accreditation. While our speakers set up, there's a small announcement I need to make. Please, if you have not already filled in, please go to the website and fill in the Patient Safety Declaration 3.0. Thank you.
Good afternoon. Are you all awake? Yes. How many of you are quality managers here? Please raise your hands. Yes. And I'm very sure you're going to relate with all of us. Let's have some fun. So as quality managers, we are a new breed, isn't it? Just about 15 years old in this country. So it all started in 2006 when NABH came into existence, and suddenly this new breed of quality managers came into existence. Before that, did any hospital have a quality manager unless you were JCA accredited? Certainly no. So this new breed comes in, and the first opinion of the decision makers, the departmental leaders, is like a James Bond coming in, an investigating agency with probably a pistol to shoot everybody down. How many of you relate to that? Yes? All of us. True. We are never seen as facilitators. We are always seen as a police force. And in 2007, we knew nothing. It was just the standards in our hands, not knowing how to proceed, what to do, and the expectations were far too many. The salaries of quality managers or the appraisal of quality managers were dependent on the number of non-compliances our dear assessors would raise. How many of you relate to that? Is it so still now? Yes? Certainly. So the entire quality journey, rests on the on this poor, timid girl or boy who would have to carry this exercise through, present the organization to the assessors, get intimidated, not just by the assessors, but the hospital as well, all staff in the hospital, and after 5 days, now the journey starts with closure of non-compliances. After all that, you get the certification or accreditation, you hold it proudly, and after that, what do? You go back to sleep. Till the next assessment dates are announced, and then you wake up, get everybody together, create that momentum, and then you're shouted at by everybody. Lot of excellent experiences we all have, isn't it? Hasn't it been a brilliant journey for us? Yes. So this session is all about that. We are going to have a panel of very experienced quality managers talking about the challenges of all of us. They are representing us. So it's going to be a very interactive session. I'm going to ask questions to our panelists and also to all of you. So if you relate to the answers that they're going to be saying, please then come forward and give your experience as well. All right? Now I'm going to pose a question to all of you. What are the qualities of a quality manager? Can you name some? Leadership, brilliant. Unbiased, true. Good communicator. Team player. Catalyst. Everything. Should be knowing everything, brilliant. And? Patience, very good. Listener, excellent. Then? Negotiator. What else? Process breaker. Okay, I thought whether you were becoming part of the problem. Problem solver, problem creator. All right? Okay, anything else? Transparent, motivator, leader, everything. So we are talking about a Superman and a super lady. That is what is expected, isn't it? Perseverance, that's another thing we left out. Never give up. Smile and smile. I don't bleed at all. The last admission I had, the doctor had difficulty drawing blood. Because my skin has become very, very thick. Everything just flies over my head. It's all about smiling and walking around. Even if you're distressed, don't show that. Just smile and walk around. So to all my dear colleagues here, all of us have similar challenges. All right? So we are going to be discussing about that. So let me now request our dear panelists here to introduce themselves about their organization, their years of experience. And over to you, Gaurav. Let's start with you.
Good afternoon once again, all of you. I'm Gaurav Loria. I take care of quality operations and service excellence at Apollo Hospitals Group. I've been with quality for almost, I think, 17 years now. I take care of quality for hospitals as well as the Apollo Health and Lifestyle Division, which has cradle spectra, clinics, diagnostics, and others, specific focused formats for healthcare delivery.
Good afternoon, everybody. I'm Shravan Kumar. I'm with Zuleika Healthcare Group, working as Deputy Director Quality. I look after quality, risk management, and business excellence. I'm American Board Certified, Fellow of American College of Healthcare Executives, a Certified Professional in Healthcare Quality, and Healthcare Accreditation Certified Professional. I also work as Business Excellence Lead Team Leader Assessor for Dubai Quality Award, Mohammed bin Rashid Al Maktoum Award, and UAE Innovation Award. It's an honor and privilege to be here.
Good afternoon, everyone. I'm Dr. Anna George. Currently, I head the designation of Quality Head for Aster India. So we have about 15 hospitals in India under Aster DM Healthcare. Prior to this, I've been a purely quality person all throughout my career. About 15 years or more. Started my journey in 2008. where I was involved in the NABH first edition, and currently, as you know, even the latest edition of both JCI and NABH. I have been through the journey for both NABH accreditation as well as JCI. The beauty of the journey is that we have been through a lot, and fortunately or unfortunately, I've always been there when the organization wanted to do it the first time. And that says it all. So this blood drawing example that Dr. Lalu gave is so familiar. But as always, the learning that it has brought with it has been huge. And it's really a pleasure and privilege to be here amongst all of you.
Hello. I'm Dr. Shweta Prabhakar. I'm representing Fortis Healthcare, and I'm the Head Quality and Patient Safety and Academics at Fortis Hospital, Mohali. It's been 22 years in healthcare and over a decade in quality. So I have been seen the both side as a quality accreditation coordinator and as an assessor. So I have seen the both sides of the coin and experienced most of the time, being on the other side and experiencing how's the accreditation journey, taking everyone together. It's been a lifetime of experience which we go through as quality managers or accreditation coordinators. But here it would be it would be a pleasure to talking and sharing experiences and challenges and try to find a solution approach towards it, because there is always a light at the end of the tunnel. So we are here to find that light. Thank you.
Thank you. So we have excellent panelists today, and we are going to be very open and vocal. Shall we? Okay, so we are going to start with the first challenge that all of us face, leadership. Is that the major challenge, or anybody thinks it's not? Leadership in quality? Certainly that's the biggest challenge. So I want to start on a positive note. I had gone for an assessment of a very, very large hospital. And as usual, we have an interview with the top man, the responsibility of management. So I sat there, and this gentleman, a very senior person, opened his computer. I was waiting, didn't know how to disturb him or, excuse. So he put on his computer. He offered me a cup of coffee. I waited very patiently. He took a tissue paper, wiped the computer, and then he turned on his PA annunciator and made an announcement, because by then all the CCTV cameras popped up in his computer, and he made an announcement. Dr. Saab, outside OR8, can you please wash your hands? And that poor Dr. Saab, outside OR8, looked here and there frantically, went about washing his hands, and then he came out. So he showed his hands, towards the CCTV camera. I skipped a beat. I just couldn't imagine something like this happening in my organization. So I asked him, sir, isn't it intimidating? He said, madam, I hardly turn on my computer. I only switch on when it's dirty. And when I turn it on and I see this, my infection control nurses, poor girls, they come and complain to me. The hand hygiene complaints is very poor. So one day I made this announcement, and then 2 days later my girls say that it jumped from 70% to 90%. So I thought this is a beautiful solution. So why not do this? So everybody thinks I'm a big boss, but actually I'm not. I'm a very poor man. But when I turn on and I see this, I do this, and the compliance remains. Isn't he a great leader? Yes? Isn't he involved in quality, patient safety? I think he's got the pulse of the organization. So let's talk leadership. All right? So we are going to turn to Dr. Anna George, the most vocal person here, and let's ask her about the challenges in leadership with taking this journey of quality and patient safety to the next level. Anna, your experience from hospitals that you worked in, and also all the stories that we have heard about in all the hospitals. Over to you, Anna, for your thoughts.
Thanks, ma'am. So I'm not going to repeat the saga that we always talk about. As quality managers, we're all used to crying, koi meri nahi sunta. I'm always saying things. So let's look at it from another perspective. Who is a leader? A leader is one who knows the way, goes the way, and shows the way. Now, what's the way? That's the question. for a CEO or the so-called leadership we call the board, what is tangible finally? What is it that he finally needs to show, he or she? EBITDA, PAT, right? Profit margins. Now, do you understand where all that comes from? Now, that is tangible on an every day or an every month basis. What is quality and safety? It's a long-term goal. It doesn't happen overnight. I may not have things to show, except for all these indicators that we show, of course. But what is this monitoring important for? You realize the importance only when a sentinel event happens. So let me share an example with you, something that had happened in one of my previous organizations where I worked. So I used to put my foot down because I didn't find any logic in IPSG 1 unless you have two things to compare. Now, if I have to compare the patient identifiers, that is the full name and the UHID number, I need two things. There has to be a label somewhere, and there has to be a request form or something. So in OP patients, outpatients, there is no ID band because everybody uses it only in IP. So then the logic struck me that it doesn't make sense. You cannot implement it everywhere, be it your sample collection area or even your pharmacy where you're dispensing medications. So the explanation that was given to me in the boardroom, the boardroom is our home where we fight it out and, argue everything, was that we have the patient card that is given. Normally, nobody remembers to bring the card. So this is another flaw that we noticed. So I kept saying, look, it will not be a foolproof plan unless you do this. You give an ID band. So then the next thing, why do we have to waste so many ID bands? You can have another option, yes, but give me another option. Nobody was ready to go for it. Till that fateful day, when we had 2 medication errors, wrong dispensing of medications, to 2 patients who had similar names. Now, this came from a geographical area where the name and the surname, you had a lot of people with similar names and surnames. So even if you use the full name, it's the same name. We had 2 incidents like that, where the patient full name, because they couldn't compare, they had nothing else to compare with, and the wrong drug. And then I had to make that point, and within the same day, this was implemented. So we have to wait for something to happen, to show. That's where the leadership needs to change. We may not have immediate tangible things, but this is all about strategic thinking and putting goals across. Now, secondly, if you ask me, the leadership in today's hospitals is not one person. You have a group. My only request would be, please put in somebody. I'm not saying it has to be only a quality manager. That's just a designation. But somebody who understands the standards, understands patient safety, and who is passionate about patient safety into your strategic council, or whoever is involved in, making your decisions or making your processes and other protocols. That never happens. I haven't seen that happening. It's always, with all due respect, the CNOs, the medical heads, the COOs, they're all good people. But are they also involved in your quality, learning for quality? Today we have all of them being taught, or they're attending a lot of programs which talk about quality, patient safety, which is all very good. That means their knowledge level is also increasing. But when you have a person who's already trained in quality, another issue happening, maybe you take a junior most person because you only want the clerical work to be done, that is filling the application form, putting the data, making PPTs. That all needs to change, is what I feel. So if you bring them into strategic decision making, you empower them to talk out. First of all, to talk out. Say, reporting is good. You have sentinel events, good, because it's come out and now we know what to do better so that those things don't happen. Your culture of safety improves because somebody is able to be vocal about it and voice out without fear. So you need somebody like that in your strategic team who can challenge top heads reasonably, with reason and with facts. So that is what I would suggest.
Oh, that's brilliant. Can we do it? Are we ready? Are there leaders here? Yes, all of us are leaders, certainly. It's a major challenge that we face. There's a huge disconnect between what we want and what the leaders want us to do. It's a huge gap, and we have to bridge this gap. So can I invite some audience to give their opinion. Now it's time for you to be vocal. Anybody interested? Please, please come forward. Yes. Ma'am, you can use the mic. I think there are some yeah.
Good evening. I'm Dr. Reshma Sheikh. I'm coming from Breach Candy Hospital. I look after quality and patient safety. I'm their Chief Quality Patient Safety Officer. The question ma'am asked is, how will you bridge the gap? You think somebody from outside will come and do it for us? You think the leader of the hospital or CEO will suddenly start and become interested in safety and quality? No. The answer is with us. We have to make ourselves visible. We have to prove ourselves. Right credentials, perfect skills, presentation. Show them that this is what a patient safety officer, a quality officer can do it. We have to enter that boardroom. They will not invite. We have to go there. And that's what is. It's a huge challenge. It's a far-off journey, but it's good to begin. So,
perfect. Let's give her a good round of applause. She has the solution. So we have to empower ourselves and also use this opportunity to project ourselves, tell what is needed, make sure that we are aligning ourselves and they align to what our requirements are. It is not a journey that is going to be fought overnight. It's a decade of change. It takes about 10 years to bring that change in our organizations. And that was brilliant answer, madam. Great. So now let's move on to the very next challenge, quantity and quality. In India, it's all about quantity, isn't it? Huge numbers. Now, I come from an organization which is today with 4,000 beds. And we see about 12,000 outpatients in a day. And imagine talking quality and patient safety to our clinicians. With the numbers that they are seeing, probably each doctor sees about 150 to 200 outpatients in a day. So how do we manage this quality and quantity, managing both together? It's a huge challenge for us. So now, let us listen to Gaurav. He comes from a very prestigious organization that always has quantity and also quality. So let's listen to him. Gaurav, over to you.
Thank you. I think that's a very, very important perspective that we need to look at and understand. You know, so there have been instances when I have also been on JCI surveys, you know, in different countries, and I have seen, you know, suddenly if you see, so generally there's an application form and you see on that application form their general occupancies, let's say 80%, 70%, 300 beds occupied. And the day that you are there in the hospital for the survey, you just have 50 patients in the hospital. And every patient has a nurse standing there taking care of the patient. Every staff is washing their hands. So you look at it and you are like, wow, what a great service and a performance. But then that CEO is just sitting on a ticker and he's waiting when 3 of you or 4 of you just leave because his revenue is going down and he needs to get these patients in back to the, get those admitted in the hospital. So I think that one example broadly speaks about the quality and the quantity when we are not confident and sure of what we have and what we can deliver. I have personally seen this in many hospitals because, you know, you can just compare it with the data that you have presenting for the hospitals, and at least, you know, people who go to different hospitals who have at least little common sense, I wouldn't even say experience, they can at least make out what's the real scenario. So it's very important for us to understand that when we set our quality systems, we start building those systems so that they could work at a larger scale. They could work at a larger magnitude also, irrespective of the fact whether I have 10 patients to care for or I have 100 patients to care for. Your systems need to be implemented at all times, irrespective of the fact it is a Saturday or a Sunday. Now, I do also understand and agree with the fact that it is a challenge. It is not that easy. It may be very easy for me to sit here and give this profound statement, but it is a challenge. Sometimes it is a challenge in even the most developed, most organized institutions as well. And somewhere I will also link it back to the first piece of the discussion that we have on the leadership. So for example, you may have 10 hospitals in your kitty, and you realize that you at a central level, you have everything going perfect, but then one hospital, you get one unit head or one medical head or one nursing head who is definitely not on par or not on the same understanding as you are. And then by the time you get them into your fold, you would have lost so much of time and you would have got the quality and the whole thing down. But that will also happen when you have not implemented or sustained your systems. So I think sustenance remains the key. And, at least with all my teams, you will always, if you talk to them, they will always tell you that this is one word which I keep telling them: please sustain, please sustain. We don't have to do 200 things, but whatever the 5 things, 10 things we are doing, let's please stick to those things. Please make sure that they are implemented well. When you are checking those things, please make sure you are checking those specifics. Guide those people on the ground. So I think that's where it becomes very important, when people don't see this as a binding or as an extra work. When people understand that this needs to be done, irrespective of whether it is a quality versus quantity. If a nurse knows that I need to as well, very well check the medications before I give it to the patient, and how important that is, irrespective of the fact if the nurse is new, old, or stressed, or have multiple patients, she will do that. So I think it lot goes back again to our systems. How do we train? How do we monitor? How do we ensure that we are handling all these people down the line to get that culture in the organization, to make sure that it happens at all times. Plus have standardized systems across the organization. Now here, I'm not just, as an Apollo person, I'm not talking of one institution. I'm talking of, let's say, 72 hospitals, 100 clinics, 200 primary care centers. So it is challenging. But then again, it's important that you have strong focus, strategy, plan, a way, a mechanism to implement, monitor, and then take it forward. So that's where quality and quantity comes really into the picture, which we need to take care of.
I totally subscribe to that. It is all about standardization, systems, processes, foolproof systems and processes, and we can manage any number of patients. So it's all about that and well attributed. So let's ask the audience now. Any thoughts on quantity versus quality and your experiences? Anybody here? Do you see that as a challenge at all? To take your organization to the next level? Yes, please come forward.
A very good afternoon. I'm Dr. Veena from Apollo Hospitals, Navi Mumbai. I head the laboratory department, and I have to supervise people, almost like 50 to 60 of them. So as we all know that we have a lot of manpower crunch in corporate setup. So everybody is overburdened. So we have to get the work done somehow, or whatever the situation is. So all the staff will come and tell me that, madam, it cannot be done today, but then we have to deliver whatever the services are. So I feel that as leaders and as senior persons, in the system and the management, we should have some encouragement and some positive environment around, because everybody is overburdened with the work and work cannot be stopped. So we have to deliver the services on time. So is there any, I feel it every day, like one or the other person will come and tell me that, madam, I'm overburdened, or I'm having some personal stress, or whatever, So should we have some policies or some committees in the institutes where such kind of staff can come and openly talk about their challenges, maybe personal, maybe professional, or maybe some some kind of politics, So just to create a healthy work environment and just to improve the productivity of that staff or that person.
Certainly. That's a very good point. Stress and burnout, and with the quantity that we are dealing. And there has to be an open house policy for people to come. And we always say, leaders never close the doors. Keep it open for anybody to come in at any time, talk to you. You be an open door. You know, just listen to everybody. So that's one of the major attributes of leadership, to be open to suggestions and solutions.
Absolutely.
Yeah, please, go ahead.
I just wanted to comment on that. Actually, we have a good practice where I come from, where we have something called frontline obsession, where the frontline workers, which includes doctors, nurses, as well as the operations staff, they get to give a list of suggestions which are taken right at the chairman's level, and they are discussed openly in an open forum. And it's not just discussed, they have to be closed. So they have a set of questions or suggestions that come, and if you can't close it, the leaders have to give an explanation why it cannot be closed. Otherwise, it has to be closed with evidence. That is one. Second thing is, there is an independent team altogether looking into ethical matters as well as integrity, transparency, those kind of issues, which can be directly approached through a mail ID, which anonymity can be maintained, you don't have to reveal, and nobody else in the leadership would know who has raised it. But the issue will be resolved. So there are some measures probably that might help.
Excellent. I think the gentleman in the front, he has.
Thank you.
Yeah. Thank you, madam.
Thank you so much for giving me this opportunity talking with you guys. And myself Saurabh Chauhan, I'm coming from Quality Fraternity. My hospital is Savodhi Healthcare. Currently I joined there. So I just share a few experience of my for the JCI accreditations and NABH. So see, we always talk about the clinicians and the upper people in the hospital who are doing the great work. But my core area, focus area of the people who are continuously working in the backyards, they are the housekeeping and GDA peoples, because they play a very important role in the hospital, because if they are not working 15 minutes in the hospital is collapsed. So my focus area is there, how you train them, because they don't want to come in your department and they don't have too much time to give for the trainings. So I always sensitize to my team to go and sit with them, take a tea with them, and train in or her own language, because they don't understand your English. They don't understand your policies and protocols. They understand what they do only. So make a policy and make the process what they understand and then train them.
Perfect.
So I got, as Nalu ma'am, you suggested that 70% compliance or 90% compliance in hand hygiene. The people who are working 24/7 in the hospital, and they don't understand the 7-step or 5-step of hand hygiene. So I have to talk with their language के खाने से पहले, खाने के बाद, सोने से पहले, सोने के बाद आपको ये करना है. So that give the glitch, and we also get the 95% hand hygiene outcome in the hospital.
Wonderful. Thank you. Thank you so much. Let's give them a good round of applause, and a lot of wonderful solutions also coming forward. Just to break the ice. Hi, yes, please.
I'm Dr. Sandhya and I come from Singapore. And we must remember one more element that goes into play for quantity versus quality. That's the role of regulatory bodies. If I were to give you some example from Singapore Hospital, we are very much governed by the Ministry of Health. And that's when they are continuously monitoring the public sector hospitals, whereby we have to make sure that we have certain elements that are put in place, like lead time for appointments. How soon or how late can a person get an appointment for specialties? Certain specialties like cardiology, oncology, these should be seen within this much time at least, and they should be given priority over the other appointments. Other things that how soon or how late can you get an appointment for elective surgeries. Other thing is that there is also a requirement that your patient in the emergency department, whether it is staying in the observation ward for 4 hours, 8 hours, or 10 hours, they're continuously monitoring that. That gives a tremendous pressure on the hospitals, the doctors, and the workers in the hospital that they have to comply with this. So in order to meet those requirements or the quantity that they have to deal with, the productivity pressure that's put on them, sometimes it does happen that the quality may get a bit distorted, despite the fact that you may put in standardization, despite the fact you may have the highest possible technology in the world, but basically humans are fallible. So it does happen that productivity pressures can play a big role in getting the quality down sometimes.
Thank you so much, madam. Unfortunately, in our country, we all believe in quantity, and there's no regulator. That's the problem. So let's hope in the next 10, 15 years, again, it's a decade of change that we have to hope for. At the moment, it is all about quantity here. So just to move on to the next challenge, we have a huge problem with our training system. We have doctors, nurses, technologists who are coming in, learning anatomy, physiology, whatever, but no idea about patient safety. Only when they come into the hospital, it is like redoing everything, training them from scratch, whether it is the intern, the CRRI, the postgraduates, or the doctors, the junior doctors who come into our system, the nursing fraternity as well. So with that, it's a challenge for us, training and training and training everybody. So Dr. Shweta Prabhakar, what is your thought on that? And do you view that as a challenge, or is it something as a strength because you can train them new? What do you think?
That's a nice, hello? That's a nice one, Dr. Lalu, but I would like to take the audience poll. Do you think that this is a challenge? All the quality managers, do you think the clinicians, the residents, the nursing, you have to teach them from the scratch? That's a challenge? I can't hear you. I still can't hear you. I still can't hear you. More louder, dear. It is the biggest challenge. Because when we address why, the things becomes easier. Do you think so? Because when we implement standards, when we talk about patient safety, when we address that why, it's the life becomes easier. So we need to address why. And how are we going to do it? You know, when I'll just give an example in one of our monthly, you know, when we review our HAIs and the audits, when we do review our compliances. And one of the SSIs which we were reviewing, and we found that there was dressing compliance, you know, there was a non-compliance. Who was being brought down by the ICN was the DNB residents. And since I'm looking after the academics, so obviously all the fingers were pointing out me that, madam, please call your DNB residents and ask them about so I happen to have a tea with my residents. And this is an open house which I do it every month. And I just ask them, try to, the background, the medical schools, we don't teach quality. They don't know about patient safety. They don't know about bundle care. When I just started with asking, do you know about the hand hygiene steps? This was a young resident who was just walked in 2-3 months, and he was just asked to do the dressing by the clinician. Not being supervised, it's being well understood that dressing is the simplest thing which can be done. It's the 3rd day dressing, POD 3. But what is important is that we have to catch them young. And that is why the policy change has to come in. The curriculums has to be integrated with the quality and patient safety chapter. And it's very important you all sign a pledge that we take it forward to the policy makers, that they include this patient safety and quality one chapter in their curriculum in the medical schools. Because I believe nursing schools have still taken a lead. They have still included, they've started teaching patient safety and quality in their curriculum. Most of the nursing schools, the nursing personals, when they come in the nursing quality and patient safety, that's a way forward which you can take, and that's how we have taken, and trying to identify that should be effective. It should not be slides and you just talk at a very, 36,000 feet, this, which they don't understand. So you need to talk at a very basic level and make it very, very effective. So that's my, Dr. Lalu, I think so. It should be included, and there's a need of the hour.
Yeah. So the change is slowly happening. The National Medical Council has brought in a very small 8-hour session of patient safety into the curriculum. So let's hope that it will change very soon. I've had excellent experiences with training our postgraduates and interns. You know, the moment you start the postgraduate induction training, they all go off to sleep. Because to them, you start talking about biomedical waste and hand hygiene and bundle care and everything, they're not interested. So what then happens is we know that the postgraduates are joining. This month, the needle stick injuries are going to spike up. So we have a pattern when the CRRI joins and the postgraduate joins, everybody is careful. The medication errors will go up, the infection rates will go up. So we are living with it. Let's hope the curriculum has something fruitful over a period of time, not just an 8-hour curriculum for them to be trained. So that's an interesting thought, and I'm not going to open this for the audience for want of time. So let me move on to the next question to Shravan. So we never talked about quality. Probably in 2006, till our NABH came into the picture, I don't think any of us talked about quality or patient safety. Today, it's all over the place. Conferences everywhere and quality managers, and suddenly from nowhere, the microbiologists popped up. I think till then, they were all under the staircase managing their labs. Very, very small labs. And then you have this new breed of medical records department people. And then you suddenly saw all the fire safety department people running around. So this has created departments that were just lying like that, suddenly into prominence, many of them. It has done a lot of good things. So, I believe it has. But let's listen to Shravan and his thoughts on the challenges with accreditation bodies and the way forward. Do you think it's a challenge? Or accreditation, has it really benefited? What are your thought process on that? Has it really improved patient safety in the country?
Sure. I forgot to mention that I also represent Alexis Hospital in Nagpur. We are the first JC accredited hospital in the whole of Central India. Coming to the question, do you all think a good electronic medical records will help clinical documentation and clinical outcomes? Yes or no? Do you all think a good pharmacy management system helps in reducing medication errors? What do you do if your clinicians don't use it? So accreditation is similar to that. If you can bring in the best accreditation systems to your hospitals, but if you don't have the intent to actually improve the patient safety or quality, it wouldn't really help. Let me share my experience. I've worked with multiple accreditation systems, whether it is JCI, NABH, or you talk about Canadian accreditation or Australian accreditation. All the accreditation standards are developed in such a way that patient safety and continuous improvement are embedded into the standards. If you implement them, you will definitely improve the patient safety and quality improvement. Starting with international patient safety goals. One of the speakers talked about patient identification. Basic yet very powerful. We've implemented this, and I've hardly seen any patient identification errors, although there have been multiple near misses. Again, these are caught because we've implemented the system of patient identification at multiple levels. Talking about safe surgery, it has become part of the daily routine that we do. In the last 10 years, we haven't had a single wrong patient or wrong procedure surgery events, and that speaks volumes. Talking about fire safety, ma'am, we all run around, teaching people fire safety when the accreditation survey is going to happen or coming up. If you see in our hospitals, every person in the hospital would know at least where would be the manual call point is, how to break a glass and announce a fire, to recognize a fire and alert the system. So accreditation did help in many ways. But I've been on the other side as well. I've been fortunate enough to visit multiple hospitals, helping them prepare for the JCI or any other surveys. I've seen that leadership thinks that you can get accredited if you work for 3 good months. and it is true. So if you don't have the right intent to actually improve patient safety, none of these accreditation standards would work. So it is really important to recognize that standards are meant to improve patient safety, and the attention should not be on the accreditation, rather should be on patient safety. Then any system of accreditation, whether it is local or international accreditation, and I'm sure it's going to help improve patient safety.
Thank you so much. That's a wonderful answer. I think it is the intent, and it is the way in which you actually understand the essence of the objective element, the standard, and implement it with the right intent. So talking about intent, let me on a lighter note quote an incident that happened. Here I was for an assessment, entered into the operating room, and a cardiothoracic surgeon doing his procedure, and he was very, very skeptical about this whole accreditation exercise. I'm glad he didn't throw me out. So when I went in there and he said, what is this all about? 3 days mela and everybody comes in, checks everything. I don't think this is going to be useful at all. And I just didn't know what to answer anyway. I stood there, saw the room and interviewed the nurses as usual, poor nurses. They are the ones who are standing in front of you, so you interview them. And I just noticed one small band on top of the patient who was draped and, one small thing on top of the right eye. So I was puzzled. CABG going on, and why is this band there on the forehead of this patient? So I slowly went out and asked them, what is this band? They said, no, NABH wants it. So I said, NABH doesn't want something like that on top of the forehead of the patient. So I had to do a root cause now to try and understand what exactly is happening in this hospital. So I went around and I looked at the surgical safety checklist. Right eye marked and left eye marked and side marked, and oh my God, everything in that checklist. And then I realized the quality manager of this hospital moved from an ophthalmology setup into a cardiothoracic setup. And along with her, she brought this surgical safety checklist used in the ophthalmology setup. That's the problem, my dear friends. It's the intent. It is the understanding of what is needed. Patient safety is totally compromised, isn't it? So if you don't really understand, and that's why it's so important for us to understand why we are doing something and implement with the right intent. So the whole journey rests on all of us. Do you agree with it? Yes. So we are the champions, and it is for us to take this journey. If you feel accreditation has made a difference at all in patient safety, you all want to take your smartphones and do the poll with me? Shall we put up the questions? Meenakshi, if you can run the poll, please. I don't know where they are. Oh, yes, it's on. So I'm going to go through a platform called Kahoot. Most of you would know this. So you can either take on your app, Kahoot app, or type in Kahoot, Kahoot.it, Kahoot.it. And you have the game pin there. This is a very, very short poll, just 10 questions. No right or wrong answer. 704-7734 is the game pin. You type your name, please. Don't type your neighbor's name. Yes, Akash Sharma has joined in. Shweta, Vicky, Abhinav. We can have the music as well. Let's jingle a bit. Yes, I like this music. For those of you who are joining new, Kahoot.it, Kahoot.it. Put in your name and the game pin, and we'll be ready to start in maybe 20 seconds, 30 seconds. Yes, I think you're being very honest. 82 and 50. Let's go to the next question. Improvement in medical documentation is evidence, both clinical and nursing documentation. Okay? Be honest. That's good. 88 and 48. The next question. Management of facility, repairs, housekeeping, all of those are better after we embarked on this exercise. I would answer yes, but I'm not biasing you. What do you say, Gaurav?
No, I would also say yes, though I'm also not biasing any one of them.
Shravan? I would say yes. There, 99 and 35. Let's go to the next one. Compliance to infection control practices have increased. Let's ask Shweta.
Are you saying it is only for 3 days or wo 5 din?
Okay. And what about you, Anna?
No, but yes, I'm not biased.
I think yes, because we see now that it has infection rates and everything has reduced.
That's good. I think the audience have it. 116 and 21. We are talking infection control, isn't it? Great. Leadership involvement in quality and patient safety have improved. This is a great question. We talked about it. The leadership involvement in quality and patient safety. Don't let us down. We said it's a challenge. Wow. 140. All right, so 100 of you have said yes, they are involved in quality and safety. Quality of care and outcomes are measured and have shown improvement. Anna, what do you say?
I think...
Don't be very diplomatic, Anna.
With the good reporting that comes, some of the outcomes have actually fallen. But I think that gives us a good area for improvement.
Oh my God, she's being very diplomatic. What do you say, Shravan? Oh yeah, 113 and 21. Let's move on to the last question, the very important one, the one whom we are serving. Patient satisfaction has improved. Yes, no, Shweta?
Definitely, patient's expectation has been, that is being perceived by the hospital. So that's why.
But do patients really look out for that accreditation logo at all? Do you think the patients are looking for it?
Yes, they do.
Not exactly.
Not anymore,
exactly.
yes. So 111 and 27. That's a brilliant finding. So I think let's give ourselves a good round of applause to all you quality managers. This session is dedicated to you. Never give up, persevere, and we are all champions. We are in this journey together. We have excellent support system. Forums like this bring us together. So let us join this beautiful journey. It's a beautiful journey. Being a quality manager, a patient safety officer is a beautiful journey, and I'm sure all of you are enjoying it. Are you all enjoying it? Yes? Are you all cribbing, enjoying? Yes. Thank you so much for this brilliant opportunity. Best wishes to all of you. Bye-bye. Thank you.
Thank you so much. Such an interactive and interesting session. We'll give it 5 minutes. We'll wait for the delegates coming from other halls to join us. We have the valedictory session, and then we have the most interesting session coming up, the prize distribution and giving away. We had a lot of paper and poster presentations. We had a lot of free gifts for lucky winners. Everything is coming up. Let's give it 5 minutes for everyone else to join us in this hall. The 2 iPads from yesterday are still pending. If you are leaving and your name is announced, you're not winning your iPad nor any other gift, please. And please inform your colleagues and your friends, everyone, to head into Darbar Hall.
today. HCL Healthcare is championing preventive healthcare by working with some of India's largest companies to provide healthcare services and products to the thousands of people that use our offerings on an annual basis.
We believe that taking preventive healthcare decisions is the right way to being healthy, happy, and disease-free. Through preventive care, we enable diagnosing potential health problems before they become long-term health issues. We are in the noble profession of caring, making sure people experience relief, putting smiles back onto faces. Prevention is better than cure. Welcome to the HCL Healthcare family. You have been selected to be a part of a very special mission in preventive healthcare in India today. HCL Healthcare is another extraordinary vision of Shiv Nadar, the man who created one of India's first and now largest IT companies. The power of the global brand HCL transcends not just across India, but to over 45 countries that we operate in. His vision and life's work has always been transformative and life-changing for those that are a part of it. And it's a real privilege for us all to be carrying out his vision. It is through wonderful people like yourself that have joined our mission that we achieve the success we have today. HCL Healthcare is championing preventive healthcare by working with some of India's largest companies to provide healthcare services and products to thousands of people that use our offerings on an annual basis. We strongly believe in the values of integrity, urgency, innovation, compassion, and accountability. It is very important that we all believe the same things about the mission of the organization, to aptly serve the people and the communities we touch. We aim high and travel into uncharted territories to explore, innovate, and transform lives. We believe that each one of you will be a valuable contributor to help HCL Healthcare achieve its ambitious goals. We are privileged to be certified as a great place to work, which is only given to India's best organizations. Welcome once again to HCL Healthcare. Make your contribution.
Please join me in welcoming Mr. Gaurav Loria, Group Quality Head and Head of Operations for Apollo Hospitals Group, to thank you all for these wonderful 2 days.
I generally don't use a paper to read out the script during when I'm standing somewhere, but I just want to make sure that I have not missed out anybody's name, or at least I'll attempt to do that. So ladies and gentlemen, distinguished guest participants, it's my honor before you to stand here to deliver the 9th International Patient Safety Conference's valedictory speech, as well as, on behalf of THIT. First, I would like to extend my gratitude to the complete Apollo leadership, Dr. Pratap C. Reddy, Ms. Preeta, Ms. Sunita, Ms. Sangeeta, Dr. Anupam Sibal, Dr. Hari Prasad, as well as Mr. Shiv Kumar, for their unwavering support that they had provided for the last 9 years for having this conference. A special thanks to all the sponsors, to all the institutions, NABH, JCI, QCI, NBE, ISCUA, CAHO, PHFI, AHA, Astron, SEMI for partnering with us. A lot of gratitude to our knowledge and academic partners, Mr. Hari Prasad Reddy, Mr. Rajendra Reddy, Mr. Sridhar, and Mr. Sachin for getting everything together for us. A sincere gratitude to the organizing team for putting together such an insightful and impactful event. Thank you, Dr. Usha and the nursing team. Thank you to all the medical directors, unit heads, CEOs of Apollo Hospitals. A big thank you to the CEOs, functional heads, as well as heads of all the departments, especially of Indraprastha Apollo Hospitals, as well as Apollo Hospitals Noida. I'm grateful for the opportunity to be a part of this learned gathering and gain insights and perspective of some of the brightest minds in the global healthcare industry. The theme of this conference, Dream Design Dare, I strongly believe was a resounding success, and I believe we have made significant strides. in achieving our goal of evoking insightful and some interesting conversations on, what are the things that we are doing in different corners of the world, what can we learn from each other, and what can we take back to our institutions to implement them to make a bigger impact and move one more level up from where we are today. I would like to thank once again our keynote speakers, panelists, attendees, all of you, the national and the international delegates, who definitely made time from their busy schedules, especially on our busiest working days, Mondays and Tuesday, and making this conference truly collaborative and inclusive. Exchange of ideas, perspectives have been enlightening, and I'm sure it has been very helpful to each one of you. However, we'll also be looking forward to your feedback. You would have received a feedback link on your WhatsApp messages. Would request you to please give that feedback, whenever you get time today, because that will be really helpful for us to relook at other opportunities wherein we can make it better for you at the 10th International Patient Safety Conference. A big thank you to the quality operations, marketing, service teams of Apollo Hospitals for their immense hard work. Thank you, team. Without each one of you, all the ground team members, this wouldn't have been possible. As we conclude this conference, I urge each one of you to please continue this dialogue to work towards patient safety and towards a common goal of building a safer healthcare institute, organization, and a safer healthcare world for all our patients. With that, I would like to sign off for now, and we will directly head into the awards that have been lined up since yesterday. While before that, I would just like to request the media team there to please, show a very quick 1.5 minute AV that we could make, in this short time for each one of you.
Fantastic conference organized by Apollo.
One thing that's great about this conference is I was invited as a speaker, and I have to give credit to all the organizers for doing a very seamless process of registration as well as pickup for. I got a mail from the Apollo Hospital for this conference, and I found this mega event was very academically very fun, and I have learned a lot of many things. It is a very good experience, and we are really privileged that we had come here actually.
Thank you once again. Let's move to the awards and the prizes.
So we'll start with the papers and posters. We have 6 categories for the paper and poster competition. First one is digital innovations and design thinking in patient safety. Before going ahead with the awards, I would like to say that we received about 300 papers and posters from more than 100 organizations, and they were evaluated by our experts on the basis of 5 things: applicability and relevance to patient safety, innovativeness or novelty of the idea, presentation skill or the style and the content quality, tangibility or impact of the solution, sustainability and scalability. And for the final awards, papers first. For impact and sustenance of quality accreditation, the second runner-up is Dr. Raghu MN. Can I request Mr. Gaurav Loria to please present the gifts to them? The first runner-up, Dr. Ketki Prashant Manur. And the winner is Manisha Ratan. The next category is creating workforce-oriented ecosystem for their safety and well-being. So the second runner-up is Miss Anamika. The first runner-up is Miss Aditi Saxena. Now that's some enthusiasm, guys. Rest of you do not have any enthusiasm left. Come on, come on. Miss Anamika, the second runner-up. And Miss Aditi Saxena, the first runner-up. The winner is Dr. Vinay Pathak. The third category is excellence in patient experience. We have Dr. Prachi Tyagi as the second runner-up. Dr. Prachi Tyagi, do we have her here? Okay, we'll move on. The first runner-up is Dr. Manishika Patayat. For the winner for the category, we have a tie. It's between Captain Neelam Deshwal and Dr. Deepa Mehra. The fourth category is trends in effective communication. We have Miss Momita Saha as the second runner-up. Momita Saha. The first runner-up is Dr. Nipun Prinja. And the winner is Dr. Mohammad Ziauddin. The fifth category is leadership to imbibe and enhance culture in patient safety. We have Ms. Sohini Chatterjee as second runner-up. Ms. Eileen J as the first runner-up. And Dr. Pragya Sonkar as the winner. The final category in paper presentation is digital innovations and design thinking in patient safety. We have Vikas Upadhyay as the second runner-up. Vikas Upadhyay. Niharika Rawat as the first runner-up. And for the winner, we have a tie again. Dr. Libin Babu and Dr. Abhinav Verma. We'll move on to the category of posters. So for the first category on impact and sustenance of quality accreditation, we have Joy Casey as the first runner-up. Can we have Joy Kezia? So, and Anvesha Paul is the winner for the category. Anvesha Paul. The next category is creating workforce-oriented ecosystem for their safety and well-being. We have Ankur Rawat as the second runner-up. Pratibha Shimpi as the first runner-up. And Dr. Soumya Pranathi B as the winner. Dr. Soumya Pranathi B. I think we don't have Dr. Soumya. Oh, she's there. The next category is excellence in patient experience. The second runner-up is Lekha Bangar. The first runner-up is Suliva Jain. And the winner is Captain Dr. Usha Banerjee. For the next category of trends in effective communication, we have Shubham Mishra as the second runner-up. Shubham Mishra. Dr. Soumya Gopi as the first runner-up. And Garima Puri as the winner. On leadership to imbibe and enhance culture and patient safety, we have Aditi Saxena as the second runner-up. Dr. Jagruti Pashte as the first runner-up. And Mr. Sukhbir Singh as the winner. Mr. Sukhbir Singh. And we have the last category for the day, digital innovations and design thinking in patient safety. We have Amitesh Khare as the second runner-up. Amitesh Khare, please put your hands together. Ms. Pratibha Kashid is the first runner-up. And Dr. Agraja Patil is the winner. In case there are any mismatches in the certificate, please feel free to contact us here on the right-hand side of the stage. We'll get it all rectified. We have another 6 categories. We had a few fun activities throughout the 2 days, and we had promised you the iPad. It's still coming. So we'll first start with the high visibility quotient, where we had asked you if you were trending on social media with the hashtag IPSC, we would be giving 3 winners some surprise gift. So we have our 3 winners. It's Dr. Mahesh Devrani, Mr. Shivan Jha, and Mr. Vishnu Saxena. Okay, so we'll move on to the next category, and also as promised, since they are not here, I am going to take back the gifts. Thank you very much for the 3 gifts. So the next one is good idea or slogan on patient safety. So 2 best patient safety improvement ideas or slogans was to be rewarded with Kindles. We received 280 plus inputs. Kindles are in high demand here. So we have 2 best slogans. The second one is, don't be safety blinded, be safety minded, by Ms. Pratibha Kashid. She's on a winning spree today. Second, Kindle. And we have it's Kindle. iPad abhi aa raha hai. I'll keep it for the last. And I hope the iPad winners are not here. Huh? At least one of them. I want it. And the first one is, culture of safety should first enter our minds before it enters our hospital. This is by Eileen J. Then we had 5 lucky delegates who were to be chosen during the valedictory session to receive surprise gifts. Can I request my colleagues to reach out with a bowl, please? And can I have the lady in brown? She's been listening very patiently to us throughout the day to make the selections. The bowl. Please come on stage. She's been such a patient listener throughout all the sessions. We want you to select 5 lucky winners who will get a gift hamper.
Okay, the first name is Dr. Abhinav Verma. Okay. The next is Angela A. Kaushik. Okay. The next is Manoj Kumar. Is Manoj Kumar here? The fourth one is Shikha Pandey. Okay. That is Aisha Sharufu. I don't know the name actually. It's Aisha. Thank you.
Thank you. We didn't catch your name though. We didn't catch your name. Doctor?
This is Dr. Mantasha Siraj.
Thank you so much, Dr. Siraj.
Thank you,
very
thank
much.
you.
We'll move to the next category. It's best dressed male and female. So the best dressed male is Mr. Shravan Kumar from Zulekha Healthcare. And the best dressed female, I think this was tougher than the previous one, right? All of us look so beautiful all the time. But some of our gentlemen have decided that Miss Urvashi from Medanta was the most well-dressed lady throughout the event. Do we have her here? Okay, she's not here, so can I take that? The next one is lucky for the next IPSC. So whenever we are having our 10th IPSC, these 5 lucky delegates will get a free entry. We'll give you a letter this time. Again, so do we get a bowl? So can I have, who is interested to have the next lucky draw? Who wants to come on stage? Please come. Bowl.
Mr. Harmat, S. Harmat. Mr. S. Harmat. Dr. Rajshri. Dr. Rajshri. Dr. Swati Chaudhary. Dr. Swati Chaudhary. Dr. Pallavi Mehra. Dr. Pallavi Mehra. Dr. Jatin Jain. Eyes easier. Yeah, sure. Sain Gamak Salvi. Sain Gamalak Salvi. Dr. Alka Pal. Dr. Alka Pal.
Okay, let's ask how many of you had actually put your name here, whose name was not announced?
Mine.
Okay,
Dr. Vinay Pathak. Dr. Vinay Pathak. Let me try. Lily. Lily.
We'll get one for you. This is together. We'll get one. No issues. Thank you. Thank you so much. Thank you so much.
Thank you, sir, for coming on stage. Thank you very much. And now the most awaited one, the 2 iPads. So we had said, everyone, that if you're an all-rounder, you visit all our stalls, scan the QR codes, and then if you have the maximum number of stall visits, we'll be giving the top 2 people 2 iPads. Now the iPads are sponsored by Pozzo. And can I have the project manager for Pozzo, Mr. M.G. Anand, on stage to give away this gift, please? So we'll be taking that from a lucky draw from the red box. Because we had a lot of people scanning this, so we'll take out 2 lucky people from the red box there, and they'll get 2 iPads.
The winner is Libin from PSRI Hospital. Libin?
He's here.
Yeah.
He's on a winning spree too, right?
The second winner is Deepak Sharma from Chitkara University. Sorry, it is Dipali Sharma. Dipali Sharma.
Chitkara guys, are you there?
Chitkara University, guys.
Bad luck.
Bad luck. Next one is Isha from Chitkara University. Another bad luck. I hope this person is here. It's Dr. Uma Rani from Amity University.
Thank you, Mr. Anand. So that's that. I was also rooting for you ladies there, the really enthusiastic group sitting there in the middle. You guys who wanted the iPad. You. I was also rooting for you, but bad luck. Better luck next time in the 10th IPSC. So you guys have been a fantastic audience. Thank you so much. And really looking forward to seeing you guys in the next IPSC 2024. Don't forget to join us for refreshments before you leave. It's the tea and coffee is available in Raja Bagh, Rani Bagh. Please do check it out.
Just one more miss that we did. Your certificates are already pushed on your applications. So if you just go on your app, the IHD app, you can see your certificate of participation on your app. You can download and take a print if you wish to do that. Tea coffee is available, so please have tea, coffee and go. And see you soon at the 10th IPSC. Thank you so much, all of you. Bye-bye. Organizing team, IPSC organizing team, can you please come on the stage? IPSC organizing team, can you please come on the stage for a photograph?